this is look into the hyperopic result. Sorry. So basically, uncorrected visual acuity after laser procedure, really almost every patient achieved driving standard, although it's not as good as the myopia, but still very good result, unaided. The predictability also almost 100% of the patient achieving within 1 diopter of the predicted value, and there's no big scatter, so what attempted is very close to achievement. But usually hyperopia usually tends to overcorrect initially for the first week and two, and then settle down within 3 months. How to optimize the laser visual correction to achieve the best result for hyperopic correction? Really, it's very important to select the right patient, and that's with creating a happy patient. Post-operative care, as we mentioned earlier, always try to avoid it to make it too steep. Always better to treat low hyperopia, below 4, avoid dry eye patient. Always you need to do mandatory do the cycloplegic refraction, and should be really the cycloplegic refraction should be less than 0.75 diopter from the manifest. Otherwise you have to wait. You cannot do, if you corrected early, you're happy initially, but then you're not happy patient. So always do cycloplegic refraction. Better use the femto and always use the large optic zone. Why prefer the laser visual correction? For laser vision correction, this is it's have excellent visual result, effective, safe, predictable. It's easy to enhance, and that can tune it, because the enhancement rate is much more in hyperopia than myopia, but it's easy to enhance, and you reserve the normal accommodation. Corneal lay is not anymore available, and because the problem is every time there's different new corneal lay, and they ended with bad result and haze, so nowadays there's no one using metallic or artificial corneal lay, although there's a potential for corneal tissue, maybe as a lay. Phakic implant is very good option for hyperopia, above 5, but the problem is most of this patient, they have shallow anterior chamber, so it's very few patients may suit phakic implant. Refractive lens exchange, I think I leave it up for patients above 50. It's more risk. We lose accommodation, reduce the quality of vision, and also creating some night vision problems. So for young patient, I don't recommend the multifocal implant. Any patient up below 40, laser vision correction is the best option. That will lead you happy yourself and happy vision. And thank you very much. So you have 3 minutes, okay?
Thank you very much, Osama. I agree with almost what you said, but I think there is one thing that I strongly disagree. Which examiner laser platform you have?
Throughout the years, I have this one study, that's physics. Now use an Alcon algorithm, okay? I use this technology. I have all the platforms, so that's why even this wavefront talk, really wavefront talks is very biased, depends on what machine you're using. So because every machine have positive point and negative point, so you cannot fit them all the same.
So one question for the audience. How many of you do hyperopia laser vision correction with LASIK over 4 diopters? But you said up to 4.
No, I do, but it's selective age. This is general rule, okay? But even last month meeting, in the big symposium, people agree that you don't touch after 3. So it's very debatable where you want, but as a general rule, below 4 is good. After 4, you need to consider too many factors: your laser, centration, the optic zone, so all, and age of the patient, so all different factors. But this talking about general rule, that's what that means. It's don't correct too high, because the result is not predictable.
How many of you perform refractive lens exchange in patients under 45, hyperopic patients less than 45 years old? Okay, the thing is that right now, there was a paper 2 years ago doing refractive lensectomies in patients younger than 4 years. So really, and there is a general concept that is repeated every time in meetings: do not do hyperopic LASIK over 4. Well, that statement will depend on the laser platform you have, because with MRIs, you can do up to 6.5. It's scientifically, it's evidence-based medicine. We have a paper, and there are many papers demonstrating safety, efficacy of LASIK in hyperopia up to 6.5 with perfect outcomes. The thing is that this statement that many surgeons think that hyperopia LASIK over 4 is just forbidden. It's like, no. So it forces them to do refractive laser exchange in 38 years patients with +5. Really, this is something that the truth should be said. And this statement of do not LASIK over 4 should be really broken, because that will, of course, depend on the laser platform you have. As Dr. Osama said, check out your platform, but many laser platforms, modern ones, you can do up to +6 easily, and then avoid the refractive lens exchange until older ages. Please do not do refractive lens exchange in young, non-presbyo patients. Really, we don't know how these lenses are going to perform 40 years later. Because if we do it in a 25-year-old patient, the lens is going to be 50 or even 60 years inside the eye. We don't know what is going to be the safety of that.
Dr. Osama, thank you for nice presentation. But doing hyperopic LASIK with physics platform, you don't think it takes very long time? It is very long time, and mostly the patient lose concentration. If you do +5, say, custom wavefront customized, it takes about 180 seconds or 200 seconds. It's very time consuming, and patient mostly not happy after hypermetropic LASIK with physics by name.
I haven't used physics for almost 12 years, by the way. But as I mentioned, every machine is different. But the way, if you're using physics, particular, you need to use a wavefront system, okay, not the standard one. That's why I recommend. Don't use the standard one, but every platform is different. That's what I'm telling you. You need to understand your machine and the limitation and the barrier. That's why you cannot fit all the same number the same way. That's why I said +4. I do even 5 and 6 occasionally, but a less selective patient, not as. But physics, yeah, very slow for hyperopia is not good. But controversial to that, the wavefront myope is very good. And even for primary eye. So that's why I said this is, you need to understand, this is the different separate talk completely together, by the way.
Okay, thank you.
What is the minimum pachymetry at which you would do a hypermetropic correction?
Sorry?
What is the minimum pachymetry you would take to do a hypermetropic correction?
That's also another thing, okay? The guideline is 500. I do a lot 480, a lot with film to laser 480, you can do it, okay? If it's normal healthy cornea. So there's a medical legal aspect impact in that way. So the statement now general rule of 500, but you could do it 480 for hyperopia, even lesser. Okay, but that's also debatable about different factors around you, not you're alone. So
Thank you. Okay, thank you very much. Thank you very much.
Thank you very much.
Nice talk. So we invite Dr. Sami Al-Rabia. He's going to talk about my best technique for myopes over 40.
Osama is lucky to do for hyperopes because hyperopes, whatever you correct, they'll be happy. They don't see distant, they don't see near, but the myope is seeing near. So problem if you just treat distance without near. Anyway. When I was requested to talk about myopia over 40, this is really wide object because you have to look at many different things. Is it low to moderate or high? And if it is low to moderate, you have to look at maybe you do on the corneal way, or if it is high, you have to look at the AC depth, white to white, because you may consider either phakic IOL or maybe phakic presbyopic IOL also. And if these are unstable, then you have to go back to that trifocal, multifocal, or extended depth IOLs. So degree myopia is very important. Now, all the other subjects of lenses and were discussed before. I'm going to talk about laser treatment for these cases. We know monofocal or monocular use of LASIK, so you do one eye and leave the other eye for reading. And really it takes a long time to adopt, and it's not a very good idea. That's why they developed the LASIK. And this LASIK has been discussed a few days ago, that it is technique to change the multifocality of the cornea in order to have distance and near. And these patients should have clear lens, their vision should be satisfactory. You know, all these things, we are not going to waste time about it. And then we have either central LASIK or peripheral LASIK, whether the near part, central part for near or the peripheral part for near. Or we have the laser blended vision. Laser blended vision is a technique that you modify it, you just work on the spherical ablation and the custom Q. Or you may have the manual customized. Now, If you look carefully, he was asking, what is the platform? What's your machine? He was asking, what's your machine? Everybody's asking. So you have to have a certain machine to do your job. Maybe you don't have this machine and you have a patient who wants to do it. So what are you going to do if you don't have a machine that can do central presbyLASIK or peripheral presbyLASIK or laser blended vision? You have just an ordinary machine and you have to go for the manual customized. And if you look carefully here, this is just to make you clear. The first one is the normal one, and this is the spherical aberration. You look at the light at the distance. If the eye is completely rounded, so the light will be forward, backward. This is a high positive spherical aberration. But our eye is not that rounded. It is, we know it is curved. It is flatter at periphery. This pushes lower, so it is a positive spherical aberration, but good one. Why it is not on the retina down? Because you have a lens. The lens with the cornea will push it. So this is a normal person in the center. Now, if you, the second one, in case of you do post-myopic laser, you change it from the second diagram to the fourth diagram, so it goes back again and the increase in the spherical aberration, positive spherical aberration. While if you do hyperopic correction, you increase it, so you go it down, and it is less or low positive spherical aberration. Now, why I said that? Because this is just an ordinary case. I use NIDIC, by the way, and then I can go up to 10 microns, 10 millimeters. So it's up to me. It's opened. And now you can see here. This is the right eye of this patient. I need you to look at the Q value down here. This is the pre-op. This is the post-op. It was minus 15, very close to the zero. And if you look at the other one, it is plus 0.12, again, very close to each other. So this eye, I gave the patient an excellent vision. He was -4, I corrected -4. I gave him 5 and 9, optic zone and transition zone, and I get exactly very good Q value. This is the good eye. What about the right eye? What about the other eye? Now, again, if you look carefully here, look at number 12, the spherical aberration. It is 0.22, and then it is 0.13. There is really no change. So this eye has sharp, good vision. The more, less spherical aberration, the sharpness your vision. Okay? The less spherical aberration, the less quality of vision, but the more depth of focus. But you have to know that whether it is plus or minus, you should not go to the toxic level. So there is something called toxic level of hyperopia, of spherical aberration. As long as you are in the non-toxic part of the spherical aberration, you are safe and you give your patient good reading. This is still the good eye. We said we give 5 to 9 treatment and -4, and nothing has changed. Every reading is okay. And then again, as our friend Dr. Khalid mentioned, this is how to look into the Zernicke. I'm not going to mention, but mainly the spherical aberration in the center. And in my machine, I can control it. I can ask the machine only to correct the spherical aberration if I want. So I can induce spherical aberration. Now, this is the second eye. This is the left eye. Again, I did not correct 4. The patient was 4. I corrected 3.5. So by intention, I left 0.5 myopia, okay? And this, the treatment zone is 4.5 and 8.5. I made it smaller. Now, this by itself, just by itself, without anything else, look at the Q value from minus 0.29, jump to minus 0.5. So I increased the depth double just by changing the Q value. Again, now look at the spherical aberration number 12. It was here 002 and then becoming 0272. So it is really much more changing by just changing the treatment zone in 1-1. In right eye, I made it big and smooth, so there is no really change. And the other one, by intention, I made it small. By intention, I want to induce spherical aberration. This is if your machine has this. But Dr. Sami, we don't have that in our machine. What to do? Now, this is again the spherical aberration, total spherical aberration, 0.08, and then becoming 0.25. This is the same patient. Manual. These are I started this manual maybe 1.5 years ago. Now I have about 28, 29 patients with this manual. What is the manual? Now, suppose this patient, and he is myopic, and I gave him first, so it is multi-stage. I do multi-stage. I give him first minus 3.8. So if I give him minus 3.8, I look at the correction. I end up with 0.2. So it's really almost very well corrected. Now, if you look carefully down here, the objective refraction is 4.2, but I corrected 3.8, so slightly less. And then I add hyperopic correction. On top of my myopic correction, I add hyperopic correction. And the addition of hyperopic correction is different this time because really, again, I have to go down, small. So my hyperopes usually 4 to 10. Now here, 6 to 10. And here, 5 to 8. I make my hyperopic, so I induce more spherical aberration. Now look at the spherical aberration. It was 0.08 before. It became 0.9. So it is 10 times increase. And if you look carefully here to the spherical aberration down, it was 1.4 and it become 2, no, I'm sorry, it was 0.08, it become to 271, spherical aberration down. So really I induce a lot of spherical aberration just by treatment the myopia as big as I can and the hyperopia as small as I can. And this by itself gives me a good one. This is the last patient. I saw him yesterday, 2 days ago. He's a dentist. If you look at the right eye spherical aberration becomes minus 0.35 down here, and the left eye minus 1.25. He's a dentist. He can maintain his work. Now, this is not just myopia. This is some sort of myopia with large focal depth, like the extended, exactly like the extended depth technique, but this is manual. So you did residual myopia, but usually they leave 1.25. If I am sick, I'm 71 now. And if I'm minus 0.5, it makes no difference to me. But if minus 0.5 with extended depth, I'll be happy to read. I can read. So really, it is mono. It is so small, some sort of monovision, so small difference that the patient won't feel, but it is large extension of depth. And that's it. Oh, this is the vision, I'm sorry. Both eyes open together. Look at the uncorrected near vision, and then look at after. So the uncorrected vision improved beautifully, and this is my fish. Thank you.
Thank you very much, Dr. Arabia. Do any of the panel wants to make a comment, or we shall carry on?
Thank you, Dr. Sami. As we know, one of the important causes for post-op undercorrection due to undercorrection with glare and halos for the patient is the cyclotorsion and decentration. So, if you have myopia with high astigmatism, what do you prefer to do for the patient, LASIK or SMILE?
The beauty, no, what did you say? Smile?
Smile, LASIK or SMILE?
No, I don't do smiles. I don't do smile. You said smile?
Yeah.
No, I don't do smile. Smile, there's no way to put hyperopic correction here.
No. I mean myopia with myopic astigmatism.
Yes.
Yeah. What do you prefer to do for the patient?
I do femtosecond LASIK.
Femtosecond.
Yes. And my machine can correct up to 7 degrees of myopia, of astigmatism. No problem. By cross cylinder.
Thank you.
Well, thank you. There is a question, but
Also with some of the newer machines that have come like the Contura, they take less time to chew less tissue. That also makes a difference in the post-LASIK
Of
period.
course, this is if you have the machine. I'm saying if you don't have the machine. They have Rolls-Royce and so on. I have a small Fiat, but I need to do the work with this small Fiat. That's why I'm saying just regular, do big myopia and small hyperopia, and the 0.5 difference, but with a good depth.
I think
Dr. Sami,
we should probably close it here because otherwise Dr. Ashraf is going to kill me. So later we can discuss it, but we are going to carry on with Dr. Khalid Al-Faht talking about astigmatism. Sorry about the question. It's because I have pressure from outside to go to the live session. So
thank you so much, Chairman and panelists, for moderating this really interesting session. This session is all about the challenging cases. Here we have another challenge that face many of the refractive surgeons, as Dr. Sami just a while mentioned, that we, in order like leaving or inducing some spherical aberrations of the myopic corrections that might help some of our patients to enhance their reading abilities. But I mean, the question is for how long this will last. We know the regression is a really challenge for many of the corneal refractive surgeries, like even Dr. Osama mentioned the hyperopic treatments and myopic treatments, and as well as the astigmatic correction. I'll try my best in this coming 10 minutes to, mention some pitfalls and very important tips about treating and taking care of the astigmatism or astigmatic corrections. How can we move it? I'm sorry. We know that the astigmatic prevalence is really very huge, and we know the astigmatism is the most common refractive error among all of the corneal refractive surgeons. Knows that, and in the meta-analysis, the astigmatism greater than 0.5 diopter in the world is estimated to be 40%. So this makes it very popular and very prevalent. Sorry.
If we don't carry on, we're going to...
Yeah. Specifically for these patients undergoing cataract surgery, and systematic review, they found pre-existing astigmatism greater than 1 diopter is almost 47% of the eyes. And we know there is regular and astigmatism with roll, against the roll, and oblique astigmatism. And that's what we are taking care. We are not taking care of the irregular astigmatism. All of the irregular astigmatism is pathological, including the corneal degeneration, corneal scarring, pterygium, keratoconus, ocular surface diseases, and corneal surgeries. Here is one of the cases of subclinical keratoconus having high steepening, and we have some Warburg syndrome and contact lenses. We should take care of these cases before we decide whether to go with the corneal refractive surgery. So what's wrong with the astigmatic treatments? We have the decentration, as mentioned with the previous speakers, and in that we should take care of the offset value. We have difficulties in determining the amount of the axis and the axis of the astigmatism, and we have higher rate of retreatment and enhancement. And many times of even post corneal refractive surgery astigmatism, we have also residual refractive error, and we have some of the hidden, what we call hidden irregular astigmatism. So cyclotorsion can lead to a decrease of the amount of the astigmatism reduction. We know almost 10 degrees can be there when the patient is really supine. So the cyclotorsion correction is really mandatory in all of the treatment of the astigmatism. And the ablation profile, usually there is a hyperopic shift because of the coupling effect. We call it coupling effect. Every one almost diopter of the cylinder is corrected, there is also 0.25 diopter of myopia also treated. So you have to take care of the coupling effect and the ablation profiles you have and you are using. Ablation time here in the astigmatism correction, and we all know, is longer than the myopic treatment, so it is more sensitive to the patient eye movement, and you need really an accurate and fast eye tracker to take care of the astigmatic correction. There is a tendency, a greater tendency of regression, both hyperopia treatments as well as the astigmatism, and this could be explained because of the post-operative mechanical instability and corneal tissue biomechanics and irregular epithelial remodeling over the ablation zone. That's why we are seeing more regression in the post-stigmatic treatment as well as the hyperopia, and we are not seeing very much in the myopic treatments. Here is a study showing the 2 years results of femtosecond assisted LASIK versus the PRK, and clearly we know the results of the femtosecond laser is really superior to the PRK treatment results. This is the conclusion of that study. At 2 years, the prevalence of residual astigmatism greater than 0.5 was really significant in the PRK group versus the femtosecond, and the percentage of the cases of residual astigmatism greater than 1 diopter is really significant in the higher in the PRK group. Another study, I think I wouldn't have time to all go to all of these results, studies, but we all agree that the femtosecond is really superior to the PRK. And we know that the PRK is associated with the higher chance of regression as well as scarring and subepithelial hazes in these cases, especially for the astigmatic correction versus the myopic treatment. There is a corneal breakthrough haze after post PRK even with the mitomycin, and the conclusion of this study shows the hyperopic and large myopic or astigmatic correction carries higher risk of haze post PRK. And this is the PRK, shows very clearly the regression scarring, and this gives the chance for the refractive error to change and to even induce sometime irregular astigmatism. I might not go through these. I mean, one of the chances to help the patients with the pre-op astigmatism is doing toric trifocal lenses or toric lenses, as well as toric phakic lenses, toric ICL and others. As a very important step just to do the pre-op marking. And here is one of the cases. Why I'm just mentioning these cases, because sometimes even when the patients are really good candidates for toric lenses rather than doing corneal refractive surgeries. Here is very important fact about the cornea. What happens to the cornea with time? Cornea really tends to drift from with-rule astigmatism to against the rule astigmatism with time. The amount of against the rule astigmatism change per decade is almost 1/3 of a diopter. Like if we are almost 40 and we are reaching about 70, in Dr. Sami age, we are having almost 1 diopter of against the rule astigmatism induction in these corneas. This is a general, change on the corneal biomechanics, and that's why the older patients are having against the rule astigmatism. So the against the rule astigmatism will go more and more with time, but with rule astigmatism will decrease with time with that formula of having 1/3 of diopter per decade. Every 10 years we are having 1/3. So we have just to think about it when we are treating older patients and even the younger patients. So one of the recommendations is just to leave up to 0.5 diopter of with-rule astigmatism, especially for the younger patient less than 50. That might even as idea of inducing spherical aberration mentioned by Dr. Sami, even leaving 0.5 diopter can even enhance the depth of focus and help these patients to read or the reading ability for them. So in the recommendation, just think about the flipping of the axis. This can lead to a residual astigmatism on the opposite meridian of the original axis, but in the same time, this will help the depth of focus, as I mentioned, and the benefit of flipping axis, as just I mentioned, that they more be likely to have independence of the spectacles and can do a lot of reading ability without use of the glasses. Okay, so as a conclusion, yes, astigmatic correction is really challenging for all of the refractive surgeons, but we can win when we are taking care of these important tips I just mentioned. We really, in 2023 now, we are having more advanced and new excimer ablation profiles, and we are having also cyclotorsion correction options that help to correct accurately the astigmatism. When you are in face of, facing challenging cases that will not really good candidates for corneal refractive surgery, think about phakic lenses, or even in the older patients, think about the toric lenses, like in the toric trifocal lenses, or even toric monofocal lenses. Whenever you are even having some residual astigmatism, you can do a two-stage LASIK as usual, and you can do the either PRK or femtosecond laser post phakic lenses, or even post cataract surgery with toric lenses. I hope I mentioned most of the things related to this really challenging fact, and still we are learning. Even 6 or 7 years ago, I regret to do a lot of high astigmatism refractive errors, but nowadays we are learning, and we know that we can win and we can succeed to help many of the astigmatic refractive patients.
Thank you
so much.
Thank you. We're going to move directly for the last speaker, Dr. Ashraf Armia. He's going to talk about phakic lenses in low and moderate myopia. And after that, this talk, please stay, because we have now the Alcon and Amico Symposium, followed by the amazing live surgery session. So please don't leave and remain.
Thank you, George. Thanks for everyone. So I'm not going to make it delay because we have a lot of full program. So the talk is game changer phakic IOL in low to moderate myopia. Okay. So I have no financial disclosure regarding this presentation, but these are my disclosures to companies that I'm consultant and speaker to. So when we look to these pentacams, I'm not happy. I'm not going to operate on the cornea for these cases for treat myopia. They are, for me, are risky cases. So when you have a thin, risky cornea situation, you should choose the safest refractive corneal procedure, which is a phakic IOL, if it fits the procedure. So what is risky corneas? In my opinion, in my practice, so thin cornea less than 480 microns, corneas with post-corneal viral infections, corneas with abnormal anterior surface with abnormalities in the epithelial mapping, and red lines, stable keratoconus after cross-linking, for me, post-ICR for keratoconus, and post-PKP for keratoconus. Some surgeons do refractive surgery for these cases, but I don't do. So phakic IOLs provide several advantages in visual performance compared to the LASIK, including less induction of high-order aberration, as we are going to see in the slides, higher contrast sensitivity, and higher retinal image magnification. And until now, there have been only few published studies on ICL implantation for low to moderate myopia. High myopia, a lot of studies, but low to moderate myopia, few studies. Phakic IOL implantation induced significantly few ocular high order aberration than did the wavefront guided LASIK, even in low to moderate myopic eyes. Although phakic IOL implantation significantly increases the contrast sensitivity, whereas the wavefront guided LASIK does not. So this is presumably because of the laser ablation associated with the LASIK creates more oblate cornea, which results in more significantly induced higher order aberration, and because the retinal magnification after the ICL or the phakic IOL implantation is reduced to a lesser extent than after LASIK. When we look to the safety, this very nice study reported that previous studies in the new design of the phakic IOL implantation for 1,200 or 300 cases followed for 5 years describe a 0 incidence of asymptomatic anterior subcapsular cataract formation. But we need more prolonged careful follow-up. And when we look to this study that was published in 2017, it was a multi-center study. It's a very nice study. Comparisons support the view that the ICL performed equally well in correction of low to moderate myopia as it did in high myopia. And also this study said that the ICL implantation for low to moderate myopia up to 10 diopter in patient aged 40 years was accurate, effective, and safe. When we look for this graph, you can see how the refractive accuracy compared with the phakic IOLs and how the patient is stable for a 20/20 vision up to 58% of the cases. And also how the ICL is stable for patient corrected with the phakic IOLs. And if we look to the luminance for the patient for visual acuity, so they said that the low luminance visual acuity and the low luminance contrast sensitivity significantly improved following the ICL implantation, and the improvement were significantly better than those observed after wave-optimized LASIK. They did a study without the low luminance goggles, and it was significantly saying that the ICL is more performing than the LASIK performance. So when deciding which refractive procedure can be offered to a given patient, surgeon must evaluate the number of factors, including the refraction, the anatomy, the other ocular conditions and diseases, surgical recovery time, cost, safety, efficacy, and the patient's lifestyle. And very important to say that excellent vision in a range of light conditioning is highly desirable. This is particularly true in military combat, especially in the United States. So night vision also reported that following the phakic IOL implantation has been promising. In the FDA clinical trials, the incidence of night vision problems such as the halos, glare, night driving difficulties decreases or remain unchanged for 3 years. And moreover, ICL implantation didn't result in any reported loss of contrast sensitivity. If we are going to compare between the phakic IOL, the LASIK, and the PRK, we can see that the phakic IOL, it's reversible. So if you have a post-refractive error, you can remove the lens and change the power. The LASIK, you can augment, yes, but the PRK is not. So the most important that it blocks for the phakic IOL, it blocks 100% the UV light. What about the toric ICL in low myopia? It's promising, and this study reported, it was in 2010. Yes, it was an old study, but it reported that the analysis of these patients showed that the patients can achieve predictable post-operative refractive results with toric ICL in a stable way. And this study showed that with the post-operative result, uncorrected visual acuity with the ICL giving more stability than the refractive surgery, than without. What about high order abrasion? They did a lot of studies, but this study was recent, 2020, and they measured the high order abrasion post-phakic refractive surgery compared to the LASIK with topo-guided LASIK. And they said that the total high order abrasion increased compared to the pre-operative data in both the wavefront guided and the topo-guided laser. And also this study showed that the ICL and the topo-guided and the toric ICL performed well in correction of high astigmatism without significant change in the high order abrasion during the 6 months observation period. And this is very also a new study in 2018. For the time, contrast sensitivity also, they measure in 2020, they measured the contrast sensitivity in patients with a phakic IOL, and this study showed that the contrast sensitivity does not clinical changes in both LASIK and the ICL. What about the biomechanical changes? Definitely, we are going not to touch the cornea, so we are not going to change the biomechanical in cases of phakic IOL, but we are going to change it if you do a refractive corneal surgery. And the most important, the accuracy of the IOP. We all know that measuring the IOP post-corneal refractive surgery, we need an equation. It is not the actual. So if you have a risky patient with suspect of glaucoma, don't touch the cornea and leave the cornea as it is with no change and go for a phakic IOL if it's okay. So my home take message. Most of the multi-center comparative studies support that the view that the ICL performed equally well in the correction of low to moderate myopia as it did in high myopia during the first year observation period. ICL implantation for low to moderate myopia is clinically, if not statistically equivalent to the result of high myopia in terms of safety, efficacy, predictability, and stability. ICL implantation is a variable surgical option for the treatment of low to moderate myopia. Given that the low luminance visual acuity and the contrast sensitivity significantly improved in compact arms soldered after implantation of the new form of the ICL, and this is especially true in patients who require excellent night vision. In addition to the visual performance, stability of the ICL is another important consideration, including the risk to the benefits analysis for refractive surgery. I will not go for this because of the time. But I can just highlight it that we did a study for a long time in our hospital in Egypt, the Watani Eye Hospital. It was a study for anisometropia and for children, and we used the ICL for these patients, and the results was amazing. We followed the patient for more than 10 years. We put from age of 6 till the age of 14, and most of the patients, we treated them from amblyopia. So this is our study. It was published in 2021, I think, yes. So it's I'm not going to go for more for the time, but these are some of the cases that we did for the patient, and you can see how the right eye, 9 diopters, and after the implantation of the ICL, how we reached just this, and we treated amblyopia for the patients. And the second case, one of the cases, it was like this, is a child 13, -8, and we reached post-operatively nearly 0, and we treated amblyopia for these patients. So my home take message for this point, the long-term efficacy, safety, stability of the VZ and ICL for correcting myopic anisometric amblyopia in pediatric is very important, and the report reported that the non-compliance with occlusion therapy validate the early implantation of the ICL in cases with failed conventional therapy to guard against infection. Thank you so much.
Ashraf, so I think we need to conclude, no? So we finished the session, but please remain because more content is coming up. Thank you very much.
We invite you all to stay with us for the coming session, the Alcon Amico Symposium, and just after we'll have the amazing live session surgery. So stay with us.
Good morning. Thank you very much. We hope that you're having a nice session so far, and we welcome you to the Alcon Amico Symposium this morning. Without further ado, we'd like to open our session with Dr. Ammar Safar, consultant ophthalmologist, vitreoretinal surgeon, and medical director at the Moorfields Eye Hospital in Dubai. Doctor, the floor is yours. Thank you.
Thank you so much. Good morning, everyone. And first, I would like to thank Alcon for giving me the opportunity to discuss with you this device, which really is, I think, or if you ask me, I believe it's one of the best investments I've done for my health and for the practice and my patients' health too. So what I'm going to try and discuss in the coming few minutes is some first of all, give you a little bit of a history. How did we actually get to this point? Also, the technical overview of the system. How does it work? How do we set the operating theater up for maximum benefit from this system? And also talk about what are the main things that I found to be very helpful in using this system. So as we all know, we have come so far in actually where we are right now. Started everything with the surgical viewing systems, if you will. Started with the surgical loops, which were first introduced in 1876. And then things started to improve. As we know, the microscope was first modified binocular microscope was introduced in 1946. And then, of course, things started to improve on that front, where we had the foot switch. Believe it or not, we didn't have a foot switch in the beginning. And then, of course, the split beam, actually the beam splitter is actually a major step where people can see what you're doing also at the same time. And then the zooming and the optics, all of this have improved. Now, of course, going into a digital platform, I think came with the introduction of digital photography also in the early 2000s, the beginning of this century. As we all know, you may remember, we used to have a camera when we go traveling, for example. Nowadays, even these cameras are obsolete. We use our phone, and every edition of our iPhone or our tablet or Samsung phone actually improves the quality of these imaging, which basically tells us that we have so much to gain from a quality, resolution, and color to move forward. So when I first tried the Ingenuity system in 2016, it was the 3D system, and that was the first generation, and I honestly thought it was not worth it at all, because there was significant lag between what I'm seeing and what I'm doing, and also the setup wasn't clear, the colors weren't really as good. So the optics that I had in my microscope were actually so much more superior than the digital image that I'm looking at. It really looked digital. It didn't look clear, crisp. It had the slight noise that you see sometimes with digital imaging. Things have actually improved significantly since then. And you can see here from 2016 until the year 2020, with the introduction of the newer processor, newer cameras, the integration of the other machines that you operate in the system, where you can actually control everything, your machine, your viewing system, you look at your parameters all in one screen, which really is an amazing thing. So basically the system is simple. You have three specific parts. One is to acquire the image, which is the camera. Then you have a processor, which has a high-speed imaging processing capabilities. And then, of course, the viewing of the image should be on a very high-end LED screen. So this is basically the camera. It optimizes the 3D surgical image, and exposure is in real time. It balances the light, which is one of the biggest features of this system, which we will talk about here in just a second, and gives you a very high resolution of imaging that you are acquiring in this camera. And then, of course, this goes into a very high-speed processor, which improves the contrast, sharpens the image, and also adjusts the colors based on your likings, and we'll show you some examples of that. And then, of course, it elevates the intensity of this image. This all will not be great if you put it on a screen that's not high resolution. So this is a very high-end screen that gives you a 4K resolution of the image that you are looking at. So what you should expect is this kind, if you look to your left here, this little bit of a faded color, you get a lot more augmentation of the color and vividness of that color to help you basically see what you need to see in very great detail. So OR setup can be actually depending on what you do or what you like to do. If you're doing cataract surgery, for example, for the right eye, you can set it up in this way. You can actually, for the left eye, you can do the other. This is another example. Those are all examples or recommendations, but the important thing is how far are you having that screen from you, which is quite important. It should be 1 to 1.3 meters from you, because that will increase your depth of focus. But these are the examples of anterior segment versus posterior segment setup. So what we need to do, of course, is to perform the surgery with excellent precision, reducing the risks of problems and complications. So that's why we need to actually have all the information available for us. So for example, sometimes your scrub nurse will tell you the settings, but you really don't hear them well, or because of the mask, you don't really understand exactly what they said. So you see everything on the screen, so that you can actually get that precise surgery without the complications, without the potential issues that you might encounter. Those are some of the very important features for this digital system versus the analog system. As you can see here, it is 5 times the extended depth of field, which I feel is the most important thing in my experience. The extended depth of field is a very important feature, along with the increased depth of resolution. Now, of course, at the same time, you can magnify 45% more, and you can adjust the color, so not the color, the light, sorry. So the light source, for example, on your light pipe, or even if you're doing an anterior segment on your microscope, can be approximately at 30% of what you are used to. Depth of field and depth of focus is a very important thing. So you look at this picture of this nice lady, you can see her very sharp, but you can't see anything behind her. This is a little bit better. You can start seeing something, but in fact, if you want it, what you want to see is this kind of contrast, where you can see, and depth of focus, where you can see her, the intermediate, and the back in a good way. So this is, yeah, there you go. So this is basically an example I wanted to show you, where you can see the posterior pole, and you can see the detached retina at the same time with excellent clarity, and you don't really have to focus down or focus up in order for you to actually see. This is the same patient where the vitreous is being shaved, and you can see here where all of them are actually clear: the posterior pole, the detached retina, and the area that's being depressed and treated with the vitrector. So magnification is also a very important thing. So imagine you're doing, for example, membrane peeling, or you're trying to apply an amniotic membrane or anything like that in a macular hole. To have the traditional view on your left versus the right blown up on this very large screen in front of you, actually that really, you're almost looking at the RPE cells there to try and make sure that you do not induce any problem intraoperatively. And this is another example. Unfortunately, it's not showing up very well here because of the lights, but I think you get the idea. Personalizing the color also is an important thing, although I have to tell you, this is not a feature that I use that much, but I set up what I like and then I stay with it. But sometimes, in some cases, you might find a need to do so. On the screen here, this looks much better, but this is a patient, for example, here. I felt that the too much red was going on there, reducing my contrast, so I changed it to a different scheme where I could see the contrast better, which I feel is a very good thing that the analog doesn't really give us at the same time. So the integration of all of the systems that Alcon has into this big screen is really, I feel, a very good and positive thing that we have, because again, you are in control. You can change everything, all the settings on the, for example, I use the constellation. On the constellation, I can change from step to step, or go back, or do everything I need to do, even flip my image or reflip it back again, all with my foot pedal. Now, the light we talked about earlier, less microscope light, less endolaser light, hence less toxicity to the retina, of course, especially with the, the need sometimes to put dye on the retina. We don't use ICG anymore, but still this idea is a very protective idea. Also, I have pretty much stopped using, I also do cataract surgery, so I've stopped staining the lens because really the view you get is very good. So how do you actually set them? This is very important to take your time to set the machine up with every case when you're actually starting to magnify the image as much as possible, and then grossly with your hand find the good focus, and then you let go, and then you actually go up. This will give you a very good a very good depth of focus to actually not be able to, or not find yourself having to zoom in and zoom out. This is the setup that we have in our theater. Like I said, it's very important to have the screen 1 to 1.3 meters from you to get the best benefit. This engages my scrub nurse here who actually can see exactly what I'm seeing. And of course, we have also medical students that are attending our surgeries and they can see exactly the same image that we see. So this is really a very good teaching tool at the same time. Thank you so much for your attention. One last thing I want to say is I've noticed that my back is far, far better after starting to use this. I now finish my OR day not really having to go lie down so that my back actually relaxes. This is really an investment in my health also as much as it is in my patient's health. Thank you again.
Thank you very much, Doctor, for your informative session and for sharing your clinical experience. Next, we'd like to invite Dr. Ismail Arbabi, Medical Director of Moorfields Eye Hospital in Abu Dhabi, who'll discuss more on the patient selection criteria. Doctor, welcome.
Thank you very much for the invitation, and thank you very much, Dr. Ammar, for presenting that such a great case. So Dr. Ammar clearly presented what Alcon has done to improve surgeons' vision and health, and now I'm going to talk what Alcon has done to improve patients' visualization and patients' vision. So today, really, I'm going to talk about the two very, very premium IOLs which we have in our hand, the PanOptix versus Vivity. What is the design and how to optimize patient selection for success. And from my point of view, is two of my favorite lenses which I've been using for a long time. So first of all, about the PanOptix design philosophy, what is different in PanOptix compared to many other lenses available in the market? So the traditional trifocal, as you know, they've got two-step heights, so they give you two additional power in addition to your distance power, so giving you a true three focal point or trifocal. However, what's different in PanOptix, it's got three-step heights, so it gives you three additional powers in addition to your distance power, so making it truly a quadrifocal intraocular lens, with the third focal point being at 120 centimeter. But the technology that they have, the Enlightened technology, what it does, the third additional power at 120 centimeter, which is not very useful, it'll be shifted to distance vision, and that increases the light transmission, and you get a light transmission of 88% as 3 millimeter pupil, which is incredibly good. And the PanOptix, what it does is actually divides the light 50% for the distance, 25% for intermediate, and 25% for near. It's got a 2.17 diopter add, so that's at IOL plane. So at the corneal plane is 1.65 diopter add. That's for your intermediate vision, giving a comfortable intermediate vision of 60 centimeter. And that's, again, a crucial difference compared to many other IOLs in the market, because most other IOLs in the market, they have an intermediate add of 80 centimeter. And if you think 80 centimeter, that's really an arm length of someone who's over 2 meter height. And I'm sure even here in this conference or in the country, there's very few people are over 2 meter height. So that's a much more comfortable intermediate vision. And it's got a near add of 3.25, which is very comparable to most other near adds of 40 centimeter. It's got a negative spherical aberration on the anterior surface. So basically it counteracts the slight positive spherical aberration we have on our cornea. Is non-abatized, and is a foldable acrylic hydrophobic IOL with very low PCO rates. And also what matters is the actual diffractive zone within PanOptix. It's got a diffractive zone of 4.5 millimeter, which almost keep it a very sweet spot, because anything smaller than 4.5 millimeter basically compromises the near and intermediate vision in low lights. And if you make the diffractive zone higher or larger, it compromises mesopic distance vision. So that's a really, really good compromise for the diffractive zone. So we're going to now talk a little bit about the Vivity design, and it is actually a truly unique EDOF or extended depth of focus design. It's the only IOL with a wavefront shaping technology. It transmits 100% of light, unlike all other diffractive IOL or trifocal IOL. And it's got excellent contrast sensitivity and visual disturbance. And in some studies, the visual disturbance and contrast sensitivity was similar to a monofocal lens, actually. So what is X-Wave technology? It's actually the Vivity. If you look at the actual lens with a naked eye, it looks like almost identical to a monofocal Alcon lens, the Clarion, for example. But what's is different within the central 2.2 millimeter? It's got this plateau, which is a raised area by 1 micron. And if you want to understand it, look at the topography. A plateau of a geographical topography, you can see it's just a raised area with a gradual change of the curvature within that plateau. So it's got a ring around that 2.2 millimeter, which is raised at 1 micron, and then a slight change of curvature within 2.2 millimeter. So what that does, this is called surface transition zone 1 and 2. One of them, the peripheral ring, actually it stretches the light, whereas the central one, the change of curvature, what does it shifts the wavefront. So what that means basically, it delivers a naturally occurring continuous extended focal range from distance to near without loss of any light, with all 100% of light getting transmitted to the back of the eye. As I said, unlike other EDOF lenses, we use a diffractive principle, and they do lose light transmission. So what it does is it stretches and shifts, and it doesn't split the light, and hence the excellent contrast sensitivity that this lens provides. So how do you go about choosing between an EDOF or a trifocal or PanOptix or Vivity? And for the trifocal, obviously, it's really should, in my opinion, should be only implanted in a pristine eye. Someone who's got completely perfect cornea, perfect retina, perfect optic nerve, and the rest of the anterior and posterior segment, basically. Anything less than pristine, you should really, in my opinion, not consider using trifocal. You think about something else. And now with Vivity, it does give us that ability to give premium vision to a lot of our patients who are not suitable for trifocal or premium IOLs. So the trifocal is ideal for someone who does a lot of near vision, for example, an accountant, a lawyer, a university professor, whereas the EDOF or Vivity is ideal for sport people, actually, because it's like someone who play golf or someone who is a cyclist. They'll want the distance and then intermediate vision, and that's really make them very happy. And they will just go into the patient's quality. And obviously there are areas which they both share, and the most important thing is trying to decrease dependency on glasses with both of them. So how do we select the patients? There are actually 4 important preoperative factors for should be 1, 2, 3, 4 for success. So the first and most important is really understanding the patients well, understanding who they are, what's their profession. As I said, as a lawyer, has a very different visual need than someone who spends most of his time outdoor playing golf and so on. Their lifestyles and activities, but most importantly, understanding their expectation and taking a thorough history and eye examination, checking for any eye abnormality which may preclude them from either of the IOLs, and also their general history, for example, diabetes and so on. And educating the patient, involving them in decision-making is incredibly important. And fourthly, really understanding the available technology. For us, we have to understand different IOLs, how they work, so then we can explain that to the patient in a very simple terms that they can understand. So understanding the patient is really, most patients are between these categories. The first category, the patient said, I want the very best quality vision, the best night vision, the best contrast, and I will wear reading glasses. They clearly go towards monofocal. You don't need to spend much time on them. And the second category say, I don't want to wear reading glasses, and to achieve that, I'll happily sacrifice some quality of vision, especially at night when I see some glare and halos. So these patients, again, clearly are good candidates for trifocal IOLs if they've got a pristine eye. However, a lot of patients will be the last one, say, I want perfect quality vision, I don't want to wear reading glasses. And these are the patients you refer to your colleague, actually, and let them deal with them. No, and that's actually, the majority of patients will start with that third statement, and that's why patients' educations come into effect. So just going to go to patients' education. It's a little bit changed, actually. Yeah. That's where patients' education become very, very important, and to bring them to the reality. And I often tell the patients, basically, the perfect lens technology does not exist. So whatever we do, it will never be what Allah has given us, our own lens, which I'll explain that our own lens has got the muscle, which is the fastest acting muscles, and whatever distance they look at, it will change the focal point almost simultaneously, and no lens can do that. And once you explain that, then they will start to realize that, they tell them that whatever we do, whether we do monofocal, EDOF, or trifocal, there is some compromise, and what compromise we want to make depending on the patients. And explaining clearly what the compromise is with monofocal, EDOF, and trifocal. And also it's very, very important. This is a bit of controversial. Some people, they say, don't even mention glare, because when you mention it, the people think about it, they look for it, and they're more likely to see it or experience it. But in my opinion, it's incredibly important. If you're doing any premium IOL, if it's Vivity or PanOptix or any other lens, you should really explain that it's likely they will get initial glare, and I will explain that majority of patients will neuroadapt. And I'll emphasize that with the glare, this is the last time you think about the glare. Once you go from here, you never heard about the glare. And even if you experience it, you just ignore it. It's not there. And I'll also mention that you should never compare between the eye operated and eye not operated. Because this way you teach the eye to look for glare, and to teach the eye to understand what the glare is and what is without the glare, and that prolongs the neuroadaptation period. So it's very, very important to explain to patient those very, very pertinent points, because once they understand they glare, you warn them they glare, they will know about the neuroadaptation. They'll be more likely and willing to accept it and wait for that time to neuroadapt, whether it's going to be a few weeks, few months, or even longer. So we'll go back, because there was a little bit of, so as I said, understanding the patients, and then was the patient's examination. The history is very, very important. And the patient's examination will start obviously with the ocular surface and the corneal pathology. And this is a very, very important. Cornea is the first place where the light hits the eye, and the light even before reaches the IOL. So if you've got a cornea which is less than perfect, it's got a regular astigmatism, if you've got a problem, it's basically the light is a poor quality even before getting to our IOL, which even compromises the light even worse, even more. So that's why I say it's garbage in, garbage out. So if you've got a cornea which is sending bad lights to IOL, it doesn't matter what IOL you have, what you're going to get is going to be even worse. So for patients, when we're considering any premium IOLs, it's actually one of the most important things. Is if the cornea, there is a corneal pathology, I really, really have very, very low threshold of rejecting these patients for premium IOL, particularly the trifocal one, because then it's very, very unlikely that they will be happy. So that's very, very important. And within corneal pathology and ocular surface, the most important thing and the most common thing, which actually probably the most patients will be dissatisfied from any post-operative surgery, is the dry eyes. So it's very, very important to spend a lot of time to treat their dry eyes, to optimize it. And some of them actually have the patient, they come 3, 4, 5 times, and they come to the doctor, if you don't want to do the surgery, just tell me why you keep bringing me in and in and in to give me more drops and more other treatment for the dry eyes. But it's very, very important to completely treat that as well as possible and optimize it. And if the dry is not controlled, then they're not suitable for any premium intraocular lenses. And the history of previous keratorefractive surgery is important. So general exclusion if they have any keratorefractive surgery is if they've got uncontrolled dry eyes, myopic ablation usually over 6 diopter, hyperopic ablation over 4 diopter, radial keratotomy or decentrate ablation zone, they generally will be excluded from premium IOLs. But even if they have had previous keratorefractive surgery, if the corneas, as I said, they're really in two groups. Those are people with completely normal tomography, and those are not. If they've got completely normal topography and tomography, they can still be considered for premium IOLs. Even trifocal, but if you're thinking about trifocal in the patients who have previous refractive surgery, the most important things you have to explain is refractive surprise. If the patient's happy and understand that, they may need an intraocular lens exchange. That in a very certain condition can still be done, but it has to be a pristine eye, even if they had laser surgery with very low high order aberration and normal high order aberration as well as normal topography. In glaucoma, again, glaucoma is not a good candidate for any premium IOLs. However, in certain cases, in glaucoma suspect or early glaucoma where they haven't had any visual field loss at all, and you've done a 10-2 field and there isn't any central field loss, they've been stable over years on monotherapy, a premium IOL can still be considered. And I think it's important as well not to condemn these patients for a lifelong. They said, because you've got glaucoma, we're not going to give you anything else. And we really have to measure it in the merit of specific patient, because some of these patients can still enjoy that if they've been stable for years and years. And the patients who have glaucoma, the surgeon may consider doing a mixed surgery during cataract surgery to make sure that decrease the risk of any progression even further. Retinal pathology, again, avoid any trifocal, any condition that progresses over time, avoiding any condition which already have decreased contrast sensitivity. Vivity in certain retinal condition can be an option, particularly some people with a very, very early drusen, for example. And patients' education we've talked about. And one thing quickly I just wanted to touch as well, in patients with unilateral ocular pathology, again, doing a mini monovision or mix and match can be incredibly helpful in decreasing their dependency on glasses, targeting essentially dominant eye for metropia and non-dominant eye for about minus 0.5 to 0.75. It works very well with Vivity, even for people who have completely pristine eye, but you want to decrease the glare and halos, you can consider that. And of course, you can do mix and match as well. So in conclusion, both PanOptix and Vivity uses unique patent technology to deliver high performance. Many patients are suitable for premium IOL between the two, actually. And I really reserve trifocal for pristine eye with no eye pathologies, whereas Vivity is a bit more forgiving and can be used in less than pristine eyes. And mix and match is another good option for someone, for example, got a very mild epiretinal membrane in one eye, for example. And thank you very much.
Thank you very much, Doctor, for sharing your experience on this very important topic, very informative. Next, and finally, to conclude our session today, it gives us great pleasure to present Dr. Prasann Rao, consultant ophthalmologist, vitreoretinal surgeon, and medical director at Medcare Eye Hospital in Dubai. Doctor, welcome.
So at the outset, let me thank Alcon for giving me this opportunity to speak. I'll be talking about Clarion lenses. So these are my financial disclosures. So how does one decide which IOL to implant after cataract extraction? So we look at basically two factors, the patient factor and the surgeon factor. So let's look at the patient's factors first. So Clarion intraocular lens is Alcon's most advanced IOL material. The key features of this material are it's a hydrophobic acrylic lens, and most importantly from the patient point of view, it has UV blocking absorption properties. And you know this is very important in this part of the world because of the huge amount of sunlight which we have. So UV blocking property in some way has protective effect on the retina. We see a lot of difference when you use Clarion lenses. Clarion is one of the most advanced and modern material, and that provides unsurpassed clarity for our patients. It is also glistening free. Among all the other lenses, it has the least levels of surface haze and something known as SSNG, which I'll mention later. This glistening and surface light scattering were reported to be very less over a period of 1 to 9 years, and it's truly a pristine intraocular lens. So there was a report published in JCRS a few years back, and it looked at Clarion lens with other of its competitors, and similar which are available in the market, the hydrophobic lenses, and it was found that Clarion has the least amount of glistening over a period of 3 to 9 years. The ultra-smooth optic delivers almost low levels of surface haze over a period of time for these patients. So again, if you look at this graph, you'll clearly see on the left, you have the Clarion lens with the least amount of surface haze as compared to the other lenses in the market. Besides this, we also look at what are the PCO rates, because this would influence the long-term clarity of vision for our patients and the need to do YAG laser. So Clarion has clearly demonstrated lesser rates of YAG at the end of 1 year as compared to Acrysoph IOL. And this is primarily because of its continuous posterior barrier, which prevents the migration of the epithelial cells over the posterior capsule. Also, it's got an enhanced IOL design, which provides sharp, crisp, distant vision. And the anterior 0.2 micron aspheric optic partially corrects the average posterior spherical aberration, which most of these eyes have when they undergo cataract surgery. It's also got this proprietary edge curvature, which significantly reduces the edge glare when you implant these lenses. As compared to other lenses, it has a fully usable 6mm aspheric optic, which provides sharp and crisp vision from edge to edge. So in the middle, you can see some lenses which have these peripheral rim, two kinds, but these may not participate in the lens visualization, unlike when you use Clarion. So these are all from the patient's point of view. What about the surgeon's point of view? From the surgeon, we need a lens which gives a predictable and consistent delivery system. And that's important when you have foldable lenses, because back in the days when you had non-foldable lenses, if you remember when you implant these lenses, when you put them in the cartridges and we would inject them, we had to tilt our hand, turn our hand, and things like that. So Alcon has come up with this unique autonomy delivery system. It's an automated disposable preloaded delivery system which is powered by the CO2 gas canister, which is present at the distal end of the injector. And most importantly, unlike other injectors, this has an intuitive single-handed control. So at one hand is supporting the eye or preventing the eye from tilting. The other hand can be simply used for injecting. And it's a very unique design, which is helpful for surgeons. So as I mentioned, it's an ergonomic design which fits comfortably, and you hold it like a pen, which all of us routinely do when we write. So it's not something which you need to learn. It comes intuitively, unconsciously to us, how we inject the lens. So as I mentioned, it's an intuitive single-handed control. And importantly, the IOL travels at a constant speed of 3 millimeters per second and can control it at any point of time. You can stop it, restart injecting, and continue it. And more importantly, it protects the incision as small as 2.2 millimeter. So these are the features of autonomy system. At the distal end, at the end, you have the canister, which has the carbon dioxide delivery system. So once you press the lever onto the injector, the carbon dioxide canister gets activated. At the other end, at the proximal end of the injector, you have the proprietary distal depth guard, which prevents excessive entry of this of the cartridge into the wound. And it has also got a 3 millimeter nozzle tip, which allows you enough entry inside the wound when injecting. There's a viscoelastic port to deliver the viscoelastic inside the eye, and it's got this lockout assembly, which is designed to protect the IOL and also gives a predictive speed of control when you inject. So all these features are very, very helpful for the surgeon. So the thing is, now you have these patient factors and you have the surgeon factors. So what do we do? How do you utilize Clarion? So as I mentioned, Clarion provides a lot of benefit for the patient as well as the surgeon. So if you look at this video, in this video you're going to see a few things. One is the smoothness in which the lens enters the eye. Once the lens has entered the anterior chamber, you actually tilt your eye, so that allows the distal haptic to enter inside the bag. Incidentally, this is the surgery which I performed on my mother. So she had cataract and she had vitreomacular traction. So I'm doing a combined procedure for her, and this is how the lens goes in so smoothly inside the eye. And then you center the lens. And the best part about the lens is the unfolding. It's a very, very smooth unfolding inside the viscoelastic agent. And you can center the lens easily inside the bag as well. So my key takeaway from this presentation is Clarion is amongst the lowest levels, has the lowest levels of surface haze. The subsurface nanoglistenings are the least, and the glistening over the lens is the least. It has the lowest possibility of ND YAG laser requirement. It's got a PCO barrier which prevents occurrence of the posterior capsular opacification. And it's got a haptic which is very flexible and leads to very well stable intraocular lens. And the autonomy injector system allows a very controlled, smooth, automated delivery of the Clarion lens. With this, thank you very much.
Thank you very much. Thank you for joining us this morning. Thank you to our esteemed speakers as well. Now it seems we'll have to postpone our discussions perhaps throughout the day as there is a live surgery which is going to start very soon. Thank you once again and wishing you a great rest of the day. Bye-bye.
Can we ask for George Aliou, please? We are going to prepare the live surgery for the anterior segment. Can we ask for our panel for the first 45 hours? Dr. Mohsen Baqqali, Dr. Hatem Ammar, Dr. Safa Jihad.
Volume. Iska volume.
Dr. Osama Glidi and Dr. Samir Rabia. Yes. جورج بعتي بقى. We have this morning live surgery from 3 centers. From India, Dr. Priya Narang and Dr. Nilsh. We have Dr. Miguel Rekiki from Italy and Dr. Abdurrahman Rais from Morocco. So, hi Priya, do you hear us? Hi Priya.
Case of ours? Yes.
Hello
Ashraf.
Hi Priya, how are you? So can you
I'm good.
Can you tell us about the case and yourself also? Can you present yourself to the audience?
Yes. I'm Dr. Priya Narang. I'm a senior ophthalmologist from Ahmedabad, India, practicing. And I do lots of challenging cases, and we have one such case right now. And as you see, this is a 26-year-old male, and he had a traumatic, massively subluxated lens, which was almost dangling in the vitreous. So, and this patient also has a traumatic mydriasis, as you can see. Now, what we did actually for this patient was, you can see the three ports there. We did the pars plana vitrectomy and lensectomy for this case. Incidentally, this patient also had choroidal rupture because of the trauma. And now what you actually see here is, you can see the fluid infusion which is there, and we have made these 2 partial thickness flaps which are just 180 degrees opposite to each other. So we plan to do gluteal fixation for this patient, and we will be using a 3-piece intraocular lens for this. And after that, we will be doing pupilloplasty procedure to cover up the traumatic mydriasis. So that is what this case is all about.
Okay, so what you are going to do exactly now?
I'm trying to make the corneal tunnel right now.
Okay.
And so I'm loading the 3-piece intraocular lens right now. If you can see this, and this is the 3-piece intraocular lens for this patient. And I'm going to do the glue procedure for this patient. So the loading of the intraocular lens is very important because that is, what decides how this IOL is going to unfold. So, yes.
Berea, I am Hatem Ammar, Egypt. This is Sensor IOL?
Yes, doctor, this is a sensor IOL.
You prefer it from MA60 of Alcon or no difference in your hands for glue IOL?
Pardon? This is AR40. I'm just trying to be cautious with the loading of this intraocular lens. So I have loaded this intraocular lens and before I inject this IOL inside, I need to check how the haptic is coming and I see it coming appropriately. Looks okay to me. Can you see this? This is a 3-piece IOL.
Yes,
and
we can see the haptic, yes.
Yes. So this is the IOL and I'm going to get this haptic a bit more out so that it is easier for me to hold. And you can see this, it goes inside. Infusion, fluid. Slight fluid infusion on.
So it is a 23 forceps or what?
1 minute.
The type of the forceps you are holding the haptic?
25.
25, yes. Okay. So you are opening the infusion also, yes?
Yes.
Okay, perfect. To maintain the pressure inside the eye.
Yes. So I have the leading haptic externalized and this system, BG forceps object, BG forceps upper. So this is the trailing haptic. And I have transferred the haptic from one hand to another. That was a handshake. And I will go and hold this. So, yes. And both the haptics are out. So this is one step of the surgery which is almost over, where in both the haptics, you can beautifully see the leading and the trailing haptic, which is outside. So this is, both the haptics are now been externalized. 10-0 suture. I'm going to close down the corneal incision first because, I don't want any leakage going on at this time. I need a closed chamber right now. So I'm going to take up a suture and close down this before I go in and tuck my haptics. थोड़ा fluid ओछू कर दो ना.
Okay, so you prefer the glued IOL better than the Yamani, or you can do this?
Yes, I do prefer it because, the results are better in my hands, to be honest. And I see less decentrations in the post-op period with this technique because, I can actually see where the sclerotomy site is. And, it's not a blind procedure, but it suits me much more, so I'm doing it. I have nothing against any procedure.
What about the tilt in the glued IOL?
Yeah, that is what. Actually, Dr. Ashraf, the tilt or the IOL, it comes from the sclerotomy, where you actually create a sclerotomy. So that is it. So if your sclerotomy is perfect, you do not get tilts. If you see the sclerotomy site where you are entering inside the sclera, So you can see this. I've just closed this down.
Okay, Dr. Sami, if you are going to do this case, you are going to go for a glued IOL or Yamani technique? Yamani. Okay. Can you? Dr. Artishaz, did you try the glue IOL or always do Yamani technique?
Thank you. I'm mostly trying in my practice Yamani technique, and I like this technique
26.
more. Yeah, of course, it's not for all
Two.
type of IOLs, but for
Two.
this kind, it can be used with with this help of
Fine.
Yamani technique. Yeah.
So, what's your next step? You are going to embed the haptic?
Yes. Now what you actually see is I'm making a scleral tunnel.
Okay.
I'm going to, tuck this haptic fluid. Fine. So what you see right now is tucking of the haptics, This is where the haptics, they go in. 26.
Perea, one question, Hatem
Yes.
Ammar. Why you don't make the tunnel while preparing the flaps before starting the surgery? I think it goes pressurized eyeball and much easier than this one.
Iris hook. Iris hook चाहिए.
Okay, Priya, we are going to move from you to another center in Italy, Dr. Miguel Rikiki, okay? And we'll come back to you again. Miguel, hi Miguel, from Dubai.
Hello, how are you?
Yes, please introduce yourself to all the audience here.
Yes. Hello everybody, my name is Miguel Rikiki. I come from south of Italy. Actually, we are located in Sellia Marina. And I'm responsible for the center that is called the Centro Polispecialistico Mediterraneo. So today we'll perform 2 femtocataract surgery with premium IOLs and 1 cross-linking plus. So we will start first with a femtocataract and then with a cross-linking. Thank you for inviting. Very honored to be there.
We are happy that we have you today, Miguel, and maybe next year you're going to be live with us. So let's start because of the sake of the time, okay? Can we present the case and the details of what we are going to do?
Yes, I will present my case. Actually, this is a patient in which I will perform a femtocataract surgery. If you can share my screen, can let me share my screen, I can.
You already on the screen now.
Yes.
The patient. Yes.
If the technician allow me to share my screen, I will I will present my PowerPoint for this patient.
Okay.
So let the technician to allow me to share my desktop screen. Okay, that's perfect. Yeah.
Yes.
You can see?
Yes.
Okay.
Quickly, Miguel, please.
Yes.
Yes.
So.
Full screen, please. Full screen, Miguel.
Yes. Okay.
Okay.
So this will be my platform today, J&J Fentolaser and Faco. We will implant first an Alcon VBT and then a COA Avant-C. I use routinely my femto cataract laser because in my hand it adds very precision and also quality to my surgery. The first patient is a male, 69, the right eye, with a medium cataract, and it needs for more spectacle independency. So we will implant an Alcon IOL that everybody knows, like wave shaping IOL, that really adds a very good far view and intermediate view without not too much loss of a contrast sensitivity. And this is my choice, my preferred choice for EDOF IOL. So we start with the surgery.
Yes. Can we stop sharing, please?
Yes.
And we go to the surgery. Yes. Let me ask you a question. Why did you choose femto cataract for this case?
Because in this case, I am sure about the circularity and the sides of the rexis, and because it really makes me very easy the cataract surgery part. So
you need more stabilized centration because you are going for a premium
yes.
cataract surgery now.
Yeah, yes. Okay. If you look, this is the pattern.
Okay. What's the size of the rexis you are going to use?
It's a 5.1 rexis.
Okay.
Now I prepared the patient. That is very easy.
Does the patient has astigmatism or not?
No, in this case not. So this is not a toric IOL. It will be the next patient. And as you can see, the procedure is quite linear and easy. So I just approve the treatment. Then I install the interface that is a liquid interface. And then I apply this interface with a little suction, with a vacuum.
Okay, in cases of deep sunken eye or a small pupil fissure, do you still go for femtocataract or you are going to go for normal?
No. The only limit of femtocataract surgery is that you must have a pupil of at least 6 millimeter or 5.8 because the laser do a capsular rexis that is 0.2 millimeter less than the iris dilatation. So you have to take this in account. So it will not help you in the case of a very small pupil. So this is not the case. That's why also I choose this. I now lock the patient. And if you look now, I am adjusting the vertical pressure. And then I confirm the operation. And now the OCT scan all the anterior chamber. And it's very, very quick. As you can see, now it's analyzing the iris diameter, the anterior chamber depth, the limits of the cornea, and the posterior limits of the cataracts. And I approve the treatment. I approve the rexis. You can change also in time, but this is not the case. And now I confirm all and start with the treatment. So this is the rexis already done. And 35 seconds for the pattern of fragmentation. I choose this cross pattern with the two big horizontal and vertical lines and a cubic pattern for the quadrant fragmentation. As you can see, now it's generating some gas bubble that you will see after in the surgery. But now with a more engineering energy delivery, we have very few bubbles that not do some disturbance during the surgery. So, okay, that's finished.
Okay, till you go to the surgical microscope,
yes.
We are going to have some question with the panel.
Yes.
Dr. Osama, what's your platform if you are going for cataract surgery, femtocataract? The same platform?
Although we had the machine now, we hardly ever use it. The cost is too much, so really I stopped using femtocataract almost because it's good for capsulorhexis, but there's no big advantage other. If you had experience here, you don't need it.
Okay.
And the cost really, the problem is the cost. The cost here is like $2,000 extra. So for me, I don't charge the patient for that extra. I don't see the benefit in my hand.
Hatem, if you are going to use this, which platform you are going to use?
If I am rich enough and my patient rich enough to pay for it, I'll use the Catalyst one. I find it in live surgeries, it's more rapid, more precise, more forgiving than the other platforms. But practically, I find it is machine femtocapsulorhexis, not femtocataract surgery. It's just doing capsulorhexis. I find capsulorhexis an easy step, not a need for all these expensive machines. Okay. But as long as the patient can buy, can pay, okay.
Yes, which platform you are using?
I'm not using femtocataract surgery, but I agree with Professor about the advantage of capsulorhexis because this is the main thing that help us to do this surgery and not to have any complications in white cataract, of course.
Do you see benefits for this technology in premium IOLs for the centration, for the size of the rhexis, for the centration of the rhexis also? Is it give a lot of benefits, or we can do this with the manual way?
I totally agree with you, Professor Ashraf, that of course the main advantage is stabilization of IOL, the size of the rhexis, not to have complications in white cataract, and of course using premium IOL to have a very good IOL stabilization during the phaco.
Okay.
And in addition also to the arcuate incision, you can use it to correct astigmatism. It makes centration.
Ashraf, just comment.
Yes, yes.
I used many years before Bouchillon platform for femtocataract surgery, and I stopped to use it because it take much time and the cost. And really, I think there is two conditions which are very helpful. White cataract, because the rhexis is very helpful, and posterior polar cataract, we can cut the epinucleus safely. Except these two cases, I believe that's not used for this machine, the cost, and we lost time.
Okay. So can we go to tell Miguel finish, prepare, back to Priya?
Yes, I'm finishing. Okay, yeah. Back to Priya, I will call
once you are ready, tell us. Priya, what you are doing now?
Yellow box.
Hi, Priya, do you hear me?
I'm trying to pull this loop out for doing a single pass 4th row.
So you are doing an iris repair for this patient?
Yes, I'm doing an iris repair for this patient. Fine. I don't know if you noticed, I had
Metti qua la presentazione più così vediamo il mio video. Sì, vai.
So I have withdrawn the loop. As we all know, this is a nanopolypropylene suture. I have passed to the proximal and the distal part, and I'm going to pass on the suture end through the loop 4 times. 4 times is the minimum throw that you need to take. I hope you guys can see this, and always in the same direction, never to go against the direction. So If you actually forget to count, you can take 1 or 2 throws more. There is no harm in it, but it should not be less, otherwise it will open up. So, are you seeing Ashraf?
Yes, I'm seeing you, Pri.
Okay.
We are seeing very well, Perea. Really, thank you for the single pass through Perea. It solved a lot of problems with us for eyes surgery. Thank you, Perea, for it.
So, do you think, Perea, that the fourth row pupilleplasty it changes the way that we are repairing the iris tissues now?
Yes, definitely. It has made things quite simple and easy. But what I'm facing in this case is that, this is a traumatic case. So how
many knots you are going to do to decrease the size of the iris and also to centralize the pupil?
I'm only going to take 2 as of now. So I think I have a corneal fiber here. So see, that's again a teaching point that, that everybody should get into. If you have a corneal fiber coming up, things, they don't slide. It does not slide inside.
Okay, Priya, we are going to move to Miguel if he's ready now. And Dr. Abdurrahman is also ready with us. We are going to be with you very soon, Dr. Abdurrahman.
Oh yeah, it has released.
Okay.
I think can you see this? It's looking so beautiful.
Okay.
So one side of single pass is already done. Yes?
Okay, done, and we are seeing also.
Microfiber.
Okay, Dr. Rahman, be ready. Just we are going to finish with Miguel in Italy, and back to you in. We are seeing you. Don't remove the camera. Okay, Miguel, can you start, please?
Yes.
Okay.
So this is the situation. As you can see, you already can see the rexis and also the cubic pattern.
Okay, there is always hazard during the hydrodissection after femto during the femto that you can due to the retained bubbles behind the nucleus you can have a block in the rexis.
Yes, this is a crucial situation. Probably the really only issue that you have to take care when you perform this kind of surgery. As you can see, I prefer to do manual incision because to me it's more quick and more easy, and I never had to reopen. Please, per favore guardi la luce, quelle 2 luci, bravissimo. Okay, this is the more tricky situation. You have to do very gentle hydrodissection. You see the wave and the bubble that went outside, and the nucleus now is going up. As you can see, is all up. You can see the bubble. Yeah, now the bubble come anteriorly. So in this way, you decompress the camera. Yeah, you can see.
Yes, we can hear you. Yes, we can see that the bubble is out, yes.
The bubble is out, and this is mandatory because this is a sign of the compression of the posterior capsule. And then I just refilled with a little visco. The capsule, as you can see, is already free floating. And now I insert my phaco machine.
What's your phaco machine you are using, platform?
Actually, I'm using a platform from J&J. This
26.
is Signature Pro. This is now I can, as you can see, the rexis coming to my mouth. So really free floating. And then I sculpt, please. And then I just make a groove to the center.
So you are going to do a vertical chopping?
No, I will do a stop and chop technique. So I just do some groove center, and I know that femto laser already divided the nucleus from posterior. You can see it's divided from posterior.
Yes, it's very
And
clear.
once this is good,
It's
I
very clear,
just
yes.
go to the phase 3, please. And now, per favore, alzi il mento, rise the chin. Okay, I'm in topic.
You are
So
in
the
topical
patient-
anesthesia?
And now, yes.
Okay.
And opening.
I know
Dr.
this is
Miguel,
not the best live surgery, but I wanted to show you my routine. And
Dr.
now,
Miguel,
it's just,
you are
yes.
always preferring to use a 20 gauge tip of this machine? This is 20
Yes,
gauge, a straight one, not
this is
curved.
20
You
gauge.
prefer this one?
Yes, I prefer this one because I have a very easy to remove also hard cataracts. And as you can see, it's also the fluidic is very good also for this cataract that is not so it's really hard at the end, but sometimes with the femto cataracts you cannot realize how much hard is the
Okay,
nucleus.
Miguel, after you finish this, we are going to come back to you before the implantation. So we are going now to Dr. Abdurrahman Rais in Morocco.
Yes.
Can you mute yourself, Miguel? Yes, Dr. Abdurrahman, we are happy to have you here in Dubai, live from Morocco. Please, can you introduce yourself to all the audience here?
Hello, everybody. I'm Dr. Rais Abdurrahman from Casablanca Eye Center. I am very happy to be here to you this morning, and I will share with you some special cases with smile surgery and premium
Alzi un po' il
IOL.
mento.
Miguel, can you mute yourself?
Tutto bene? Yes. Please mute. Please mute.
Yes, Abdurrahman. Dr. Arhan.
And I will show you some cases for smile and with frisbee smile and thin cornea, and some cases with trifocal lens and toric lens and ICL toric with 3D surgery.
What's
I will
your
start with-
machine, Dr. Arhan? What's your machine?
My machine is, today I will work with Visimax 800. It's
Okay.
the latest machine from Zeiss.
Okay.
And we can do Smile Pro. It's very fast machine. We can do cutting in less than 10 seconds.
Okay.
We are very happy with this machine. And the first cases is the Frisbee Smile with monovision, because for a man who has 48 years old, dominant eye, right eye, and -5 for cylinder and 0.75 for astigmatism in each eye. So this is the first case.
Okay, let's
We can
start,
start
and
if you want.
you can have some questions from our panelists. Dr. Samir Rabia here from Kuwait. Do you want to ask? You know? Okay. Okay. What's your parameters for setting for the smile, Dr. Abraham?
Sorry, what?
What's your parameters for the size of the lenticule?
Yeah. Okay. Dr. Sami, how are you? Nice to meet you, to hear you. So the setting are very simple. With smile surgery, we have to keep residual posterior wall more than 250, only 250. That's why we can do a lot of things. Here we have the planification, and we have an incision at 90 degrees, angle 56 degrees. And we have the diameter of the optical zone is 7 millimeter, and the flap, the lenticule, the flap is 130. We are 130 deep, then we do the lenticule.
Okay, let's go. And there is very question. Yes.
Abdurrahman, good morning, Abdurrahman.
Alan,
Muhsin.
صباح الخير محسن.
Muhsin. At
Good
40,
morning.
myopia 48 lady, which kind of screening you do before making surgery? I'm asking about to be sure that the lenses it's clear.
Lens is clear, smile. lens is clear. He has only 48 years old, so lens is clear. And we can share with you the topography for the patient to have an idea.
Because Ashraf, I think we share the same position because I used to do eye tracing.
Yes.
Yes.
So,
to be sure,
as
at
you
this
see,
age,
you are
there is no lens opacity. Yes.
No lens change. No.
Can we go to the surgery, Dr. Abdurrahman?
Yes, of course.
Yes.
Let's. Let's. أعطيني له بسم الله مصطفى صبا. الحمد لله. حلو هذا مثير. سير الزين الله يخليك.
Ashraf, فهمني الرجال.
Yes, Miguel. Just 2 minutes.
Yeah.
2 minutes. We're going to be.
Okay, I will wait 2 minutes.
Okay.
Yes, we start. Yes.
So this machine changes to be different than the old one.
Yes, it's faster than the old one, and it's
centration?
another machine, another ergonomic machine, but the curve and learn is very short.
Dr. Abdurrahman, I am Hatem Ammar from Egypt. You find this platform is better in the post-operative quality of vision than the older one? They assume that surface is more...
Can you repeat this question?
You find this new platform is better in visual quality post-operative than the older one?
No, it's the same quality. It's the same quality. At now, it's the same. We have the same post-op for a patient. But it's more faster. And I think with time it will be better because, fast surgery is better during smile than low.
Yes. Can we go for the surgery, Dr. Arhan?
I think the smaller the spot here, they made it much smaller. So the quality is much better, I think. And you have a patient who is 22nd day. Before 2020 will take a week.
So you are doing the docking now, Dr. Abraham, yes?
Yeah. Yes, we are doing docking. We have joysticks, and the patient has to see the green lights, and it must be good centered, of course. And yeah, good. ما تحركش. Pas bouger, ما تتحركش خليك. Voilà. شوف شي قسم le nez. Pas bouger. Don't move. Okay, donc this is 20 seconds, less than 10 seconds, yes. Voilà. Yes, ما تتحركش. Voilà, la lumière va disparaître. It's done.
Okay, so it's fast. So you're going to have the dissection now, yes?
Yes, dissection now. So, yes.
You are going to move the patient or the same microscope?
Yeah. To do the
dissection.
The dissection of the lenticule.
Yeah.
Is it clear for you? So I start for doing to make identification for lenticule. This is the anterior plan. This is my own technique and the posterior plan. Then we come back once again to the anterior plan. And do dissection over the lenticule. Je suis bien centré?
It seems a very smooth dissection, Dr. Abraham.
Yeah, it's very nice.
Yeah.
And now I'm doing the posterior wall. And we can do the relax refractive lenticule extraction. Like this.
Yeah, beautiful surgery, Dr. Arhan. Very smoothly went fine. So we are going to leave you to move to Miguel Rikiki in Italy. And please mute yourself, Dr. Rahman. Miguel,
yeah.
What you did?
Tell me. Miguel, yes.
So, I just implant the lens. I didn't show you because it's a very common procedure. The only issue there is the Alcon BBT is not preloaded, so I have to load by myself.
Okay.
And then I push. But what is more important to me is to show you how the lens now is perfectly centered in this beautiful circle, perfect circular axis. And so this is guarantee for concentration. I center the Purkinje reflex on the central zone of the lens, that is the active one, is the zone that acts like the heat of effects. So very easy, very low ultrasound power, and that's it.
And you have the
Then,
ability to center the eye because the patient is in topical anesthesia. So just you telling the patient, look for the light.
Yes, yes, and the beautiful with this kind of anesthesia, the patient is very collaborative. So you have also to select the patient. Not all the patients are used to this, but in this case, I have to do my compliments to this patient. That is very, very, very collaborative. So I disconnect now, and I will take the line for the second case. That is a toric IOL that I will mark also with a femtocataract with an intrastromal incision, okay? See you later.
Thank you. Thank you. Very nice case, Miguel. We can go for Priya. Priya, what you are doing now?
Okay, and the haptics, I will just lift the flaps and show you. The haptics are very well tucked now. And we did a 3-port pars plana vitrectomy. So, you know, I'm just sealing up those port sites with a 6-0 white krill so that, you know, you do not have any leakage from any point of view. And after this, I'm almost done, and I'm going to seal up the flaps with the glue and close up the conjunctiva also.
And,
so,
and how many sutures you take in the iris to make the pupil centralized?
I just took 2, one in the superior and one in the lower kind of thing. And you can see it's very well, you know, covered up. So, looks good. We have closed down, you could see that we had a traumatic mydriasis. So we have closed down here and we closed down here. So like it's almost good enough for the patient. The added advantage, you know, many times of doing this is even like suppose in myopic eyes, isko nikal de?
Beautiful surgery, Priya. It was not an easy
so
case
I'm just
for
removing
life
the
surgery.
fluid infusion also from, I'm just removing the fluid infusion also from the eye. And like, we are almost done. Yes, Ashraf, you are asking me something. Please ask.
Okay.
Actually, many times you don't need to close this, but we have taken up because this patient, you know, also has a choroidal rupture. So like we don't want to leave any side that is open for this patient. So we are doing it. Many times, you know, the trocar incisions are the valvular incisions and you do not need to do anything much for them.
Berea, you always make...
Yes, Ashraf, you were asking me something.
Berea, you always insert a trocar and cannula, or sometimes you do glued IOL with anterior chamber maintenance. If you don't need to do vitrectomy.
I use anterior chamber maintenance, doctor, but for this patient, you know what? We have already done a lensectomy with core vitrectomy for this patient because he had a massively subluxated lens. So before we had actually started the procedure, we did that. So we were anyway going to have these port incisions for this patient. But yes, otherwise, you know, we can use the anterior chamber maintenance. There's nothing wrong with it. It's very good, actually, you know, using anterior chamber maintenance. But what happens, you know, with the anterior chamber maintenance is that, you know, you have to be very careful about the site of, you know, the size of the port that you have created. Otherwise, you know, in these complicated cases, you do not actually want your fluid infusion or you do not want your infusion cannula to slip out from anywhere. So many times trocars, they work very well. And many times what I do is that, you know, instead, even if I don't need a posterior segment trocar, I use the same trocar of the posterior segment in the anterior chamber. And I go about 0.5, something like, you know, I'll just show you what I do. About 0.5 millimeters somewhere from here. Use that as an anterior chamber maintainer. So it works very well for these patients. Glue.
Okay, we are going to
So
move.
we are almost done with this case, and
So
yes, yes.
you are going to prepare
So we
the
are
next
just going to
case.
seal this patient right now.
Okay. So you
Yes, we are getting the next case ready. Yes.
Okay. So we are going to move to Miguel. Tell Dr. Abdurrahman Al-Rais prepare the next case. So Dr. Miguel.
I'm ready. I'm ready. So this is the next case. This is a patient that is astigmatic also. So in this case, I choose to implant a toric COA IOL that I don't know if you that actually is distributed in a Middle East. So this is a particular
Miguel,
Yes.
do you choose toric IOL or you have a femto? So why you don't go for arcuate incisions?
Because in this way it's more predictable. Arcuate incision I use sometimes when I have astigmatism more than 4 diopter, and I'm not sure about the IOL, so I can adjust in a second moment. In this way, this is the second eye of this very myopic patient, so I'm more confident with the toric IOL that the residual astigmatism will be low.
Okay.
So this is the case. Is a myopic eye, 26.72. I already do a excimer laser toric marking with the Schwind laser, but I will do also capsulorhexis and intrastromal corneal toric marking, as you will see. The good of this lens is that have a power that decrease from the center to the periphery. That's because there are a lot of studies that show that astigmatism is not the same in the center of 3 millimeter, and this decrease until 6 millimeters. So the peculiar characteristic of this lens is that the power decrease from center to the periphery. So the correction of astigmatism is quite better also in a mesopic and scotopic condition. And the other beautiful thing of this lens is the injection system that is very predictable and with a very low force, but you will see in the sample.
Okay, can we go to the surgery?
So, yes.
Okay.
This is the planning. As you can see, I plan in this case not only the rhexis and cataract fragmentation, but also I will do toric marking intrastromal, so the epithelium is not open at the degree of the axis that I want. Guardi il mio naso. So this is the preparation, the same. And I approve the treatment now. Okay. And now I center the interface pointing at 0,81 degrees. Apro tutti e due occhi, guardi il mio naso.
Dr. Maguel.
Fermo fermo.
Dr. Maguel.
Yes.
Hatem Ammar from Egypt, you also don't do incisions by the femto machine. You always trust the keratom than the femto machine.
Yes, yes. I never use a femtosecond for entering, for the enter. Yeah, because in my opinion, are not useful. So this is a very good machine for facofragmentation, capsulorhexis.
Yeah, but you trust the machine in
I
arcuate
use
incisions?
the arcuate incision. Yes, I use arcuate incision.
Miguel, we lost you. We lost the photo, the video.
Hanno perso il video. Vai su LCMS. Okay, you have the video now.
Dr. Abdurrahman, we are going to be with you in 1 minute.
Abbiamo il video? Sì.
Yes.
You have the video now?
Yes.
Okay.
So we are doing the docking now for the femtocataract.
Yes. There is a bubble now. Yes, I removed it. This is quite different from the previous cases because I will do also toric incision. So, scanning laser in about 30 seconds, analyze all the cornea. In the next release next year, this procedure will be linked also to IOL Master 700. So we will have also iris recognition and more precise toric marking. So this is a news. This is a breaking news that I will. I'm telling you. I have the permission from J&J to declare this. So I approve it all and go with the Rexis. Remember, this is a very myopic patient. So in these cases, the centration, the size of the Rexis is quite more important with respect to a normal patient, especially if you put a toric IOL.
So your software can do the mark for the toric?
The next release, yes. Not actually, but the next release will be linked with the IOL Master 700. So in this case, I do a manual adjustment. I mark it with a excimer lace and the pencil 180 degrees, and I put the interface exactly in a horizontal axis. And then I compute to do the toric marking at 93 degrees.
Okay,
it is
so
actually
this is
the degree in which I will put the lens.
So this is a new change in the because marking during the femto, it will be a game changer for putting a toric IOL.
Yes, and this
Okay.
will be a game changer. The link with the iris recognition and the IOL Master 700 will be for sure.
Okay, Miguel, we are going to leave you and go to the other center. Dr.
Yes.
Okay, can you mute
Thank
yourself? Dr. Abdurrahman, you are with us now, live.
Hello. Hello. Are you hearing me?
Yes, we are hearing you.
Yes. So the second case is for SMILE. It's a young woman, 26 years old, and she has minus 2.75 and little astigmatism. We can show you now her topography. And she has a very thin cornea, 474. And the idea is to do SMILE with deep lenticle, 130 microns, and we can have a good residual wall. I will tell you. So we will start in a few minutes. Optical zone 6 millimeters.
What's your flap size? Thickness, sorry? The flap thickness?
Flap thickness is 474. I can show you again the
No, the flap, the cap, the thickness of the cap.
133. 133. 30.
130, okay.
Yeah.
So you don't go for a cap around 100 or 110?
Yes, if necessary, yes. Because the important thing for me is to let the posterior wall more than 250. So if my first choice for the thin cap is to have the deeper one, the 130 is excellent, or 120. If not, I can do 100.
Okay.
So, we go to surgery. Vas-y. Zoubida, ça va? Ah non, ça l'a fait.
Dr. Abdurrahman, you always do femto smile for all your patient, or you can do femto LASIK in some cases?
I didn't hear the question.
You always do femto smile for all your cases, or you sometimes do femto LASIK routine, femto LASIK
Yes,
or
it's
LASIK?
my first choice. It's my first choice to do SMILE first, yes. I do less LASIK, more PK for astigmatism cornea, and more SMILE. ضربت هيك شوية وأنا ما تحركش في الضوء كده الله يخليك. الضوء صرت هبط شوية. La table, la position de la tête, هبط شوية. هبط شوية. Voilà, super. So it's important to have a good position for the patient and to do and try to do good centration. Encore هو دراسك شويه فوالا فوالا ما تحركش شد الخضر ديالي as possible of course no it's not yeah ما تحركش this is good centration no
It was.
not ما تحركش راسك هكا ما تحركش فوالا تري بيان شد الخضر الله يخليك فوالا سوبر زبيده بارفي ما تحركش الله يخليك ne bouge pas so the blue light on the right it's okay session is okay ما تحركش الضوء يمشي it's very fast ما تحركش
Docteur Abdelrahman, bonsoir. Safa معك.
bonsoir Jihad
Comment ça va? I just want to ask you what is the maximum amount of myopia did you do correct by SMILE?
can you speak more
slowly
lower,
okay.
higher Jihad prefer
What's your maximum amount of myopia do you correct by SMILE?
what is maximum
The maximum myopia you correct.
Maximum myopia
Yeah.
yes with this machine we can go until minus 10 for myopia.
And you, what you do?
I do this, and when cornea is good, I do until minus 10, and until minus 5 for astigmatism.
It looks very nice, Dr. Abdelrahman. Central.
Did you feel the difference between the two machines? You use
yes.
both, I think, in
it's
your
more
daily
faster
practice?
with this machine. It's more faster. The surgery is the same for the surgeon for the lenticule retraction, but for the cutting, it's more faster. With the old machine, it was 20 seconds. Here we have 9 seconds for cutting, very fast.
And
we don't have time to lose session.
And what about the precision, the outcome of the visual acuity, the patient, the precision of the predictive refraction?
Okay, wonderful dissection, Dr. Abdelrahman. Really very smooth. The two cases, تسلم ايدك بصراحة. Very nice and perfect centration.
Can do another eye? Yes.
We have some questions, Dr. Ashraf.
Yes.
For Dr. Abdelrahman.
Okay, we are ready?
Yes.
Yeah.
Dr. Abdelrahman, you have a question from Dr. Kharij Al-Arfaj from Saudi Arabia. So he's going to ask you. Yes.
Dr. Abdelrahman, do you hear me?
Yeah.
Yes. Okay. So if I am a refractive surgeon and really comfortable with my platform doing femto LASIK, give me a good reasons, 2 or 3 reasons that I should move from my platform on femto LASIK to SMILE. Good reasons. I want you to convince me to move to SMILE, to do a SMILE procedure as a standard corneal refractive surgery.
Yeah.
Guardi sempre più giù, guardi, è un pochino più giù il... Ecco, bravo, così è perfetto.
Yeah, hello? Yeah. With smart surgery, it's very safe because when we think 2 seconds about the physiology of eye, the anterior cornea is more rigid than the posterior. And that's why we can resist to wide and cold and snow and all things. So if we preserve this anterior cornea, it's very nice. And for dry syndrome, we don't have the dry syndrome with SMILE because we are deeper than the nerve, the nerve. And also how the biomechanic is conserved. We don't open the eye. That's why I am very, and I see difference between SMILE and LASIK patients. SMILE patients are very happy after surgery, always.
And the recovery time is the same almost, or it is slower a little bit than femto LASIK? The recovery time, the residual.
The recovery time, yes. It's the recovery time is a little bit slower than LASIK.
Yeah.
After 2 days, they are okay.
And
after day 1, they are
Va bene?
70 or 80% after.
Aspettiamo solo un minutino.
And the last question about the dryness. Do you notice really difference dryness and the dryness clinically and in the practice? Do you see the difference between the femto LASIK and SMILE?
Yeah, clinically we have difference.
Yeah.
Yes. We
Thank
see
you.
difference, and we can do some studies together if you want, but it's better, much better, more better than LASIK. And if we compare the results, so I have more than 10 years that I do SMILE, and I have some experience about that, and I've also experience about thin cornea. It's worked very well.
Okay, Dr. Abdurrahman, we are going to move to Miguel
I'm ready.
Kiki.
Yes.
Because
Yes,
he's going to, yes. And can you mute the others? So go
Okay.
Miguel.
You can hear me?
Yes,
You can hear
and
me?
see you, and see you well,
Okay.
yes.
Question for
I
Dr.
just
Miguel.
do paracentesis. Now I go for the main incision.
Dr. Miguel?
As you can see,
Dr. Miguel,
as
you are
you
going
can
to receive
see-
questions.
Yes.
When you are doing femtocataract surgery, why you don't use the femto to do corneal incision? First question. Second question, when you are doing femtocataract surgery, do you take in account the CPET axis for the incision,
The
corneal
CPET
incision?
Okay. So in this case, I'm about the incision. My incision is 2.4 millimeters, so it's really astigmatically neutral. So I have 0.2. I have 0.2 degree of astigmatism after surgery. So I didn't really take in account. And the way, because I don't do corneal incision, is that you have always to reopen. Because, by the way, if the femtolaser do the corneal incision, if are open, the eye will blown. So you have always to reopen. So in my way, it's a wasting of time. So I just don't do this. And the other reason is that this kind of incision you have to do also in a perfect circle. So the cornea is not a perfect circle. So sometimes you do the incision about the main incision, but you can do the side incision exactly where you want, especially in oval cornea. So this is the reason why in my routine I didn't use this.
So you are going to crack the nucleus now?
No, not easy way, because as you can see, the nucleus is already up, so it just catch. Okay, fase 2.
Dr.
So
Miguel,
in this case, yeah.
One question I am Hatem Ammar from Egypt. In this machine, you use white star technology and in which ratio?
Yes.
Or you use ordinary ultrasound?
No. It's a white star.
And
So
what's
it's
the
very-
ratio you
it's very-
prefer, 8:4 or 16:4? What's the ratio you prefer? On and off time?
So, sorry, in normal cataract, the white star is very, very gentle. In this case, I know I have a very soft nucleus. The issue there is the patient is very myopic. So as you can see, I'm really catching the cataract in a very deep plane.
Very
as you
simple
can
and
see,
soft
no?
case. That's why I recommend the
Yes.
21 gauge is much more stable in this case than the 20 gauge tip.
In my hands, it's just a question of a pedal, no? So the
One
parameters
more
are
question.
on your feet. So,
Dr. Miguel,
so actually,
do you using phaco energy right now during your surgery, or you are doing just irrigation
actually no,
aspiration?
I'm just in aspiration. Actually.
Just irrigation aspiration? And
yes.
because we see the shallow anterior chamber during
No,
the
no.
surgery. What kind of viscoelastic are you using?
Actually, I use a 1.8 hyaluronidase for the first phases, but when in this case, it's because it's soft, I just use it at 1.0. So it's very, very light, viscoelastics. So the other issue here is as all the soft cataract is some way sticky. So I'm just, please, I will send. Okay.
And do you have more corneal edema after flux surgery as compared to standard phacoemulsification? or results are the same?
No, usually it's the same, less in very hard cataract. Less in very hard cataract because I just do a trench and I can emulsify the pieces in a August plane. So really, I do not have not too much edema.
Miguel,
so in this way,
Miguel,
now,
Miguel,
yeah.
we are going to leave you now and back again
Okay.
because we are going to Priya
Yes.
Narang. Priya,
Okay.
tell us about the case. Priya, do you hear me? Dr. Nilsh. Dr. Nilsh, can you tell us about the case, please? Dr. Nilsh, do you hear me? Yeah, can you present your case, please?
It looks to be tilted IOL. Malpositioned single piece IOL.
Okay, we can go back to Miguel. Tell Dr. Henry. Okay, Miguel, we are with you now, and we can mute Priya.
Dr. Miguel, can you hear me?
Okay. Can you hear me? Yes.
Can you hear me? I'm Dr. Ismail from Egypt. I just wanted to ask you a question. Do you like to, first of all, congratulations for the nice surgery. Actually, it's perfect.
Thank you.
Do you like to make some kind of maneuver to evacuate some of the air bubbles trapped behind the nucleus before starting? Because with my little experience with the femto laser, femtophaco in general, I do have the platform of Bausch & Lomb about 10, 11 years ago.
Yes.
And we should do such a maneuver, otherwise you might be faced with the rupture of the posterior capsule. What do you like about this?
This is the best question that you can ask to a femtocataract surgeon. So this is the real issue of the femto laser, and this is the problem in which all the company struggled for years at the beginning of this technology. So the question is, you have to evacuate the air from the posterior capsule after a gentle hydrodissection. You saw in my first cases that I show you the hydrodissection, and then I tilted a little bit the nucleus just to let the gas to pass from the posterior surface to anterior.
Okay.
Once you do this,
Miguel,
you are so confident that the capsule will be not in pressure.
Miguel, we are going to leave you for 5 minutes or 3 minutes and back you again. Dr. Nilsh, do you hear us?
Yes, sir, I can hear you. Are you able to hear me, sir?
Yeah, can you present the case, please, and you present yourself, please?
Yeah. First of all, I'll like to thank Priya Madam and the scientific committee to allow me to present my physical case. Now, this was a case of 74-year-old lady wherein she had undergone cataract surgery. And there was a complication you can see here. I'm trying to remove the epithelium because there's little corneal edema here. You can see there's a J&J lens is there, eye lens, which is dangling in the vitreous. So I'm trying to prepare the glued IOL flaps. Okay, so I have to go in for a vitrectomy. My plan is in this case a vitrectomy, removal of this J&J lens, and implantation of the 3-piece. Now here I'm going to show a different IOL. It's an Oro View. Can you please show the image of that Oro View? It's an Oro View foldable IOL 3-piece with PMA haptics. Okay, and the best part of this is I have started nowadays using this IOL as a glued IOL because you can see the size is almost 13.5 millimeter. So I have better portion of the haptic to glue and to tuck into the sterile pockets. Okay. So here I'm trying to prepare the other flaps. The size of the flap is 2 to 2.5 millimeter, and it is almost 180 degree from the limbus.
What is the size of the flaps?
It is 2 to 2.5 millimeters, sir.
Okay, and how far from the limbus?
It is 2.22 to 2.5 millimeter.
Okay.
From the limbus, and it is almost 180 degree aligning is done here. You can see the marks here.
Yes.
So the most important step here is preparing these flaps.
So you are planning to remove the IOL and use the glued IOL?
Yes, sir.
Okay, okay. So
Yes,
you didn't try to refixate the lens again?
No, sir. What we have seen over the long time, no, it goes for a dislocation. So better to take it out and implant a new lens. Because nowadays you can see here, a lot of IOLs are getting dislocated. We see in our OPD a lot of patients who are coming with the dislocated IOLs.
Okay, Dr. Nish, we are going to leave you for 2 minutes and back to you again.
Yes, sir.
Dr. Miguel, what you are going to implant?
Yes. I'm going to implant a COA Avanci preloaded toric IOL. So as you can see, the injection is so smooth, very, very smooth. So and this is important because especially in cases like this in which you have a very deep anterior chamber, this smoothness helps you so much. And now,
so Miguel, do you use the digital marking or you use the ink?
No.
Yeah.
I do not have actually digital marking.
Okay.
So I'm using, you can see the marking with intrastromal with the laser. So I'm using this. And as you can see, there is also an area of desensitization that I do with the PTK with excimer laser. So this is the most precise way because it calculates also cyclotorsion. You can see this is the area of the area in which I did the excimer laser.
So this
I will use
Miguel. So this is the new software from J&J that you can mark the cornea for the toric alignment.
Yes. This is the last evolution.
Okay.
In the ultimate, we will have a link with the IOL Master.
But I think it's not commercially available nowadays. I think still not.
No, but it will be.
Yeah. Okay.
So,
and what type?
Stay tuned.
And what type of viscoelastic you are using in the bag before implanting the toric IOL? Visco cohesive or visco dispersive?
No, cohesive because you have to open the bag and you have also to facilitate the removal. As you can see, 1 second, and when you use now cohesive, that's all. That's all. This is finished. So this is important because you have to be sure that all the visco will be removed, and if you have cohesive, it will be more easy. So
Miguel, we are going to leave you and go to Dr. Abdurrahman. He's going to operate in a 3D surgery. Dr. Abdurrahman, do you hear me? Dr. Abdurrahman? Yeah, do you hear me? What type of surgery you are going to use and what is your platform?
So, now I'm happy to present you the trifocal surgery with physio lens, the fine vision for old patient and cataract surgery with hypermetrop, plus 175 and a little astigmatism, 0.50. And I did the last weekend, few days before, the right eye. He's very well, and now we're doing the second eye. The platform is, I will working with the Artevo Zeiss, Artevo with 3D surgery, and also I am using Centurion machine for phacoemulsification.
Okay, and do you find that 3D surgery is now changing the way we are doing surgery now?
Yes, it's very nice for me. I like challenges that I find my comfort in 3D surgery. You will see that it's very nice. You have a very short learning curve, and it gives me, I am less stressed. And as you are seeing, my microscope is going on and nothing to do the normal surgery.
Okay,
I never did.
Let's go for surgery.
Yeah.
Let's go for surgery.
Yeah.
Yes.
Thank you. Topography, yes. Surgery. Ilham?
Yeah, let's go for surgery.
Yeah. So, Ilham, شوف معي اسمك.
So also you are going to use the marker alignment.
Yes, markers. So here you see 3 markers from Callisto machine, from Zeiss. And I always do 3 incision, 1 main incision and 2 side ports. And always do marking my localization with the...
So this is the Callisto from Zeiss?
Yeah.
And you also, you do the mark in case that the Callisto is not working, so you have double marking, digital and the ink.
Yes.
Okay, perfect.
I prefer, and I do
Dr. Abdulrahman, it is in the periphery, there is zonular weakness or it is reflections of light?
If there is subluxation, Doctor,
zonular.
If there is subluxation for this case,
Is it the equator or reflection?
I didn't see the zonular dialysis, but I hope that is not.
Hope.
It's normal. I think we have a good dilatation.
Be careful.
So, become هل نشان? Okay. It's topical anesthesia. Huh?
maybe it is the reflection, because I think little bit tilting the microscope can give the impression that we have subluxation.
بعد
Allora fai il giro da là.
It's the reflection of the micro. ما تحركش يا سيدي.
Sì, sì. Sì. Poi qui mi serve il PC vicino perché devo far vedere le slide.
Mute Miguel.
It's the reflection of microscope.
Bello.
It's the reflection of microscope.
L'occhio migliore per fare una...
It was just a reflection, it was not subluxation. A tilt. بس انت بتاع subluxation اصلا.
It's not a hard lens. Tu peux montrer l'ambiance de la salle?
So, what's your technique in chopping, vertical or horizontal chopping, Dr. Abraham?
I don't do chopping. I am a little bit classical. I do always the divide and conquer.
Okay.
And if you have a soft lens, I can attack directly the soft lens.
This is Centurion machine.
Can we go to the surgery, please? Because they changed the camera to you. Yes. Okay.
This is Centurion machine, Dr. Abdulrahman?
Yes, Centurion machine.
You use active fluidics?
Only OZL, not.
You use the active fluidics or the gravity?
Active fluid, yes.
Active fluidics. This is the handpiece of Sentry, the new handpiece?
No, I don't understand your question.
The new Sentry handpiece of the Centurion, gold.
J'ai pas entendu. Can you repeat, please?
The new Centurion, the new tip, the new balance tip, yes. So, Dr. Arhan, all your cases in phaco, either soft or hard, you go for divide and conquer technique.
Yes.
So it's more it is the classic and the most safest.
Yes, here, for example, it's soft. It's not always easy for me. Soft lens, I prefer to attack it directly.
Yes.
It's better than divide and conquer.
Yeah. So if it's a little bit soft, you can do a flip and chip technique. You can pick a big gutter in the middle and you flip it.
Yeah.
Okay. And what you put the physiol for the patient in the other eye, yes?
Yeah.
Okay.
We have to take care with the soft lens, you know. It's always not.
Okay. We are going to move, Amir. Amir.
Very nice surgery, Dr. Abdurrahman.
Okay.
Congratulations.
Can we move to Dr. Nilsh? Tell us what's going on. Dr. Rahman, we are coming back to you again. Dr. Nilsh?
The three-piece IOL has been removed, so I'm just doing a little bit vitrectomy to make sure that everything is clear behind. The bag was quite kind of subluxated, and probably sulcus was not there. So otherwise, I would have placed IOL in the sulcus.
Okay,
so for first aim is to try to fix the IOL in the sulcus if possible, but it was not possible in this case. Yeah, are you able to see the view? Yeah, unmute. Yeah. Okay, so now the glued IOL flaps are ready, and can you remove this? So you can see here the flaps are ready, and I have made the tunnel here. This is the tunnel here from where I am going to implant the lens. Can you show me the lens, please?
So this is a new lens patent for you?
Yeah, it's a new lens. It's a new lens. And I am more feeling comfortable with the lens because I have more amount of haptic which can be tucked here. It can be used as a foldable also, but in this case, since I have to remove the IOL, explant the IOL, so probably I'm trying to use it without the injector. It's a preloaded IOL which comes. Can you show the image of the IOL, please? Yeah.
Yes.
So it comes with the preloaded IOL. Okay. So comes with the injector system.
So this is the first three-piece IOL to come in a preloaded design.
Yes, sir. Now I can show you the lens also. Now if you can see here. Yeah, you can see here, this is the preloaded version. I hope the view is clear. Okay, so you can see here, this is the optic, these are the two haptics, and the size is almost 13.5 millimeter.
Looks
great. So I have more area to work on.
Yeah.
Okay. Only one catchy position which I have already spoken with this guy is, it takes a little bit time to press the cartridge because that's very important step. Yeah. Otherwise, yeah, so I have taken it out. Now only thing I am using is a non-foldable kind of one. Okay, I am going to remove this thing. Yeah. So this is removed. This is the lens.
Because you have already.
Rest steps are the same.
Because you have already
a
big incision. Yes.
Yeah. So there is no use of using the injector.
Yeah, okay. So you're going to do the same technique, glued IOL.
Yes, sir. I'm going to do the same technique of the glued IOL.
Yes.
Okay.
Can I get so?
I'm ready. Just.
Yeah. So this is an important, crucial step. Just go little bit 1 millimeter behind the limbus. Can you put some saline, please? Yeah.
Okay. Dr. Nish, we are going to move from you to Miguel because he's going for the Dr. Abdurrahman Rais first. Dr. Abdurrahman, you are putting a trifocal IOL, yes?
Yeah.
This is the Physiol.
Yeah.
Okay, this is the new design of Physiol with 2 haptics or 4 haptics?
Yeah, new design for Physiol.
New design for Physiol, exactly. Yes. So do you think that the 2 haptic of new design of Physiol is better than the 4 haptics, the old 4 haptics?
No, I prefer C-loop.
You prefer the C-loop, okay.
Yeah.
Okay. And the patient in topical anesthesia or block?
Yeah, topical anesthesia, yeah.
So you are going to look for the centration and you tell him to fixate the pupil?
Yes.
Okay.
عبد الرحمن أهلا وسهلا. هيكل. دكتور هيكل.
هيكل أهلا يا حبيبي.
How are you? Just I have a question for you. In real life, you use only 3D or both?
ما سمعتكش بالكويس.
In real life, you use only 3D microscope or also normal microscope?
Yes. No. Since I have the Artimo microscope, I use the 3D surgery.
Beautiful surgery, Dr. Abdurrahman. We are going to move to you, to Miguel Rikiki.
Yeah. Yeah. I have to do centration and it's finished.
Yes. Miguel?
Okay, thank you. This is the specialty of the home.
What is the case, please?
The case is a patient with a keratoconus. I will show you after the laser treatment the maps. I'm going to do the SERIX protocol. That is a combination of a transpure K topo-guided and accelerated cross-linking. As you can see, this is as you can see, I will do now the abnormal decentrated ablation that I center on the apex of the posterior elevation of the cone. And as you can see, the ablation is, in this case, is a novelty because is a total corneal wavefront guided treatment, because actually I upgraded my system with the TM39 machine that is a OCT from CSO that actually take in account the total corneal power.
So,
this is a,
so Miguel, this is the new integration between CSO and Schwind.
Yes, and what is good for this kind of treatment is that the laser takes in account also the epithelial map. So you will ablate much more less tissue in this kind of treatment in which you know the epithelium is a thinner. So in my experience, I did now more than 30 cases have a tissue savings of more than 25%. It is very lot, especially in this kind of eyes in which the thickness is
we can
so
go.
important.
We can go
So,
to the surgery
I will
directly.
start,
Yes.
I will start. As you will see, the treatment is a little bit the center, intertemporal, on the tip of the bone. Then, after this, I will show you just the slide for this patient, because in this kind of surgery we have some dead time that we had to face. Okay, this is the ablation. I don't know if you can see, is the centered, is a 6 millimeter transpure K ablation. And now I just put the riboflavin. The beautiful things of the transpure K guided treatment is that only the cornea affected by keratoconus is directly receiving the cross-linking treatment. Because remember, the keratoconus is a focal pathology. So if you treat all the cornea, you will have a flattening of all the cornea, and the cone is the same. But if you cross-link just the area of the cone, you will have focal flattening, and this will be better also in for reduction of aberrometry. So this is the case. I will show you. You can share, you can see my screen now?
Yes.
Okay, this is the case. I will just show you the, okay. So, this is the case. It's a quite central keratoconus with an apex of a 50.92 diopters. And you can see the posterior, this is the TMS T39 image. You can see the bulging of the posterior surface. This is the treatment. As you can see, is not the same because it's guided. It's a total corneal wavefront guided, but at the end, you will have a maximum ablation of 84 micron with epithelium. So it's very gentle treatment. This is the SERIX protocol. And after, I will cross-link the cornea with an energy that is customized on the epithelial thickness using the nomogram that we developed with the Cosimo Mazzotta. This is the rationale of the treatment.
Okay, Miguel, can we, I think we are going, we came to the end of the live surgery. So please,
Yes,
all the surgeons can come to the camera to say something.
Yes, camera.
Yes, we are going to close this live surgery. So we want to thank you all for this. Please stop sharing, please.
Can I have a quick question to Miguel?
Yeah.
Miguel,
Yes.
are you hearing
Miguel,
me?
stop sharing, please.
Thank you, Miguel.
Yeah. Oh, sorry.
Stop sharing, Miguel.
Yes.
Yes.
I'm here. Sorry.
Yes.
Hello, Miguel. This is the Dead Sea photo. Can I ask, did you
Hello,
use
my friend.
mitomycin in the combination when you combine both cross-linking and?
No, this is another very important question. You do not have to use mitomycin in every kind of single or combined cross-linking procedure. Why? When you do cross-linking, you kill the keratocytes. So the stromal aids cannot exist after cross-linking because you kill the actors. The hyperreflectivity that you see after cross-linking is just a corneal edema, not real aids. So I never use this because also Shadi Avad in a beautiful work showed how if you use mitomycin C,
can we make it a little bit fast, Miguel? Yes.
Yes.
Can we have the question short and the answer short because we are coming to the end of our live surgery. So there is another question from the panel. Yes.
Okay, Miguel, again, a question connected with your surgery.
Doctor.
There are many opinions that it's better to perform step-by-step surgery, first cross-linking, then customized trans-epi correction, visual correction, and you do both. How is your experience in visual outcomes in both cases? Because many doctors think that visual recovery are different.
Rapidly, one thing, this is not a refractive procedure.
Rapidly,
so this is a therapeutic procedure. And second, if you do trans-PRK after cross-linking, you will have a big risk of corneal aids because after 4 or 5 months, the keratocyte repopulate the cornea, and so you're adding another inflammatory procedure. So you will have a big risk. That's the reason why I always combine these procedures and never do first cross-linking and then trans-PRK.
Thank you, Miguel. Dr. Abdurrahman?
Thank you.
Dr. Abdurrahman, do you hear us? First, Miguel, thank you so much for the very elegant surgeries, and we are happy that you have it. But keep with us, Dr. Abdurrahman. Thank you so much. It's a wonderful surgeries. The smiles. I know that the life surgery is not an easy issue, and the surgeries went smoothly without any complication. This means that you all an elegant, strong surgeons. And strong, the heart also. So tell us about your experience with us, Dr. Abdurrahman.
I'm very happy to share with you my experience. Unfortunately, we don't have a lot of time to share a lot of important cases, but perhaps another time, and you are welcome to come to visit us at Casablanca. And no, it's a great experience, and it's not so easy to do. It's the first live surgery from our clinic, and we are very proud for the team who is with us. And thank you very much for your invitation, and thanks very much for our team.
Dr. Abdurrahman,
thank you so much.
Dr. Rahman, I am Hatem Ammar, Egypt. I never did smile, but after your presentation, I really love the smile. I find it easy, and I will change my mind to do smile. Very elegant surgery.
And by the way, the Moroccan ophthalmologist is highly representative here in the meeting, and to have also a live surgery, this is a very strong power for Morocco in the MEOM. Thank you so much, and we hope to have you again. Priya and Dr. Nilsh from India. Thank you so much, Priya and Dr. Nilsh. Please say some words to us.
Thank you very much, sir. Yes, sir.
Priya, we cannot hear you, Priya. We cannot hear you.
Can you hear me now?
Yes.
Can you hear me?
Yeah.
Okay. Thank you so much for this wonderful opportunity. We had a great time doing live surgery here, and Dr. Nilesh, he's still completing the case, which is almost done.
Yes, we can see it, yes.
Yes. So thank you so much for this wonderful thing. It was really fun doing all this thing.
Thank you, Priya.
Dr. Nilesh, you want to say something?
Yes.
Yeah. Thank you.
Thank you.
Berea, thank you. You are always the masters of complicated cataract surgery in India. Thank you. Very difficult, very tough cases, and pass smoothly. Thank you.
Dr. Nilsh, thank you so much for being for the first time with us. And really, we appreciate your surgery and also your patency for the new trifocal IOL, three-piece IOL. I think it will be going to make a change to have a preloaded trifocal three-piece IOL. It's different.
Yes, sir. Yes.
3 pieces, yes. Thank you so much. So thanks for everyone that attended our live surgery today from 3 centers from the world: India, Italy, and Morocco. Thanks. And we are going to continue for the next session. Thank you so much. And thanks for all the panel and the moderator for this our session. Thank you so much.
لا ما ينفعش بس لو يعني It's okay. 30 minutes dealing. 30 minutes. It's okay, Dr. We know this live surgeries cannot be controlled. Good afternoon. I would like to welcome all you for our next sessions, which is uveitis sessions. And this is assigned to have to answer certain questions. What can be done differently? We will show you some cases. I'm Hassan Al-Dibi, the moderator of these sessions, and I have Dr. Kohel Fahad and Julia, and even though Dr. Salam with us. So I would like to call the panelists to be here in the stage, and we'll start with Dr. Fahad Kohel with the first cases. Dr. Kohel.
Again, I'd like to thank the MEOM organizers for kindly inviting me to share some cases with you. So I've only got 6 minutes, so can I kind of get to the point? I'm going to share 2 cases where the patients have done well, they haven't had a bad outcome, but basically I think I should have been more aggressive sooner. And hopefully you'll see what I mean in a moment. So this is a 28-year-old female who noticed wavy lines in the vision of the right eye a day earlier. She's myopic, fit and well, family history of glaucoma. And as you can see on the right-hand side, you've got this subretinal change associated with these very focal areas of elevation at the level of the RPE. And you can see this single white spot, again at the level of the RPE in the left eye. OCT shows a subretinal hyperreflective material in the right eye. Left eye looks to be normal. And then fluorescein angiography confirms that we're dealing with a choroidal neovascular membrane. And in the left eye, there's this single dot, again, at the level of the retinal pigment epithelium that's hyperfluorescent and is hypofluorescent initially on ICG and then becomes hyperfluorescent in the late stages. I noticed that, but I ignored it. I was focused mainly on the right eye, the eye that had reduced vision, and that was my main focus. And I didn't pay attention to the changes in the left eye. So the diagnosis basically is choroidal neovascularization, secondary to punctate inner choroidopathy. So I treated the right eye as a myopic CMV, and I gave the patient Lucentis 3 times, but I didn't address the underlying inflammatory problem. I just ignored that lesion, very juxtafoveal. So she did very well, vision 6/7.5 in the right eye, 6/6 in the left eye. That was 3 months later. Doing well, but again, I'm just treating the CMV, not addressing the inflammatory aspect of the disease. She comes back a few months later with a reactivation. I give another 2 injections, stable for 6 months. And then she comes to casualty about 9 months to a year after the initial presentation, complaining of a new blind spot in her left eye. So I requested infrared reflectance, and now you can see there's a foveal spot, a foveal lesion. Whereas before, there was just a juxtafoveal lesion. So I treated that with a subtenon's injection. And then ultimately, we started her on azathioprine with steroid. However, I wish I had done things differently and had considered systemic immunosuppression earlier, even if it was azathioprine with a little bit of steroid, and avoided that new area of foveal inflammation. Now, she's done very well 5 years down the line. However, she is at risk now in that left eye of potentially a foveal choroidal neovascular membrane. And I feel personally that I kind of let her down by ignoring what was in front of my eyes. And then the second case, 25-year-old boy with learning difficulties, presents to the medical retina department with 4-week history of gradual vision loss in the right eye. Vision is 160, 6.5 in the left. And as you can see on the color fundus photograph, he has this area of macular atrophy with widespread photoreceptor atrophy on OCT. This was his right eye, so it was center involving, which is why it was blind. But in the left eye, he has a juxtafoveal area of geographic atrophy. So the diagnosis was sepiginous choroiditis. His quantiferin was normal. I started him on 60 milligrams of prednisolone with gastric and bone protection. I already started him on mycophenolate because I anticipated this was going to be chronic and I need to have long-term treatment. And I reviewed him a week later, so I was keeping him under close review. This was his OCT a week later. Vision is 6.5. So what do? I reduce his steroid by 10 milligrams from 60 to 50. So still on high dose treatment. And the geographic atrophy lesion extends within a week. I think, sorry for my exaggerated expression, but I fell off my chair, really worried, because now I have a young man with learning disabilities already blind in one eye, 6/5 vision in the other eye, and because I basically not messed up, but because of not treating the diagnosis or the condition aggressively, potentially this geographic atrophy lesion can progress, and just by the grace of God, it extended temporally, not superiorly, to involve the fovea. So what do I do next? I realized I had to be aggressive. So he has 2 pulsed intravenous methylprednisolone. I give him an Ozurdex injection in the left eye, and I immediately escalate his mycophenolate to 3 grams per day. Eventually, we settled down back to 2 grams a day. However, to this day, I don't know why I wasn't aggressive from day one. And I think sometimes, as a uveitis specialist, I think when you recognize that there's that potential for sight loss, you just need to be aggressive and not rest on your laurels. Yes, I was able to maintain this patient's vision 6/5, 5 years later. However, 2 years later. However, it could have gone the wrong way, and I may not have been able to rescue the situation purely because I was resting on my laurels and not vigilant and not aggressive when I needed to be. And I was basically complacent. Thank you for your attention.
Thank you, Dr. Faith. Great cases, but because of the times that might be, we'll let the question to the end. It's my turn to present my cases and looking for you what can be done differently. So the first case is 42-year-old Saudi origin lady presented with gradual decreased visions in her left eye over the last 1 month associated with photophobia, pain, headache, flu-like symptoms. Also, she noticed blurriness in her right eye. Systemically, she was almost healthy lady, except for headache for 1 week durations, and she had a gift history of that. She's having cat in her backyard. Otherwise, past occur history were negative. Her vision in the right eye 20/20 and left eye is 20/200. The pressure was normal. Anterior chamber in the right eyes 1 blood cells and left eye 2 blood cells. Dilated fundus exams of the right eye show these lesions having superior temporal, deep lesions to the retina that choroidal mass-like with oxidative retinal that surrounding that area. In her left eye, you see that there is disc swelling, and there is same lesions at the inferior arcades with subretinal fluid. So this is, 42-year-old, suddenly having all these things together. So what can I do? So I started slowly that I get my investigation. This is her autofluorescent, and noted that there is an faint hyperfluorescent, autofluorescent at the lesions, superior temporal, and even though with area of the subretinal fluid. In both eyes, as you see very clearly, hyperfluorescent. So fluorescent angiography done show just only faint hyperfluorescent at the area of the lesions, and then with fluorescent just wool underneath the elevated retina in both eyes. Her ICG as well done. The other eye just only. Her OCT showed that large choroidal lesions with subretinal fluid at that area, and that's making us better more and more. The left eye at the disc just inferior, we see the subretinal fluid and the lesion involved even though the retina. So the diagnosis at this area was too difficult, so we did an ICG and showed there is multiple, hypofluorescent in both eyes, as the case of, choroidal granulomas. So what will be our differential diagnosis this time? TB is common in our areas, followed by sarcoidosis, cat scratch could be, but it's not the top of the list, and possibility of metastasis. It could be other situation. Worth to mention that as well, the patient in the second day after examinations, her vision in the left eye dropped to counting fingers. So it is very difficult here to what you will do. So let us to see what we say. This is the investigations. During that time, it's taking time, but we did our most important BBD test with quantiferon, liver function test. So all of these results came negative. So because quantiferon taking some time, we're starting the patient on INH 300 milligram until we get the result, and we started in oral steroid 50 milligram. See what's happened? After 3 weeks, the vision regained to 20/20 in both eyes with the resolutions of all this granuloma. This is the first case, so let me to ask the question, what can be done differently if this is your case? Do you agree with me to do what I did, or you have to do something different? Maybe I will ask my panelist here, Dr. Fahad.
I think this was really well managed, actually. It resolved very, very quickly. I think it's not criticism. It's just sometimes as uveitis specialists, it's about knowing when to be aggressive and to be prompt with the treatment. And I think had you done that, you may have avoided that cam fingers drop. But otherwise, she responded very well and she settled and a really good result. Thank you for sharing this case.
Do you would like to start at this patient in IV methylprednisone if you are in doubt? IV methylprednisone, pulse therapy?
For TB, you mean?
Yeah. I'm starting in IS as a prophylactic and started my oral steroid. But if you are in place, you will start IV methylprednisone, venously, intravenous?
You know what? That's a good point. The problem with IV methylpred, as you know, if you have untreated TB, it can lead to miliary TB. So I would definitely give oral steroid. But if I'm suspecting TB, get infectious disease to see quickly, and then get their guidance. And if I feel I need to be more aggressive, and they give me the confidence to be, then I have had a few cases of serpiginous, serpiginous, where I've had to give intravenous methylpred, but I've had the blessing of my infectious diseases specialist.
Do you always start together the antibiotics for TB plus the corticosteroid, or you wait at least 1 week?
I started from the first day of admission in INH because I'm not sure, because the history is not suggestive of tuberculosis. CT scan was okay of the fundus. The BBD was negative. I was just waiting only for the quantiferon, which I started INH. Once I get that results, I stopped INH and continued with the steroid. That's what
just for the audience, in most cases of ocular TB, there's no pulmonary TB.
Yes.
We have only the ocular involvement.
But at least we do our best to make sure that we don't have any type of latent, but because of these masses, still you are in doubt of TB is almost being there. So we started, and things are getting nicely towards the resolution of this granuloma. The second case, because of the times, 50-year-old, referred with suspicious of ciliary body tumor, right eye. The post-ocular surgery was unremarkable, review of system as well normal. The patient was in topical and oral steroids. So the vision in the right eye, let me just only to start back. Where am I? Can I get back, please, to my presentations? It's okay. There is something wrong, my friend. This will be short case. It's not working, my friend. Yeah, thank you. Yeah, so this is 50-year-old, referred with suspicious ciliary body. The ocular examination, as you see, there is congested, conjunctiva. With the gonioscopy showed that there is, lesions in the angle. Anterior segment show moderate conjunctival injections, and the anterior chamber showed 1 blastulus with peripheral anterior cycnia and peripheral synecia. Iris showed that some nodules, if you look just only to the nasal part of the pupil, that there is copy nodules, and as well in the same cataract. The left fundus exam of this patient saw this picture with the vitritis, hazy view with inferior temporal mass. Fluorescein angiography showed only hyperfluorescent with little bit diffuse choroidal leakage. The UPM, the ultrasound by microscopic, of the cellular body, show there is a small mass at the angle that measuring 6 by 3.4 and 4 millimeter lesions. And examination, that lab investigation of this patient turned it to be normal. No, that possibility of infectious, especially tuberculosis or syphilis. The AC was high with normal lysozymes. So the patient were treated with the, oh my God. The patient treated with the oral prednisone and topical steroid, and after that we get, yes, after that the patient, mass resolve, as you see in the UBM in your right hand, and the fundus view that all the vitreitis were cleared and the retina getting nicely flattened, and even though the mass will disappear from the inferotemporal area. So sometimes when you are in these situations, it's too difficult to go to which directions. The most important to work this patient to rule out the possibility of infectious causes, especially tuberculosis in our area, syphilis nowadays starting to be, and make sure that there is any areas possibility of metastasis. So we did that, and we treat the patient to directions of possible sarcoidosis, although that we have all the investigation, not go that except, the angiotensin converting enzyme. With this, I would like to thank you, and if you have any different thought about the case, you can tell us, please. Dr. Julia?
Good afternoon. Thank you so much for having me here today. So what could I have done differently? I have very simple cases. I hope you can do better than me. This is the first one. This is a 27 years old male who came because of red eyes only. And the only important personal history is that he's suffering from hidradenitis suppurativa, and he is on adalimumab, okay? 40 milligrams every 2 weeks. His vision is 20/20, uncorrected. He does not wear contact lenses. Intraocular pressure is normal in both eyes. And he came because of redness in the right eye and severe photophobia. And as you can see here, this is the right eye. There is injection, there is an area of superior panus, and very little corneal lesions, multifocal lesions, that are over the cornea, and few of them at the limbus. Here you have a better view of the lesions. They take the fluorescein in a very hazy pattern. The epithelium over the lesion is intact. They are located in the anterior stroma. There is a clear margin between the lesions and the limbus, and there is corneal neovascularization. So this is the definition, the description of immune infiltrates. So immune infiltrates, a young patient, no meibomian gland disease, no contact lenses, and hidradenitis suppurativa. And as you know, there are corneal problems associated with his main diagnosis, like most of the cases reported, which are not a lot, they have anterior uveitis he didn't have, but interstitial keratitis, bilateral flictenular keratoconjunctivitis, and even peripheral ulcerative keratitis were described in the context of hidradenitis suppurativa, but he is under treatment with adalimumab. Anyhow, I suspected this presentation was related to his underlying diagnosis, and I started him on lubricants, tapering dose of topical Lotemax, loteprednol, and I started topical cyclosporin twice per day. He improved, he did better, but when he received his next dose of adalimumab around 3 to 4 days after, he called me. He said, I am having the problem again. And he came back, and now the lesions were in both eyes, even though he were under treatment. Again, these are peripheral corneal infiltrates. So what should I have suspected here is a case of immune complex deposition. So type 3 hypersensitivity reaction. And this patient is using adalimumab. So I asked him, how are you doing with the adalimumab? Well, I don't know, maybe they will change the medication, maybe I am not responding so well. So I tested him for antibodies against adalimumab, and he tested positive and in high number. So he was switched from his dermatologist to secukinumab because of a lack of response, and actually this is how the eyes are doing only by discontinuation of adalimumab. Now the patient is on preservative-free artificial tears only, and there is only one case reported in the literature about systemic adalimumab induction of peripheral corneal infiltrate. So what could I have done differently? Well, when he came to me, I did not think about the possibility of anti-TNF alpha generating adverse inflammatory reactions, although they are very well described. Any questions? Okay, so let's move to the next one, please.
I just have one question. So obviously you've got that case report, now you've got your case as well. Have you come across another case like that, or is that the one?
This is my first one. Yeah, this is my first one. Well, I should report.
But thank you for sharing. I think you should report it, yes.
I know. So the second case is a 47-year-old male, otherwise he's healthy, everything is fine, came to the hospital for second opinion on ocular hypertension. This is his visual acuity, very low vision, 2400 and 2200. His intraocular pressure is under control on 3 topical medications in the right eye, but out of control in the left eye. He's pseudophakic. He has multifocal implants in both eyes, and at the posterior segment, the only positive finding is epiretinal membrane. So this is the baseline OCT disc and the visual fields. You can see the visual fields in the left eye is kind of advanced damage. So the doctor decided to go for the diagnosis of primary open-angle glaucoma and did an urgent trabeculectomy with mitomycin C for the left eye. Everything went well, the pressure decreased, but there was inflammation when he came back for his post-op visit. And that's why I got involved with him. And this is how difficult it was for me to see the fundus. There was some vitritis, the cornea was clear, the implant was clear, and of course he had epiretinal membranes, but he has diffuse generalized macular atrophy. Okay? So when I saw the patient and I was asked to see him because of the cells, I asked for a fluorescein angiography, and I'm very sorry because the quality is not the best, but you can see ischemia in the retina, you can see small vessels vasculitis with capilloropathy, and little bit of macular edema in the left eye. My first questions to the patients was, did you ever suffer from red eyes before? And he said, yes, many episodes of red eyes, decreased vision, eye pain, positive oral ulcers, positive history of genital ulcers, and when I tested him for HLA-B51, he was positive. So this is a case of Behçet disease. So unfortunately, the situation is already very advanced, and although now he is under systemic immunosuppression, I am not able to restore his vision. But my questions, what could have been done differently? And I have like a list of questions here. First of all, the patient was 47 years old and he was pseudophakic. No one asked him why you got cataract at young age. Second, why to put a multifocal implant if the vision is bad, if the eye is not healthy? And then why to label a patient as primary open-angle glaucoma until we have ruled out many other things. And if you see the visual fields, and it's a pity I cannot go back, there is a big discrepancy between the damage to the optic nerve, because the damage to the optic nerve was initial damage for glaucoma, and the very advanced visual field testing. So probably this is mostly related to widespread ischemia of the retina. Thank you so much if you have questions.
next speaker with us is Dr. Ahmed Salam. I'm trying to contact him. He's, I think so, in the other room. I saw him. I tried to contact him, but I couldn't. Could you look for him, please? He's in the other room. Thank you, Dr. Julia. In these cases, usually in Bahjat disease, who is presented with unilateral, disease, sometimes it's misleading, and the patient when having such, high IOP, cataract, and seen by non-uveitis specialists, usually they are never think about the possibility of associations with uveitis systemic disease. So most of the time, that's, there's the surgery could be done nicely, very well organized. But as the patient not diagnosed to have this, usually everything is getting as like volcano after the surgery. So the patient, instead of already being compromised, he will be lost. And this is, I noticed, in most of the, general practice and private, that the patient's coming and they put, as you said, multifocal IOLs, and this is making the situation is even though more worse. So I would like to have this message.
So he's not complaining about his multifocal IOLs because he cannot see. He's legally blind, and he went for glaucoma surgery without systemic corticosteroids. So his post-op was not so easy. And of course, the inflammation was more after the surgery, but I am sure the inflammation was present before, or there were inflammatory sequelas that they were there. They were very easy to see.
Usually when I have young patients that presented with cataract or high, usually I have a lot of questions to put it in mind and to answer it. 1, 2, 3. When I exclude all the things, then might be all proceed. This is the way that usually when I have someone not expecting to have that cataract and operating without, I saw children, that came with, GIA and being operated without taking any precautions because no one thinking that about recessive GIA.
We lost an opportunity with this patient. He is on systemic azathioprine because, of course, Behçet can affect the central nervous system, can have many other implications, but one of the major implications is already done. Although he's so grateful, every time he comes, he says to me, since I am on treatment, I am much better. So in a way, he feels better, and I think this is the result of the ongoing chronic inflammation he was living with.
But I think the second case was excellent, and I liked your point about primary open-angle glaucoma being a diagnosis of exclusion. So in my previous job back in the UK in Sheffield, numerous post-surgical inflammations were following glaucoma surgery, and it's because my glaucoma colleagues hadn't done a dilated fundus assessment, hadn't done a gonioscopy, hadn't even contemplated that this raised intraocular pressure could be due to uveitis. So I really hope that if you ever get an opportunity to present a case at a glaucoma meeting, I think this is a good one. Just, before you enter into surgery.
It's touching many sensitivities. This is primary open. I mean, IDAPT, the angle is open.
Yeah, but still, I think, or certainly learn lessons. For example, I've had patients after cataract surgery getting a lot of inflammation, and then I did a fluorescein angiogram, and then you identify they have a very low-grade retinovasculitis that you hadn't anticipated and didn't identify clinically.
Yeah, Professor Ahmed now is here.
Yes, I'm so sorry for being late. I was in the wet lab. Dr. Amri instructed me to stay there.
Yeah. As usual.
Hello, everyone. Chairperson. I'll present the first case. It's actually a very unique case. A 40-year-old North African male came with decreased vision in the right eye for 2 years. Vision is 20/80 in the right eye, and the left eye is 20/20. Story is that he had a problem with this eye 10 years back, and there was a peripheral retinal lesion that was seen in this eye, but they never knew what it was. And anti-segment is fine, and this is the posterior segment of the right eye. I mean, it's difficult to see the picture because of the light, but there's some macular, thank you so much. There's a macular lesion there, as you can see. It's cool, yeah. And then the left eye looks very normal, at least here. And then this is the peripheral part of the right eye that was seen 10 years back. And they were never sure what's this lesion. And he had decreased vision after that. So this is the fundus autofluorescence of the right eye. And that's the fundus autofluorescence of the left eye. So there's something there. And then the right eye OCT here was the near infrared picture. And the left eye OCT was the near infrared picture. So very subtle changes. The left eye, which is he's not aware of, is 20/20 vision. And that's the fluorescein angiogram and the ICG. And then here, similar right eye. And then subtle features here in the left, a little bit of leakage on the fluorescein, very subtle. And then late pictures here on the left. So there's something also happening with the left eye. And then this is the peripheral lesion in the right eye. It was really just some staining here and areas of hyperfluorescence from blockage from the pigments. So the question is, he has this placoid lesion in the macula. So what's the differential diagnosis? And here's a list of the differential diagnoses. So always we think inflammation, infection, masquerade in any uveitis. So we'll eliminate things that are unlikely because of how the disease is phenotypically presenting. So I'll take those off. So we're left here with sarcoidosis and undifferentiated, and here syphilis and TB, and then here as well was maybe a lymphoma. So syphilis is an important one. So anti-treponemal antibodies came back positive, and RPR was high. He actually ended up being HIV. There's history of men having sex with men with second time questioning, and his CD4 count was low. Very interesting, that was his skin biopsy 10 years back. We were able to get the skin biopsy, and we were able to test it at this time for immunoreactivity, and we found actually a treponemal here. So this is actually a technology that was not present 10 years back. So we were able to get the sample and test it again. And that really was very unique in this case. And then, so the diagnosed syphilitic choroiditonitis, and we treated him with penicillin. At that time, that was in the UK, they used intramuscular penicillin and steroids. And he did really very well. So that's the first case.
Thank you, Ahmed.
Thank you.
Good case and excellent that no one can think about it in that way. But always we say that rule out possibility of infections. All the times, all the times. I had the same things that 2 cases that presented with the choroidal mass, 2 patients, young patient. And after ruling out the TB and syphilis, we're starting our straightforward treatment, and every one of them will respond very well. So always we do like that. Questions? Dr. Kahel, Dr.
No, just good on you, because most of us would have looked at that and said, it's all burnt out, things are inactive. What kind of spurred you to kind of investigate it further? Was he symptomatic in his good eye? Was that the, so
I think
that pushed
the pattern,
you to do more?
I mean, the more you see, you become used to the patterns of syphilis. One of the placoid lesion in the macula is a characteristic pattern. Another pattern is the RP-like retinitis pigmentosa-like lesion in the periphery. Again, he has that. That's another pattern as well. Well, there are other patterns as well. And always, as Dr. Hassan is saying, you need to suspect syphilis and rule that out because it can present in different patterns.
I saw that the OCT, the right eye is having some sort of subtle, down, hyper, foci indulations like. And might be this is the pathognomonic for syphilis. Dr. Kahel, you presented the case, I believe it is big case.
Yeah.
That one in the beginning was presented with, CMV, and you treated with anti-VEGF because of these cases. Usually the vitreous is not involved too much. And thinking this could be myopic, choroidal neovascular membranes. And you discover the lesion in the other.
And the thing for me was just that you not paying attention. I noticed it. I even wrote the diagnosis PIC, but didn't do anything about it. Just managed the worse eye. Kind of very keen to get that rehabilitated, but it's just something. Sometimes take a step back. You've got a foveal or juxtafoveal inflammatory lesion. She's young. She's already lost vision in one eye due to CMV. What is the harm? I feel the risk-benefit of being on immunosuppression would favor immunosuppression. And had I done that, I may have avoided that second lesion. Yes, she has done very well, but who knows, in 10, 12 years, she may still, that fellow eye may still become complicated by CMV because I think that when, you cannot control everything, but you have to try your best.
Would you advise to do ICG in these cases from the beginning?
Fahd, can you explain maybe to the audience what we're talking about? I think you're talking about a PIC case, right?
Yes, so it's my, so it's the first presentation.
You're
So it's the
talking
first
about PIC case.
presentation.
Almost
so
we are the last one, and we are talking.
It was punctate intracorridopathy, and I did a fluorescein and ICG at baseline. I basically treated her CMV in the right eye, identified this choroidal lesion in the left eye, but didn't do anything about it. Didn't think, should I do systemic immunosuppression? Just treated the right eye with Lucentis. She then comes in 9 months later, developing a new lesion in the left eye, but this is now foveal. And although I've been able to rescue it with subtenon steroids, and then subsequently with azathioprine and a bit of steroid, and 5 years later, that left eye hasn't been complicated. It's, she's still 28. She has another 30, 40, 50 years of life, and potentially she may still get on and develop a choroidal neovascular membrane. And it's just, what could I have done differently? Treating both eyes, focusing with the right eye with the Lucentis, but not ignoring that there's an inflammatory component to this patient's condition.
I agree with your management for systemic treatment. Inflammatory choroidal neovascularization should be ideally managed with systemic immunosuppression. But do you think there's any role in this case for intravitreal dexamethasone implant?
I would probably consider it if there was morbidity in that patient. So there was either pregnancy or there was a reason why I would want to give it. Otherwise, they're young. I'd much prefer avoid, even though the risk of cataract is small, I would often go for systemic treatment.
Yeah, regarding to the possibility of using this, immunosuppressive medication, it wasn't proof 100% that will prevent, the involvement of the other eye. But myself, from my experience, I found that's very effective, especially when there is one eye already being, getting the subfoveal, subretinal fibrosis at the fovea, and usually I'm treating myself before treating my patients, so I put them in immunosuppressive medication. This is young ladies usually, and they have in productive age, they won't like to get, so I keep them even though in Imuran, which is safely can be given during pregnancy.
And just very, very quickly, just from experience, these cases come like buses or coaches, one after the other. So then a few months later, I had another patient, young female, CMV in the right eye, no observable lesion in the left eye, but on fluorescein angiography, ICG, you identify the choroidal lesions. I'd learned my mistake once, I didn't get burnt twice, and I started on systemic immunosuppression because I determined that, to not have the same fate in her, because the right eye was blinded by her punctate intracorridopathy. It's quite a cruel disease, and affects females unfairly, and young females unfairly. But I think you've just got to be aggressive to do the best for these patients.
Dr. Ahmed, would you like to do something different?
No, I think there's mixed evidence whether systemic immunosuppression does work in PIC or not. So there are studies that saying it does work, and there are other studies that saying it does not work. I think if a patient is having recurrent PIC and it's affecting or threatening the macula, I think it's sensible to go for immunosuppression. The other point which Fahd has beautifully illustrated, the most important is treat the CNV when it happens, and that needs anti-VEGF as well. But just, something to know about this mixed evidence, but people, if there's visual threat, will probably immunosuppress. Should I go for the second case? Or?
Yeah, can you go?
Yes. Okay, well, this is an interesting case, a 14-year-old Caucasian kid that was referred from the optometrist because of suspected optic nerve swelling. Severe headaches over 2 weeks, and black spot in the visual field in the right eye, and also vomiting. Myopia, a little bit of myopia, denies anything else, and there's nothing else in the history. So visual acuity is 20/25. and color vision is just slightly down in the right eye. And antechamber inflammation in the right eye, 2+ cells there, a bit of trace in the left. The vitreous is more or less clear, and that's the fundus picture here in the right eye and in the left eye. The nerve is indeed swollen. There's something happening there which will show better on here, the autofluorescence and the fluorescein angiogram. So this is the fluorescein angiogram, and then here, this is the next frames. And you can see we started with hypofluorescence going into hyperfluorescence with some leakage from the disc. And here as well, the left eye, and something happening here with the left eye, so there are lesions as well, but less intense. And then ICG, which is nice from the right, and the poor quality ICG on the left here. You cannot tell much really what's happening. So the question on here is getting better, so there are lesions on the left as well. And that's the OCT on the right and the OCT on the left. So again, uveitis is easy, same differential diagnosis, right? Even same slide. So which one, any thoughts from the audience? From the floor? Yeah. Which one of those?
Young boy.
So yeah, so again, you want to exclude syphilis and TB. TB is unlikely, it's an unlikely presentation, syphilis, but it's a kid and the history does not go. So then if you go through here, then most likely this is MP. So that was the working diagnosis, MP. And he had a lumbar puncture before us seeing him, and that was slightly high, but with some lymphocytes, but nothing else. And then he had MRI and MRV, that's again before seeing him, because there was suspicion of papilledema. And the diagnosis was MP, and then he was started on intravenous solumadrol and anterior chamber, and topical drops. He had also MRA to exclude cerebral vasculitis, especially that he had the headache. Shouldn't he have had headache, we would not do an MRA on him. And the MRA was fine, and then we discharged him on prednisone, tapered down, he did very well, improved, and we stopped. But 6 weeks, and 6 weeks after follow-up, everything was fine, everything resolved, and then we stopped the treatment. And then he returned back 8 weeks after, at that time he was on 10 milligram prednisone, and he returned back with another recurrence. So these are the new pictures, and if you compare here, this is at presentation, right and left. This is when he resolved, and then it came back. So when it comes back, then you need to revise the diagnosis, especially that MP is meant not to come back. But then we have a solution for this. If it comes back, then we call the MP amphigenous. So now we called him amphigenous, and we went to immunosuppression with methotrexate. And he read it so well, and he recovered very nicely, as you can see here. There's always something there in the visual field, but he has done so nicely. And we kept him on the methotrexate for 2 years, and we just weaned him off recently. So again, MP versus amphigenous. If it's recurrent, if it's very progressive, we call it amphigenous. I just want you to know that, again, a similar picture in another patient here, but more localized. And you can see here the lesions, and we were thinking that this patient had MP, but then when, and he had extensive areas of void flow here on the OCTA, from the choriocapillaris, but when we tested him, he tested positive for syphilis. So syphilis can give you the same appearance, so you have to be careful. And that patient, the second case I was showing you, actually had syphilis.
Yes, thank you. Ahmed. It's a great case, and usually confusing, making, I looked for such cases, for relentless types of placoid. And usually it's really an aggressive disease that ended by poor visions, multiple choroidal scars, and you are lucky and your patient is lucky that you caught them early. My question that regarding sarcoidosis, sarcoidosis, especially in this age, is presented with 5% of them with disc swelling and hypo, hypo. In ICG, there is a lot of granulomas as you show in your cases. So in such case, that you would aggressively work this patient as a sarcoidosis, because the lesions at the end when you treat, it's not having the same behavior of relentless ambi that ended with multiple scars.
Yeah, so my view on this, yes, this patient may end up being sarcoidosis, but it's not going to change anything.
Of course.
Because the treatment is the same, and even if he has sarcoidosis, unless he has a significant systemic chest issue, the pulmonologists even are not interested in seeing him. So I think what I try to do is I try to put the diagnosis in one of those three categories, either infection, inflammation, and masquerade. If it's inflammation and I know that it's sarcoid, then fantastic, I've done very good. If I don't know that it's sarcoid, then treatment is more or less the same.
I do agree.
That's how it is.
Yeah, there is a trend that, especially in the UK, because the incidence of relentless usually little bit in 20s, of the age, and they add there is high possibility of this patient might be need to have tuberculosis, and they add for them anti-TBs with the commitment, immunosuppressive medications, steroid and immunosuppressive medications. I'm asking these questions because this case is not usually to do with it.
I think what it is useful here for the diagnosis is the fluorescein angiography pattern, the block early, stain late pattern, that if you are in doubt with sarco, this will go more towards AMPI. But again, the treatment will not change. The prognosis might be changed, but not the treatment.
Any questions from the audience? If there is no more questions, I would like to thank you all for these great cases, and thanks to me. Thank you, bye. Can you put your airdrop on me?
Can we ask Dr. Hasna? Hasna. Hasna, because as a panelist, Dr. Murad, I think he's not here, and Dr. Hani Sakli. So let's start the session in the proper time. We are going to talk about clear the fog around the keratoconus. So it's a keratoconus session, and I think all the speakers are eminent in this field, so we are going to enjoy definitely. So the first talk is Formofrost keratoconus by Dr. Rashid Saadi, the head of the Oman Society of Ophthalmology. Please, Dr. Rashid.
Thank you. First, thank you, Dr. Ashraf and Dr. Muhammad Amri for this opportunity. Good afternoon, everybody. Today I'm going to talk about Formofrost keratoconus. It's very important topic, especially for the corneal surgeons. First, some introduction. The term Formofrost keratoconus was initially coined by Mark Amsler in 1938 in cases with slightly tilted Jaffa Myers. The term frosta is derived as a French word because we can say it in English, confused, crude, or unfinished. Frosta refers to an incomplete and abortive form of disease, in contrast to the concept of full-blown presentation. Robin Schmitz described Formofrost keratoconus as eyes with unremarkable biomicroscopy and no visual impairment, having good distance corrected visual acuity by glasses which present atypical keratoconus irregularity on the topographic mapping. But in 2009, Claes proposed that the term form keratoconus should also apply to the contralateral eyes. And this is very important for all refractive surgeons of keratoconus patients with no clinical finding of any sort. Rollman and co-workers also, they said no agreement about ectasia risk scoring system actually, although this disease also at risk. Recently, Henquist and co-worker performed a systematic literature review of KCS and Formofrost, and concluding that there is a significant lack of unified criteria. So there's no consensus on the current definition of the Formofrost keratoconus. But in 2015, a global consensus stated that keratoconus in bilateral disease is a bilateral disease, and that ectasia may occur unilaterally, as we know, due to purely biomechanical stress. Nevertheless, Formofrost keratoconus has been recognized as the most important risk factor for developing progressive ectasia after refractive surgery, refractive laser correction. So we can say high susceptibility for corneal biomechanical decompensation and ectasia progression. Here, if you see in this drawing, you see the Formofrost here in this area line. It's very difficult to diagnose those cases, especially in second eye and those young patients. And our test will show false negative most on the basis of the current screening methods. But and what we can find easily now diagnose suspected patient. But the new machine in the latest since 2 years, those machines they have also they also include OCT, anterior OCTs with artificial intelligence. They could diagnose those patients, but with difficulties. So if you go through literature, systematic review of subclinical keratoconus and Formofrost keratoconus, the review demonstrated that the lack of unified criteria. Later came comparison of morphological and biomechanical of keratoconus, Formofrost keratoconus, and no area. We can say even Ambrosio criteria could not define this also. But when the new machine, those they have OCT, the topograph with OCT, anterior OCTs, with somehow artificial intelligence, they have better combined anterior, posterior curvature variables, along with bachymetric data obtained from OCT, allow automated detection of early keratoconus and keratoconus with very good accuracy. Machine learning algorithm now helping a lot to detect those patients with Formofrost keratoconus. The rule of this one important paper recently published, rule of corneal epithelial mapping, Corfix biomechanical index, and artificial intelligence-based topographic biomechanical index in diagnosis spectrum of keratoconus showed that the utility of epithelial mapping as a solitary tool is limited to in detecting the spectrum of KC, especially in former FRST. However, combining with corneal biomechanical parameters could also improve the efficiency of diagnosis. So, as a message, while we contemplate the advances in multimodal corneal and refractive imaging into the multimodal domain, this is predictable that molecular biology and genetics will play a higher roles. For example, in characterization of keratoconus, considering the molecular and cellular change associated with pathogenesis of ectasia, including extracellular matrix degeneration and upregulation of degenerative enzyme, oxidative stress and inflammation may further enhance the ability for ectasia characterization. So to conclude, advances in corneal imaging with multimodal approach allow for augmenting sensitivity and specificity to identify those susceptible patients with former FRST keratoconus. Thank you very much. Welcome all in Muscat.
Dr. Rashid, does the biomarkers now going to change differentiate between the suspect and the former keratoconus? We can use the new biomarkers to find this region.
There's many studies now actually because this genetic also, especially in keratoconus, there's some many studies, they consider genetics and biomarkers. They're saying, but still it's actually not defined completely, fully. But there's a good science now to help the surgeon especially.
And the coming artificial intelligence keratoconus is already started and it's going to improve. Is this region, the hidden region, the suspect form FRST can be also early diagnosed through artificial intelligence? Because already keratoconus, we can diagnose it easily. But the suspect form FRST, it's not an easy issue.
Suspect sometimes easier now, especially for us in our clinic, we face this problem. We are using a lot of artificial intelligence in the machines. The reason why we are also recruiting the pilots. And the pilots in this age, if you don't discover them maybe after a few years, they become positive somehow, and then we have to stop them from flying, especially military pilots. So this is very important actually, this to concentrate not only for the refractive surgery, also for jobs-wise.
All right. Thank you, Dr. Rashid. Thank you. Thanks, Dr. Ashraf, for starting the session. Our next talk will be Dr. Mahmoud Ismail will be talking about updates in corneal cross-linking.
Bismillah ar-Rahman ar-Rahim. Once again, thanks for the MEOM Academy, Dr. Muhammad Al-Amri, and all the faculty for considering me for this nice meeting. Actually, we have been doing cross-linking for the last almost 20 years now, and it's well known that we have to deliver about 5.4 millijoule to address a cross-linking or to change the corneal parameters in cases of keratoconus diagnosed in phase 1. But this is not the rule. The rule is we have to follow guidelines of opacometry, not less than 400 microns. And you need the photosensitizer, and the real job is to bridge, to make bridging between the fibrils or the collagen to be more solid. And this is the whole idea about bridging. Sometimes you face cases with some difficulties. Like in a case like this, post-LASIK ectasia, and you discover that the patient's pachymetry does not fit in the criteria of the guidelines for our Dresden protocol for keratoconus cross-linking. So what to do? First, you don't do him cross-linking, and you address him to go for, let's say, rigid permeable contact lenses, or you can assist the cross-linking by contact lenses. You can do epi-on, which does not have any value. You can go for stromal hydration, which is tedious, and you can use the hypoosmolar riboflavin that sometimes we go for. But Elias Jarad have published a very interesting paper about how to induce fibrogenesis, which is the hallmark and the original idea of cross-link. He proclamates that the bonds can be done in cases of post-LASIK ectasia by puncturing the stroma somehow from the surface. He proposed the idea and he did some animal model and he prepared the cases, did 5 cases only in this study. And the idea was very temptative for me, and I addressed one of my students to take it as a master degree thesis in my university. And how to do it? Actually, you are creating bridges. You are puncturing the Bowman's membrane with 27 gauge needle under topical anesthesia, initiating the fibrogenesis, which is the hallmark of the idea of cross-linking. More or less, then you are addressing the ectatic portion of the keratoconus. And this is how it appears in the OCT, as if you are stapling the cornea with the flap with the stroma. And this is the idea of the punctures that we did for this patient. And this is how it looks. In the current moment, we are looking forward to apply it in a nomogram for femtolaser application, and this will be more or less regularized and normalized. Last but not least, I would like to invite you all to attend the next Congress for the Egyptian Society of Ophthalmology. It will be in April, 24th, 26th of April, and it coincides with the Western Eastern festivity, inshallah. Thank you very much.
Thank you. We will have a few questions, if you don't mind. First,
I'm sure that you will have.
Yes, I wouldn't start. I'll open it first for my colleagues in the panel. If anyone wants to comment, or I should start first. All right. Regarding the micropuncture, would you be concerned that this might create a channel for epithelial ingrowth? When you are creating it, when there is a flap, with the case you described, post-LASIK ectasia?
The puncture never creates epithelial ingrowth. You need a flap to create epithelial ingrowth. The puncture creates a microfibrogenesis getting from the submomen area. The Bowman once cut never heals except by fibrous tissue.
So you don't go too deep to reach the interface?
Yeah, you will just initiate a small puncture in the Bowman membrane, and the reaction is fibrogenesis, as you have seen in the OCT map.
Yeah. Okay.
We currently are publishing the paper now, and it will appear in next months in the Indian journal. We have sent it to the All India Journal of Ophthalmology.
Was there any changes in the topography?
Very slight, Yahani. It's not corresponding. Yani, the aim is to stabilize. Yani, the aim is to stabilize, but the change was not much, actually. And I was looking forward to see some more beautiful maps, more regularized maps after puncturing the stroma, but actually no, it didn't. Maybe when we do it with the femtosecond laser, the aim was to do it with femtosecond laser is to go beyond the Bowman and to create a full puncture through the Bowman membrane and to make a nomogram for it. Yani, as you can see, if it's 48 diopters with so and so pachymetry, you will get such. Yani, it needs more work. But this is the pilot study. تفضل Dr. Wasim. This is more than 1 year.
1 year, and just an idea, combining it with cross-linking?
I'm thinking about doing this.
Okay.
You have the advantage now that you are applying epi-on, almost epi-on, and with some tiny epithelial off. It might work that it penetrates more, and this is it might be helpful. Actually, this is a master thesis, Dr. Wasim. And the problem with the master thesis, it's in between the first part and the second part exam of the master thesis, the master degree in Egypt. So the candidate wants to finish it as soon as possible because he has another exam. It's just an entry code for the exam. يعني ده رقم الجلوس للحصول على دخول الامتحان second part. So he is eager to finish it as soon as possible. I am following the patient by myself now because he fulfilled what was his aim. Yeah. Ilyas Jarad himself, I talked to him, and he said I couldn't dare to make more patients. We'll see.
I think the idea of combining it might.
It was his idea actually. It's not mine idea.
All right. Any questions from my colleagues here?
Okay.
Thank you.
Thank you very much, sir.
Thank you. We'll move to our next talk, the role of ICR by Dr. Haikal Kammal.
Thank you very much. Once again, thank you very much, Dr. Ashraf, for the invitation and congratulations for this great Congress. So my talk today will be about the role of intracorneal ring segments. So as you already know, rings provide us with corneal flattening depending on thickness, diameter, and also length to better control astigmatism. Today, the exact topographic effect of this ring model is still not well defined, and some questions are asked. How much flattening is enough? Which flattening profile and how? This is two papers that I published 10 years ago in which we defined, as you see, the flattening profile of each ring model and how to select the appropriate intracorneal rings. And today our new philosophy is to adapt to each keratoconus form the perfect ring profile in order to personalize the treatment. In front of you, the morphological classification of keratoconus published by Dr. Alfonso in 2016. And as you can see, we have a symmetric phenotype, nipple, bow tie, and croissant, and asymmetric morphology like duck and snowman. And today, the best deal is to have a perfect matching between ring profile, ring flattening profile, and the ectasia shape. Here is the issue. Why? Because, as you know, refraction is not vision, but shape is vision. With a symmetric keratoconus, we have a good result with standard ring with 70% of satisfactory outcome. But with asymmetric keratoconus as duck and snowman, we have a low satisfactory outcome with symmetric keratoconus. So here we should propose asymmetric keratoconus. One of the major reasons of unsatisfactory result is in asymmetric keratoconus is the significant difference between the coma axis and the astigmatism axis. In front of you, a duck morphology. You have the steepest axis in red and the coma axis in white. So if you put the ring on the steepest axis, you will treat astigmatism but not coma aberrations. And if you put the ring on the coma axis, you will treat coma, but you will overcorrect the astigmatism. So this is the most difficult cases to treat. In this video, I will illustrate what I just said. You have a snowman. If you put a regular ring, you will correct the astigmatism, but not the coma. The difference between the inferior part and superior part is still here. So the solution is progressive ring in order to better flatten the cornea in the inferior part to better fit the shape. This is the new IGL progressive segment that I designed with IGL. And here you have a double progression in width and also in thickness to better flatten the inferior part of keratoconus. This is our first study published in 2021, and we found a very, very good refractive result. And the most important result is in a high order aberration that we found a really statistically good result. This is an example of DAC morphology treated with a standard ring, and as you can see, the astigmatism is treated but not the coma aberration, with a slight steepening in the inferior part. The second one, it's also a DAC morphology treated with progressive ring, and as you can see that we have a better homogeneous topography. So here we treated astigmatism and also coma aberrations. Here is the differential map of progressive ring, and as you can see, we have a flattening progression of 3 diopter more and less. This is the new IGL nomogram of progressive ring, considering the shape, the asphericity, and also coma aberrations. So I will summarize here the nomogram. So the choice of the rings depend on keratoconus shape, and in symmetric keratoconus you will use standard ring. In nipple we will use 320 degrees ring. In bow tie we will use 2 symmetric ring. In croissant like DMP you will use only 1 segment, and in asymmetric keratoconus as DAC and Snowman you should use progressive ring to have a better result. So 1 progressive ring in DAC morphology and 2 progressive ring in Snowman morphology. Some examples, you have here a DAC morphology treated with 6 millimeter progressive segment, and we have here a very good postoperative result. Another example of Snowman morphology treated with 2 progressive segments with also good topographic results. This is a post-LASIK ectasia with Snowman shape, treated also with 2 progressive segments, and you can see a good topographic results also. So in conclusion, the good prognosis for intracorneal ring segment is first the stage of keratoconus. Keratometry should be less than 55, pachymetry more than 450 to have a very good result. And also we should adapt ring profile to shape in order to customize the treatment. Symmetric keratoconus, symmetric ring for symmetric keratoconus, and asymmetric ring for asymmetric keratoconus. Thank you very much.
Thank you, Dr. Hakel. I know that you are expert in the ICR in our region since many years. Let me ask you, the progressive is 1 size or multiple size?
No, it's multiple size. We have 2 diameter, 5 and 6 millimeter, and 3 thickness in the inferior part. The superior part is always 150 micron thickness, and the inferior part we have 200, 250, and 300.
And if you are going to put the progressive, how you are measuring the depths of the ring of the cornea? Because it will be different
80% of the minimal thickness, okay. 80 to 70%.
The same as the regular ICR?
The same thing.
Okay, and you know that it's a progressive, a different thickness from the front to the beginning to, so during the insertion, you are going to do the tunnel through the femto. So the tunnel will be different inside.
We put the maximum of the width.
The maximum.
As the maximum.
So it will be a little bit wide in the small thickness?
Yes.
This will go to change the effect of the ring of the cornea? Because if it's tight, the effect will be more. If the tunnel is little bit wide, the effect of the flattening will be less. Or does not change.
I understand. Yeah. It's affects. Of course, it affects. Yes. Because when the channel is when we have more width of the channel, we have less effect. Okay. So, and now we need this thing, because in the superior part we will have less effect even with the width channel, and we will have more effect in the inferior part when the channel is tight.
Last question. You are saying the 6 millimeter and the 5 millimeter.
Yes.
According to how you are going to choose between the 5 and 6?
It depends on asphericity. When we have a high asphericity, we need to flatten the center of the cornea, so we choose 5 millimeter. And when the asphericity is low and when the keratoconus is in the periphery, we will go for 6 millimeter ring.
Thank you, Dr. Heka. It's a wonderful presentation, really. So we can move to the next presentation by Dr. Mohsen Bakkali. We are going to talk about wavefront customized surface ablation. Dr. Mohsen Bakkali, one of the eminent keratoconus surgeons in Morocco and our region also.
Bismillah ar-Rahman ar-Rahim. Thanks again, my dear Ashraf, and thanks to Dr. Al-Amri for this beautiful meeting. I would like to share you my experience regarding the management of keratoconus by combined cross-linking and wave-front guided photoablation. Over time, the management of keratoconus has been greatly influenced by the ocular imagery. As a result, some new approach emerged, like cross-linking combined to photoablation. It's sure that the arrival of cross-linking help us to stop the disease and to avoid or postpone the corneal graft, but it's still gap between satisfied doctor and unsatisfied patient, because the cross-linking can stop the disease but can't improve the acuity, the visual acuity. And a lot of our patient, young patient, the real life, in some cases like this young patient, even the disease is stabilized by cross-linking. The low vision caused by high order aberration, it's a big problem for those young patients. So the question is, how can we reach the goal to stabilize the disease and to improve the vision? The answer is yes. We can combine cross-linking with photoablation, and for the cornea, for the steepest area, we will make more, for the steepest area, we will work more flattened, and flattened area more steepest by combined cross-linking and photoablation. The first paper was published by two authors the same year, same country, Konopoulos and Kimiones, and it was innovative technique to combine photoablation by cross-linking procedure. The safe indication, in my opinion, it's as follows. It's progressive and moderate keratoconus. Low and moderate keratoconus, the Kmax should be lower than 55 diopters. The maximum of photoablation should never exceed 50 microns. The residual stroma with epithelium should more than 500 microns. And in some cases, we can discuss about, is there any indication for stable keratoconus? I think, yes, when the high order aberration caused low visual acuity. Our protocol unfolds in 6 steps. I will shortly detail step by step. The corneal screening is a crucial stage in this procedure. I think the corneal OCT is mandatory, and we have to assess the corneal, the epithelial mapping. In this case, it's most important place. And the aberrometry, it's also mandatory, but as you like, we can do aberrometry for advanced keratoconus. That's why this technique is only for low and moderate keratoconus. The second step, very important in this procedure, that's the pattern of photoablation is guided by wavefront. It's like artificial intelligence. It's not the surgeon who will choose the pattern, it's the machine who will help us and guide us for the protocol by combined zyoptic software. As we call this simulation, in these cases where the keratoconus is advanced, this software helps us, and the answer is patient out of range. I think it's very safe to be helped by the machine for choosing the protocol of photoablation. The other important tip in this procedure, instead doing epithelium ablation manually, which will offer irregular surface, since, as you know, the epithelium is irregular in keratoconus. If we remove the epithelium by spatula, we will leave a regular surface. If we remove the epithelium by laser, we will have smooth surface. Smooth surface, it's key of success of this technique. Then we will have wave-guided PLK, never more than 55 microns, and we work in smooth surface, and as I mentioned, the photoablation less than 55 microns. And the cross-linking, it's speed protocol, 9-10 minutes, followed by 10 minutes riboflavin. Widely used this technique, I know that's my friend Heikel, it's expert of corneal rings, but since we more diagnosis more for low and moderate keratoconus, over in the world, the need of corneal graft is decreased, and less intracorneal rings, and there is a real shift towards more photoablation combined with the photoablation with cross-linking. Some cases, and with follow-up about 1 year, we have decrease of high-order aberration, decrease of Kmax, and real improve of best corrected visual acuity. Even this technique is widely used since the first paper to 2007. Some debatable questions still persist, and we have to deal shortly about the current question. What about safety? It seems risky to photoablate corneal keratoconus, of course. But since we can secure our photoablation by doing cross-linking, because we have the certitude that the stiffness is at least increased 3 times. What about stability? Since the first paper, many papers report that there is a real stability regarding the best corrected visual acuity. There are 2 current questions. Shall we do same-day treatment or sequential treatment? I do same-day treatment as when it is possible, because we will win time, and cross-linking will be done in smooth surface, and we'll photoablate the cornea which not treated by cross-linking. When we do sequential treatment, there is no visual improvement after cross-linking, and we will photoablate cornea already treated by cross-linking, and it seems not logical to photoablate cornea when did cross-linking before. Another current question, what is the best choice, topo-guided or wave-guided? For my opinion, I prefer wave-guided because we will correct high-order aberration, but topo-guided we will correct low-order aberration. As you know, the low-order aberration we can correct by eyeglasses. We don't need laser for that. And in topo-guided, we take in account only anterior aberration, and the treatment is vertex-centered, and there is no eye tracker. In wave-guided, we correct the high-order aberration, and we are pupil-centered treatment. The eye tracker is very useful. So I think the new area of keratoconus management, there is a new chapter, and the future management of keratoconus, it's a refractive approach. By combining treatment, we can stabilize the keratoconus, reduce optical aberration, and improve the best corrected visual acuity. Thank you.
Thank you. I'll open the floor for question if anyone have any questions.
No, actually, our experience is with the topography guided, but I really like your concept here. We have published many articles about the combined topography guided with cross-linking, and I believe in the simultaneous procedures. Except sometimes we see patients, they underwent cross-linking in another place. Do you have any experience with these patients? How can you approach them? If they already did the cross-linking and still they have their topography very irregular.
When I have in some situation, I respect 6 months after cross-linking, and this is my approach. When I have very high level order aberration, I do cross-linking first, and eye weight. Because in advanced cases, we can do aberrometry, or aberrometry, it's not accurate, especially less than 55 microns. In some cases, we can do sequential treatment.
You do in the next phase only the topography-guided PRK or wavefront-guided PRK? Of course, I understand that the aberrometer will be very difficult. But if we do topography-guided PRK, you do it alone or you would repeat the cross-linking again? And would you use mitomycin if you are going to do only topography-guided PRK?
First, I never use mitomycin. This is a very nice paper published by Hafizi and Shadi Awad. Many highs when we use mitomycin. In this case, in my opinion, when we have the opportunity to be sure that you have accurate aberrometry, we have to go directly to aberrometer treatment. I think keratoconus disease, it's talking aberrometry, special aberrometry. It's not low sphere aberration. Our patient, the low visual acuity, the eyeglasses, we can correct the sphere, we can correct the cylinder. It's the low, the remaining low visual acuity, it's directly linked to high order aberration. So we have to target this.
And you repeat the cross-linking or only the...
I have the chance to have many OCT. If I do OCT, I have the chance to see the demarcation line, and I see it, I don't cross-linking again.
Thank you.
Thank you. Thank you.
Thank you.
We'll go to our next speaker. Dr. Marwan Abra. He will be talking about new effective technique of corneal LA.
Thank you for the invitation, and I'm happy to be between friends and colleagues. I would like to share with you my experience, which started in January 2019, working on Xenia. How does it work? Right, so what is Xenia? Xenia is a corneal implant. It's a medical device, and the lenticule is extracted from porcine tissue, which is subjective to decellularization process, intensely cross-linked and sterilized and packed. I'm going to escape the animation video for the sake of time. And this is our result. With the OCT, you can see the implant is implanted in the anterior 1/3 of the cornea, normally 130 micron from the surface of the cornea. I started my study in November 2019, and this is my result. With the discussion of the result, all my patients have improvement in the vision, increase in central corneal thickness, and most importantly, they are all off the waiting list for keratoplasty. Same time, Professor Al-Masri in Alexandria University, he was doing the same study, and he came with the same conclusion, and this is quoted from his publication. There was no statistically significant difference between preoperative and postoperative keratometry after 12 months, and there's no improvement in the high order abrasion. Having said that, the corneal thickness in the cornea get thicker, and consequently, he can do more cornea cross-linking. And this is the same. So why we are not getting excellent result? And the answer could maybe location of the Xenia implant is not in the right location, or we are weakening the cornea by doing femtosecond laser, which is already weak cornea, and we're cutting the collagen fiber across. So I decided to make a study, and the design of the study to overcome the two limitations of the original technique. I have 5 patients, aged between 13 and 35. All of them have cornea cross-linking over 1 year, apart from one patient. He had it 2 weeks before I implanting the Xenia. And the way I did it is create a pocket subject by manual pocket creation using guarded knife and corneal dissector. And at this particular study, I used the 3rd generation. We are on the 4th generation of lenticule, which is manufactured by Giebauer Medical. And the diameter of the lenticule is about 7.5 to 8 millimeter, and the thickness 44 micron plus minus 5. Could you play the video, please? This is how we receive the package and the container that contain the xenia, and we hydrate it before we starting the work on the cornea. I calibrate my diamond knife about 100 micron from descent membrane, and I make about 5 millimeter incision. And then I create the horizontal plane where I'm going to dissect the cornea. You have to be a bit careful when you reach the central part of the cornea. By the way, this patient is Kmax 82 and the elevation back 108 micron. Once you make sure there's a nice pocket, and I go all the way to 1 millimeter from the limbus. This is the fourth generation, and you can see in a minute the clarity of the material. Then I inserted it. And then flatten it and spread it and position it and center it by inserting BSS, so by squirting BSS above the surface of the lenticule. Then I put a bandage contact lens. Right, I'm going to share, I have all the 5 patients, I'm going to share a couple of patients. This patient is 21 years old boy and gentleman. His refractive error was -16, -4 at 170. Otherwise, he's fit and well. And you can see here the white line where the lenticule is positioned very close to the descent membrane. And this is the full refractive map pre and post. And the keratoconus staging, it was 3 to 4, now it's 1 to 2. And the high order abrasion, as you can see, it changed from -2.56 to 0.095, and the RMS from 16 to 6. And in summary, this patient Kmax was 68, post-op is 49, and there's improvement in astigmatism, in the elevation front, elevation back, and even in the high order abrasion, which is very important. This is my next patient. This is 13 years old boy. This is the one who had 2 weeks before implanting him the cornea cross-linking, and that his refraction -4.75, -7 diopter cylinder. And you can see also the same, the lenticule and the implant, how deep it is in the cornea. And the material, the clarity, this is slit lamp, is very good. And that's pre and post, the axial sagittal curvature, front and back. And you see the changes. The Kmax has changed massively from 54 to 45. Same apply for elevation, front and back. All parameters are back to normal measures. And this is the true net power, and the refraction dropped down from 50 to 37. And even the Pentacam machine does not recognize this patient as keratoconus as a surgical procedure on the cornea. And this is the follow-up. I don't rely much on auto-kerato, but this is just for addition. I mean, all the people that work for me, they do it. So you can see the change. Oh, sorry. From -475, become -1.5, the astigmatism dropped down from 750 to 250. In summary, this patient Kmax dropped from 54 to 45, and all parameter, even the wavefront improved. Third patient, we just go scroll quickly for sake of time. And you can see the location of the implant, the pre and post, and the staging of the keratoconus, and the sagittal curvature front and back, and elevation front and back. This is this lady. She have 70. Kmax was 77, dropped down to 48, and even the grading from 3 to 4 to 1 to 2, and all parameters are get much better. Same story. Now we go to. I put the two tables here to summarize my result, comparing the posterior to the anterior implant, and courtesy for Professor Al-Masri on the right-hand side, this is his result. The range of flattening of the cornea, the Kmax, it's about from 63 to 49. There is improvement in steep K, mean K, and flat Ks. So what next? We are working now on the size-wise, the curvature, the shape of the lenticule, and the centration, whether centration is better in relation to the center of the cone or the center of the cornea. So Xenia cornea implanting it into the posterior rather the anterior corneal stroma is beneficial because it serves to stiffen the posterior cornea in addition to the anterior cornea, which can be stiffened during separate cornea cross-linking procedure. The impact of cornea cross-linking and the Xenia device on the anterior and the posterior cornea respectively can work in combination to provide a greater improvement to corneal shape and consequently visual acuity. The pocket could be created using both femtosecond laser or manual delamination. I believe that the latter is preferable, as it separates the lamellae of the corneal fiber and thus preserve the corneal hysteresis. In summary, this technique, the modified, the company gave me the credit for this technique, so I name it. It improved the corneal thickness, it improved maximum the Kmax and improved the high order aberration and the disease staging and consequently improving the patient vision. In conclusion, the modified technique for Xenia implant may become the standard surgical treatment for keratoconus that comprehensively address the disease and its visual consequences. Thank you.
Thank you, Dr. Marwan, for this presentation and the new innovation. I have two questions.
Sure.
What this innovation adds, you know that before we were using the lenticule of the smile.
Sorry,
the smile lenticule to be put like this, and it gives good results also. So if we going to compare between this this way to put the lenticule smile from a natural cornea to Zen, what does Xenia going to add more for this?
Sure, that's a very important question. Xenia is decellularized. There's zero rejection, no reaction whatsoever. I did the study and we've been studying it. There's no reaction whatsoever. And there is, in the smile, you have the cells. In Xenia, you can control how much you want to cross-link it. So you can make it steeper, stiffer. You can play with it. With the smile is by a concave, I believe. It depends how you generate your lenticule. The clarity is fantastic, and I have no experience in the lenticule from smile, but so far this is the big advantage, and you don't have to give patient drops post-op apart from 1 week because there's no reaction.
Okay, just a question, and then Dr. Mahmoud and Dr. Bakali. There is another question. How is the long-term follow-up? Because this is like the ICR. In the long run, you can have some opacity around the ICR. So in the long follow-up of this lenticule, either you have the same opacity around or under the undersurface, and this will decrease definitely the contrast sensitivity and the visual acuity for the patient.
That's also another good question. The point is the follow-up for my patient now over 4 years, and we don't have this reaction. But having said that, the interface in the 4 to 6 weeks, so I don't refract the patient in the 4 to 6 weeks simply because it's not easy. There's interface between the two. I don't know what sort of mechanics happen later on. And the vision, it doesn't improve instantly. The patient feel there's improvement, but the best improvement after 4 to 6 weeks' time.
Okay. Dr. Mahmoud?
Nice presentation, Dr. Marwan. Excellent, actually. Of course, like Dr. Ashraf have said, we have all treated the patients with the SMILE lenticule. And of course, the gamma-radiated tissue. I had an experience with the gamma-radiated corneas in the old days, and the acceleration that happens. But why you are saying in that manual technique is better than the femto?
Right.
Why? Why are you saying so?
Simply because in the manual technique, you split the collagen fibers. With the femtosecond, when you depress the cornea, you cut collagen fibers, so you don't have delamination. You have cutting of the fibers. And this is the theory that me and Jean Marshall believe in it. Having said that, in 2 weeks' time, we're starting to do 15 patients with a femtosecond, deep femtosecond. We did the experiment on pig's eyes and cadaver's eyes, and now we're going to implement it on a human, and we compare the result between delamination and femtosecond cut. Having said that, everybody know the collagen density in the posterior part of the cornea is different.
I think.
But we have to have evidence base, and this is why we're comparing. We're going to do compare the result.
Yes. I don't think, Dr. Marwan, it's relation to the manual or the femto. It is the location of the game changer in your study was going deeper because the collagen type 4 is lacking there. So there is an inert part, because if you go back to your presentation, the first slides with the first cases that you did, the OCT image is horrible. So when you presented the last OCT, the new OCTs are very beautiful because there is no reaction, it's some kind of rejection for the implant.
Fully agree.
I think, Dr. Marwan, going deep is the game changer. And it was a very good idea of you to change the location of the lenticule. The idea is brilliant, actually.
Thank you very much. Because the point that drives me to think of it, everybody work on the anterior cornea, nothing on the posterior, so they might as well go down deep.
There is a question, Dr. Bakali.
Sure. 2 questions, please. If we have to do cross-linking later, what about the diffusion about UV through this material? Second question, suppose I think you don't have enough follow-up, we will to do cataract surgery later. But what about keratometry? Which index we will put? The cornea, it's 114. So in this cornea with the 2 material, which index of refraction?
That's a very good question. The point is, as I mentioned to you, I have 5 patients. 4 of them already cross-linked a year before. The 13-year-old boy cross-linked 2 weeks, so the effect of cornea cross-linking hasn't materialized. This guy, his vision is 615, unaided, corrected 612 plus 2. So I believe that we should put the Xenia implant before cornea cross-linking because we fix and lock the outcome of our implant, if you see what I mean. Now, regarding cornea cross-linking, all the material goes through it, even electrolyte fluid, and we don't have corneal edema. And we did the study on the epithelium and the changes in the epithelium. The change in the epithelium not related to Xenia blocking. The relation is because you change the shape of the cornea, so everybody know the epithelium thinner on the cone and thicker somewhere. Here, we reversed the image, so we found out later on that the epithelium thicker on the cone because the cone went down, if you can see from the previous slide. Regarding the cataract, I think so far, touch with, 6 months, and there's no significant changes in the keratometry. I believe the whole idea is like stabilizing it. It's like a table, the cornea sit on it, and later on, in about a month or 2, we're going to do, like you did, treatment with the laser to normalize the surface and consequently improve the vision of the patients.
Okay, thank you, Dr. Marwan. For the sake of the time, we are going to move To the next presentation. It's a very important presentation by Dr. Hasna Lamari, the General Secretary of La Samir, Morocco, the Cataract and Refractive Society. Is cross-linking always necessary in young patients? Please, Hasna.
Thank you, Ashraf. I am very happy to be here. It's a very nice congress. After some very nice and very complicated surgery, we return to something more simple. Cross-linking is a safe and efficient method to limit keratoconus evolution, and it's known actually for more than 1 decade. It's invasive surgery because it's more efficient if epi-off, and there is complication. We know that is a risk of worsening keratoconus in young people, but must we treat or wait to prove the evolution? The first case is one patient who I see him at 16 years old. He changed his ophthalmologist because the cross-linking for the first eye was complicated by corneal ulcer. The follow-up is more than 15 years old, and this is the topography of the first eye, and this is the topography of the other eye. He make topography every year, and we see that there is no evolution. The second case is patient 40 years old. He has bilateral keratoconus, and the patient refused the cross-linking because the economic reason. I lost him. He don't come to the consultation for 3 years, and after 3 years, he comes with his parents and say, "I want cross-linking." So this is the first topography, the right eye, the left eye, and this is the evolution between these 3 years, and we see there is no evolution in the right eye, even in the left eye. The third case is a patient who was 12 years old, bilateral keratoconus. This is the right eye, the left eye. We make cross-linking in the right eye, and it's complicated by very dense haze. I can't do the second eye, and we follow up without treatment, and we see that is no evolution in between the two for this patient. And the last one is a patient who was 15 years old. His uncle is ophthalmologist, and he has a bilateral keratoconus. This is the right eye, the left eye, and the family asked to not treat with regular follow-up. And this is his topography, and no evolution for the right eye, no evolution for the left eye. So there is a problem. If we have keratoconus in young people, must we treat it, or must we confirm the evolution before? We see the papers, and this is a very nice study. The first eye was treated, and the second eye was not treated with 5 years follow-up results. There is no change in the visual acuity and the thinness of the cornea in the non-treated eye in the 5 years. The follow-up of untreated eye demonstrated stability of keratoconus in both visual and topographic measurements during all 5 years. And they conclude, our conclusion is that follow-up study suggests that cross-linking is a safe procedure in the pediatric age, and there is no urgency in treating pediatric patients with keratoconus without proof of progression. This is another study who follow up pediatric patient for 7 years without treatment, and they need to treat only 25% of the patient. This other study of Damien Gatinel say that when we stop air rubbing, we can halt the progression of keratoconus. And when we study the natural history of progression in pediatric keratoconus, we see that there is 2 predictors of evolution: steps, cornea, allergy, and rubbing. There is a lot of paper in the literature who report cross-linking complication with someone is very bad. So in conclusion, evolution in keratoconus is not well elucidated. 2 factors are predictors of evolution: step, cornea, allergy, and rubbing. Cross-linking is more efficient if epi-off, and repeat cross-linking is not reported more in the papers. The risk of complication with cross-linking is 2 to 10%. So in my experience, I have 4 young patients confirmed keratoconus stable with 2 to 15 years old follow-up. So I think when we have a patient more than 10 years with keratoconus stage 2 or less, keratoconus is not emergency if we educate the patient. We must treat the allergy, stop rubbing, and very strict monitoring. We must see him every 3 months and wait to prove the evolution before cross-linking. Thank you.
Thank you, Hasna. I think the topic will go on to have a lot of questions. Murad, you have?
Thank you. This is a good presentation. There is always a dilemma, especially in our part of the world here. I'm talking about UAE, where we have a significant family history of keratoconus, and those young people usually lose follow-up. So I'm tending more to young people with family history is go ahead with cross-linking. I know that you're saying that, yes, we can wait. There is a chance that you don't need, you should wait to see a progression. But I think this is my comment in our part of the world. There is a family history, and I've seen many cases that we go ahead with the cross-linking. This is my only indication to go ahead with the cross-linking. This is my comment.
You know, we can see also in our region that most of children have a keratoconus due to the climate and this severe rubbing the eyes. So in a child, this is the usual rubbing, and the spring catarrh is always common in our region. So if we find the patient stage 2 with continuous allergy and rubbing the eyes, so if we wait more and more for a year or 2 years, definitely it's going to progress. So what's your cutoff? And do you go also to look for the case for the patient, or the corneal thickness, or his habits, or what? Take a decision not to cross-link the child if it's keratoconus 2. It's not an easy issue.
I propose to my patient to do the cross-linking, but this observation, I moderate my speech, because one patient said to me, I don't do the cross-linking to my children, there is not evolution. So I say there is a risk of evolution. Yes. If you can come regularly and make a topography and OCT regularly, we can wait. If you can't do this, we must do the cross-linking.
Yes. Dr. Wasim?
Actually, as Dr. Murad mentioned, in our part of the world, keratoconus is a problem, an issue. And as Dr. Ashraf mentioned, that we do have lots of vernal and atopic disorders as well. In my opinion, in this case, once we treat the patient from the allergy and stop rubbing, we can do something in between, which is epi-on, cross-linking, for example, although it's advised for children epi-off, but we can do some epi-on if we can follow up the patient on regular basis. That may reduce a little bit the incidence of haze or something like that, or after the surgery.
Yes, epi-on is a good option, but is it efficient like epi-off for children? There is not a lot of paper who speak about Another cross-linking, we know that the crossover of the stroma is 7 years. We don't know after 7 years what can happen. So it's very difficult to respond to this question.
Thank you, Hassan, so much for this very important presentation. Thank you so much. I will go to introduce Dr. Wasim Al-Atroudi. Is going to talk about a new topic. I like the topic. Minimal invasive topography guided PRK with custom crosslinking.
Thank you, Doctor.
MITCX. Very nice pronunciation.
MITEX.
MITEX.
Yeah. So thank you, Dr. Ashraf, dear colleagues. We've been doing the topo-guided PRK with collagen cross-linking simultaneously since a while, since Athens protocol right now. And as Dr. Hani mentioned, we published some papers. It has its own advantages, but at the same time, it has its own disadvantages. Like a small optical zone in the treatment, it's a tissue consumption procedure. We bombard the cornea with the stromal of the cornea with a huge amount of laser, and it doesn't take into account this dynamic layer, the beautiful layer, which is the epithelium. It causes haze, and it causes progressive flattening as well sometimes. The idea here is, can we use this beautiful epithelium to work like a shield to minimize the effect of laser in the areas that we don't want to fire it with laser? And at the same time, is this epithelial shield can help us to customize our cross-linking a little bit? So can we make our laser less invasive, and can we make our cross-linking more customized? And this is the idea behind it. It's MITEX, stands for Minimal Invasive Topography Guided PRK with custom cross-linking. And we will go for a clinical case. Definitely we do it for a progressive keratoconus that the patient has poor quantity or quality of vision with contact lens intolerance, as you can see with this young lady. Those are the different maps of her cornea, including the epithelial maps. And what I want to highlight is the sagittal curvature of the front face or surface of the cornea and the epithelial map. As we can see, this dynamic layer where the thickest part of the epithelium is covering the flattest part of the cornea, which is next to the cone tip, and the thinnest part of the epithelium is covering the steepest part of the cornea, which is the cone tip as well. I do have an access, I don't have financial interest, to the EX500 wave light, which it does the topo-guided treatment. So after validating your images, you generate the ablation profile by the machine. And here I'm looking for a large optical zone to improve the functional vision of the patient as well. The optical zone is 6.5. And I want to put the three maps together: epithelial map, the sagittal curvature, and the ablation profile. As you can see, the machine is telling me here that I want to ablate 85 microns of your cornea. Out of those 85 microns, as you can see, around 40 microns here, epithelium, and the remaining, the stroma, will receive around another 45 microns. And in the hyperopic portion of the treatment, as you can see here, the machine is gonna ablate around 65 microns. Out of those is 50 microns here from the stroma, as you can see, and so from the epithelium, and the stroma is gonna receive only 15 microns. And the most interesting thing is this area, this part here, which is already flat. I don't want to flatten it more with laser. As you can see, the machine is gonna ablate 35 microns. The machine is telling me I'm gonna ablate 35 microns, and I do have around 50 microns of epithelium here. So what will happen is that a remaining of a sheet of epithelium with a thickness of 15 microns gonna cover this area during the surgery and during the cross-linking. So the steps of the procedure, the only twist here is that you don't remove the epithelium. You just start your surgery. No trans-PRK, I mean the trans-PRK, don't do PTK. Do your topo-guided directly over the epithelium, and then you do your usual cross-linking. Those are the images. This is immediately after laser. As you can see here, you can see some parts which is ablated and other parts are not. This is the collagen cross-linking, and this is after I finish, just I clean the remaining of the epithelium. I feel this would help to give a better re-epithelialization. And as you can appreciate here, that there is part which is Bowman is still intact, that means no laser has been fired there, and the myopic and hyperopic treatment, which is matching to the ablation profile by the machine. This is 1 month post-op. You can see there is a decent demarcation line, sometimes with different types of depth, as you can see here. And here, the slit lamp photo after 1 month, this friendly haze because of the cross-linking and the center of the cornea is clear. The most important is how regular is the cornea has been after the surgery, and this is the difference map between before and after surgery. What we can see here is the following, that the flat area has steepening around 3.5 diopters, and the steep area has flattened around 7.1 diopters, with a consumption of tissue 27 microns in the thinnest area and 6 microns in the pupil center. So what we have achieved is a regularization of the cornea around 10 diopters, optical zoom 6.5 millimeter with a price of 27 microns only. I think that's great. And this is just another case here to highlight. Definitely the cornea speaks for itself, how regular has been before and after the astigmatism. But what I want to highlight here is that, is it logic that the cornea has got thicker after doing a laser ablative procedure in the pupil center? The answer here is the epithelium remodeling. As you can see, how the epithelium has got thickened. It was thin here before, 4 months after it has got thickened in this area in a place where it did not receive the stroma, any kind of laser. So those 10 extra microns appearing as if the cornea has got thicker there. So in conclusion, it's, in my opinion, it's a holistic approach that takes into consideration the epithelium, and it's a tissue-saving procedure, and it customizes a little bit the cross-linking, because there will be an area that will receive a higher dose of cross-linking, and those areas, we want them to be flattened more than the other areas. And thank you for your attention. I make it as short as possible. I thought it's 6 minutes.
Thank you so much, Dr. Wasim. This is on the machine EX500, you do this?
Exactly.
This is a different software?
Sorry? No, it's the topo-guided software that you can find it in any machine that it does. You don't need an aberrometer here. All what you need, a good epithelial map, do your routine topo-guided PRK on the machine. The only twist, do not remove the epithelium. Calculation-wise, you take the axis, which is generated by the machine, and you play with the sphere and the cylinder till you reach a combination of depth in the stroma, because you know your epithelium, right? No matter what the machine will give you, I will ablate 100 micron. If you have a 50 micron of epithelium, you will end up ablating only 50 in the stroma, okay? So you play with the sphere and the cylinder components in a way you can match around, you want to ablate around 45 microns, which is almost 3 diopters of regularization in the myopic part, and something a little bit less or similar, in a way that you keep a little bit of sheet of the epithelium in between to work as a mask for the cross-linking, as a mask for the laser. It doesn't reach the stroma and those flat areas that you don't want to flatten them more.
After 3 months, did you measure the high-order abrasion? Because you removed some of the epithelium, you left some, so the epithelium were going to be remodeling again. If there is any change of the high order?
There is no way, there is no time. I thought it's 6 minutes only to show you the higher order aberration of the topography that it has got better. But what I mean, yes, but what I mean here that the epithelium is dynamic layer. It's gonna remodel according to what's the stroma beneath it.
Yes.
My concern it was if I'm gonna ablate something which is close to the visual axis, and I'm gonna ablate half in the stroma and I'll keep Bowman's layer there.
Yes,
is this gonna affect the quality of the patient's vision? So far, we haven't noticed this.
Okay, and do you go for the steep area on the pentacam or in the epithelium mapping? Because usually when you do the epithelium mapping, you find that the site of the cone and the size of the cone on the epithelium mapping is different than the pentacam.
Actually, our pentacam does not, it doesn't have the feature of measuring the epithelium, but the OCT it does. So what I do, I match the two images. If it's located similar to the cone, which is usually the case if you're having a good images, then I go ahead for the treatment. Definitely, where the cone is located is important as well. Let's talk about central cone with progressive and poor vision contact lens intolerance. In this case, I do the epithelial map, but not to do a topography guide because already the cone in the center, this is where I want to put it, and then do cross-linking, then lock it. So I do a refractive neutral PTK of 50 microns, for example, that will shave a little bit of the cone tip and do your cross-linking afterwards.
Thank you so much. Any questions? Yeah, Dr. Hika?
Congratulations, Dr. Wasim. Very smart idea.
Yes.
I started the same thing with Schwind laser that I call it wavefront cross-linking using epithelium mask. As you, the result is very good, but the main concern here is that the photoablation is not the same in the epithelium than in the stroma. So we must make some rectification, and you must work with Allegretto to have a new nomogram or something
idea
algorithm.
Here, yes, I agree 100%, but the idea here is by the end of the day, we want to regularize the cornea. It's not that a refractive accurate procedure, but we need to get this. But yes, I agree with you, maybe that changes. It will give you more ability to ablate more cornea, for example, if the ratio of ablation is different between the epithelium and the cornea. 100% agree. But here, with Schwind, I think the machine is much more sophisticated, and it requires more, let's say, skills in how choosing your higher order aberrations and what to do. I attended one session. I couldn't understand it actually, how it works. But this is, in my opinion, it's simple. Any topo guide, any machine that has a topo guided platform, you can do it with that.
Very smart idea.
Thank you.
Congratulations.
Thank you so much.
Thank you, Dr. Wasim. Really a very nice presentation.
Thank you.
Thank you so much.
Dr.
Yeah,
Marwan.
Dr. Marwan.
Sorry. Dr. Wasim, congratulations. Excellent idea. I like it. And I used thinking in the past why we don't use a mask on the cornea to do it. You don't have to with your technique. I'm encouraged now to use your technique on my patient.
Oh yeah, why not?
So
yeah.
the combination will be
Yes.
improving the vision. Yeah,
Exactly.
great.
Exactly.
Thank you,
you.
Dr. Wasim.
Thank you so much.
Thank you. So we are coming to the last presentation. One of the challenging topics, how to optimize IOL calculation in keratoconus. It's one of the challenges. Dr. Mahfoudi from Algeria, one of the experts in keratoconus in Algeria. Please, Dr. Mahfoudi.
Thank you, dear friend. Thank you, Dr. Mohamed Al-Amiri, for the invitation. It's very difficult to come and speak after 10 hours of keratoconus. So, cataract surgery in keratoconus eyes can improve patient refraction. Proper patient selection and IOL calculation methods are necessary to get the best results. The main problem in keratoconus patients is unreliable biometric measurement. IOL calculation in these eyes is a more challenging process. What's the problem? What's the source of inaccuracy? The keratoconus presents multiple challenges in your selection. The use of standard keratometry index or in keratoconus patients can lead to an overestimation of corneal power and an underestimation of IOL power, thus leading to a peropic shift. The use of corneal power for prediction of effective lens position by Vergen's formula in keratoconus patients may lead to an erroneous outcome, as a steep keratoconus cornea may fool the IOL formula to assume a deeper anterior chamber depth and ALP, and therefore a stronger IOL power. Thus, many of assumptions that are made in normal IOL power calculation are not valid for such patients. How can I overcome this problem? We can use manual keratometry. In addition to the data absence concerning to the posterior cornea, the Pergini image will be distorted in ectatic eyes, making the calculation less reliable. Automated keratometry, due to the great variability in diopters within different areas in this cornea, measuring only on small area is not enough to have accurate result. So, what we can do? We can use new devices like YOLMaster 7000 based on swept source OCT, as well as all Scheimpflug based devices would help us have the posterior cornea values and thus the net corneal power. The pentacam, in the Scheimpflug-based device like the pentacam, we can calculate the true net power, we can calculate the equivalent Chi reading, the holiday report gives us great help to determine the keratometry which we use in our calculation. However, a very high standard deviation of Chi reading keratoconus patient may call for repeat measurements. Take the lowest Chi reading values from multiple measurements to avoid selecting a lower IOL power and thus avoiding a per-opaque shift. Biometry, ultrasound biometry has provided to be inaccurate in keratoconus patient. Optical biometry is preferred for axial length measurements due to the acquisition of it in the visual axis. What we can use about formula. Which your formulas is the most accurate for patient with keratoconus has been a subject of great controversy. A recent recommendation suggests adapting the choice of formula on the stage of the disease. This stage is proposed by Khan to choose the formula according to this stage. In the middle stage, we can use the Acerca 2, paradoxically is very accurate. Acerca T, Barrett Universal 2. In the moderate stage, we can use Barrett Universal 2, and the severe stage, Hygie's formula. We can also use Khan formula, which is available online with nomogram adjustment about the stage and target a myopic shift. We can also use new technology. Newer devices are being released to improve corneal power measurements and improve eye calculation, like Pentacam EXL and OptoView Cornea Advanced. One of the growing IOL power calculation methods is Oculus software, which perform based on ray tracing optics. Oculus software calculates the path of the focal point of the entire beams passing through the pupils at each optical level in terms of Snell's law. Artificial intelligence is machine learning is a form of artificial intelligence that focuses on creating systems that learn or improve their performance based on the data they process. Aura system is one of the most new technology, captures and catalogs the data in its analyzer's database to optimize cataract procedure in real time operatively. To conclude, there are multiple sources of biometric error in keratoconus patients. Hence, your calculation methods may not be inefficient as expected in these eyes. Various methods of IOL power calculation optimization and recommendation may hold the key to improve surgical outcomes in keratoconus eyes. In general, compared to a per-opaque outcome, a myopic target is better tolerated by patients with keratoconus. A myopic target also promotes either contact lens fitting. Thank you for your attention.
Thank you, Dr. Mahfoudi, so much. And very nice presentation. Do you have questions? What about astigmatism in keratoconus? When we do go for treatment of astigmatism, and when we don't go for treatment of astigmatism? We are going to go for toric or not?
Toric IOL is a good alternative for this patient, but to determine the axis of astigmatism is very, very difficult. Which astigmatism we are going to choose, it's very difficult. Personally, I don't choose IOL toric for this patient because it's very difficult to determine the axis, and we have a big problem after the surgery.
And do we go for spherical or non-spherical monofocal IOLs for these patients?
For these patients, spherical IOL.
And if it's a stage advanced keratoconus, say stage 3 or 4, do we go for like the IC8 with a pinhole IOL that it can decrease the degree of astigmatism and it can decrease the degree of high order aberration post-cataract surgery? The IC8, the IOL with the pinhole pupil.
Yes?
Yes, because you know that the problem in the keratoconus, the advanced keratoconus,
regular cornea and the massive high order aberration. So if we decrease the size of pupil, so we are decreasing the amount of astigmatism and we are decreasing the amount of high order aberration. Do we go for this or we don't?
I haven't any experience about this.
Okay. Dr. Bakali.
I think in this topic, where it's very important to take in account where is the cone. If the cone is in the center, we have a protocol different when the cone is inferiorly. Because when the cone is outside of the pupil, the central keratometry, it looks like normal. So it's not a big issue to focus on the keratometry. So the cone localization, I think we should take in account. First, I agree with you. In the keratoconus, the spherical aberration of the cornea is highly negative. So should be neutral or positive. There is one kind of IOL with positive spherical aberration. I don't mention the name. But we should take about, even its monofocal IOL, we should take in account asphericity. Not to aggravate asphericity negative by negative.
From your opinion, or from your experience, Dr. Bakali, when we are going to measure the amount of astigmatism, what is the size we are going? 2 millimeter, 3 millimeter? Because more than this, it will be a mess. We are not going to measure anything.
In my experience, never toric IOL, never. It's unpredictable. The keratometry is not accurate, and we will put toric IOL. We have some result which is horrible. Never toric IOL, monofocal IOL. We try to target to neutralize the asphericity of the cornea. And I take into account the axial length. And we should be aware of what false myopia. The keratoconus, it's many kinds of false myopia, and so the longer axial length we should take into account. And to target myopia, -1, -2, and forget the astigmatism. And the same cases, the question is, the big issue, to regularize the cornea first and cataract later, or to do cataract and regularize the cornea? This is the question. And for answer for the question, we have to answer for the first question, where is the cone?
Thank you, Dr. Mahfouz, so much, and thanks for all the presentation. This is a very strong session, and thank you so much, and for all the panelists. And I'm just going to announce that the hard copy for the certificate of this meeting with the credited hours will be, when you go out, please pick your hard copy of the certificate when you leave, before you leave today. Thank you so much. We are going to move for the next session, I think so.
Can you hear me?
Yes, I can hear you. Yeah, just we need only 5 minutes and we will start.
Okay, lovely. Thank you.
Thank you, Doctor. Thank you.
Hello, everybody. Thanks for your presence. We're going to start the low vision session with Dr. Galton. So, hello, Dr. Galton. Hello.
Good afternoon.
Good afternoon.
Okay, I'll share my presentation. Can you see it? So we're going to talk about nystagmus, abnormal head posture, and low vision. I will start my presentation by showing a lady in order to improve her visual acuity and block the nystagmus. She needs to rotate the head to the left very deeply, and this may be uncomfortable for daily activities. So, reviewing some basic concepts in nystagmus, which is a rhythmic, involuntary oscillation of both eyes, horizontal, vertical, rotational. There is this reference about classification, which is quite good. And we know that different types of nystagmus, they have in common. Most of them low visual acuity, some of them oscilloscope, and abnormal head position to block or to decrease the oscillation. We have variable terminology, torticollis, abnormal head posture, compensatory head position, anomalous head posture. We know they compensate or decrease nystagmus by using the blocking zone. But does a head position may improve visual quality by blocking the nystagmus? We know, as I said, they can be horizontal, vertical, torsional, and they can be combined, horizontal and vertical and torsional. So the head position will show us exactly how many components this nystagmus has. It can be fixed or variable. Sometimes can be very uncomfortable, as the video I show you previously. And they require a detailed semiology in order to treat it. Differently from what we think, people with low vision do not need to stay their lives coping with the nystagmus. We can do something for them. We have to think about what to do to them. Her in 2010 reviewed 24 studies, most of them, unfortunately, series of cases, and where in those studies, success parameters varied a lot. They could be visual acuity lines, foveation time, strabismus, torticollis, Nulzon, and some of them use the electromyography. As those studies are a series of cases, it's difficult to point if nystagmus may improve visual acuity line, but I will show you that we can use different parameters to study this amelioration when you treat the nystagmus. In order to establish a good diagnosis, you have to take into consideration if this is a monocular or binocular visual acuity. Also, we test monocular and binocular, far and near. We know some nystagmus, they get worse when we close one eye. If there is amblyopia, we have to take into consideration. We should measurement the torticollis, not only take a look, but measurement of the torticollis. A good examination of the anterior and posterior segment examination, and sometimes we need to order extra examinations such as brain imaging and so on. One of the instruments I use to study nystagmus and abnormal head posture in those low vision patients, as well as in patients with strabismus, is a plastic goniometer. It's a very simple material that we can use to measure torticollis, abnormal head posture, horizontally, vertically, and cyclorotational. We can tilt the head as well. And we can estimate in degrees, which is very interesting. This study published in the binocular vision compared two situations when we estimate abnormal head posture and we estimate a number of rotational degrees, and when we measure this normal head posture. The authors had pointed that objective methods of measuring normal head postures, such as the goniometer, may be preferable for horizontal head postures, because when we estimate, we can make some errors. This can be important when you're planning treatment for nystagmus, especially at the surgery. Another thing is make your patient read smaller and smaller optotypes. This will increase the abnormal head position, and it will give you an idea of how much correction they will need, and what's the problem they have with the normal head posture, if they block or not the head posture. We make him read. So sorry. He's reading the chart, and the nystagmus will increase. Clinical treatment will consist of correcting ametropia, which is quite important. We need to correct ametropia. The more the patient sees well, the less nystagmus that we will have. It's important to check the ability to accommodate, because convergency and accommodation will decrease the nystagmus. Treat amblyopia. This is very important. So next, there are a lot of treatments that we don't know exactly if they are good or not, with contact lenses, prisms, red filters, some drugs, and the Botox for that. We are not going to take into consideration right now those treatments. Talking about surgery is something for selected patients, not for everyone. And in order to think about surgery, we have to clarify expectations that visual acuity lines may not improve, but there will be maybe a functional benefit for treating the normal head position and the strabismus together. So we have to measure strabismus with and without the head posture, and in all fields of gazes and compare two versions. It's important to see the patient several times because nystagmus and the head posture may vary a lot. Try to quantify. Remember that observation is different from measuring with an instrument. There are a lot of techniques in the literature, the Castabao, the Scott-Craft 40% more, tenotomies, and we lack, there's a lack of literature standards. We simply don't know. What I do sometimes is I split the components horizontal, vertical, in two different procedures. I don't combine it. So some patients I correct first the horizontal, next the vertical, because it's easier to control the results. I will show some 4 patients that we have studied with low vision, strabismus, nystagmus, and abnormal head posture. Here are the cases, 2 of them with albinism, 1 congenital cataract, Stargardt disease, very low visual acuity, 200, 2000, 200, 200. Different ametropies. All of them had horizontal abnormal head posture, different strabismus. 3 of the 4 had divergent strabismus. So we did the surgery to correct the normal head position as well as the strabismus. What I want to show you, for example, this patient, he had a 20 prism diopter, XT, nystagmus, abduction deficit, and high hypermetropia. There is only a slight head tilt to the left with measured with the goniometer. What happened? Abnormal head posture disappears after surgery. And what I want to call your attention, there was improved visual performance far and near. I'm not saying there was increased lines of vision, but increased visual performance, increased reading distance, can read with low contrast, can use better visual optical aids, and increased reading speed.
Student quarto da cadeira, lela para mim, olhando de lá, não lela para mim.
Normal head position. Another patient, and after surgery, much better than nystagmus, and we don't see a normal head posture.
Focaliza a palavra sonho.
The 2 sisters, and to finalize, I want to show you that reading speed improved in all 4 cases, and also the ability to read with glasses and optical aids. So all 4 patients reported improvement after surgery of daily activities, watching objects at distance, reading and dealing with computer. Although no specific questionnaire of quality of life has been applied. In conclusion, patients with low vision may benefit of having their nystagmus and abnormal head posture treatment. Don't leave this to be just observed, and they should warn them that they should live their lives with this condition. Before establishing a treatment, clinical or surgical, try to know your patient in depth. Study the semiology of fields of gaze. See them more than once. Reading speed and the use of optical aids electronic OADs may improve after treatment of abnormal head position. Thank you very much.
Do you have any question regarding this presentation, please? So we move to the next presentation with Mr. Ashraf Al-Abd, visual aids in low vision and contact lens for kids.
Hi everyone, thank you for having me. Thank to all the MEOM team. We will start with definition as usual. Low vision aid or ELV is such as a magnifier or telescope can support people with visual impairment with activity at work or at school and in daily life. These activities are diverse as looking through a magazine, reading a text, maneuvering through a busy street, and recognizing a specific person in a crowd. Therefore, more LVEs can promote or increase their independence. It is widely accepted belief in clinical practice that children with visual impairment can profit from the use of an ELV. But at which age we can start? Generally, these aids are prescribed when children start experiencing visual difficulties at school, which is usually around the age of 6 or 7. More often than not, learning to use an ELV at that age turns out to be too demanding for a child. This is the period when several novel academic skills, in particular reading and writing, have to be mastered as well. Children with visual impairment already have difficulties with reading. Not only does the process of learning to use of low vision aids stretch the load on them further, it is to be expected that an earlier preschool mastering of an aid will be beneficial in at least partly preventing development delays. An additional factor is that at this age, children tend to reject the use of an ELV because they are afraid of stigmatizing. Earlier acquaintance with it may perhaps also overcome this problem. So, a solution to the problems outlined before would be introduce ELV early in life when younger children may display no aversion to them and can adapt to their use before they start to learn or to learn to read. This solution has been recommended before, starting with Carvalho, Cox at 2009. We may know all the old and basics visual aids. We will see here some new technological tools for children. All the tools that we will see, they have no interest of representing them just for information. I'm not here to sell them. So, as basic tool, we all know the sample stand magnifier for near work and play can help young children zoom in a book and an object up to 10 times, or lighted vision, like this one. Of these tools are also available, or we may know also the monocular handled telescope. But unfortunately, Apple and Android, there are too many other tools provided by Apple and Android, tools for children with low vision. Children often start interacting with the smartphone or tablets at an early age. Built-in tools such as large font and high contrast are also available to help our children. The first application, here it is Sensory Magma. It's available, it's an iOS free application. This is simple, calming and relaxing visual app can help teach causes and effect. Tap, hold, or punch the screen to change the direction, color, or the size of lava flow. It's for early age children with low vision, with vision improvement. There is a second one, it's Fireworks Arcade. This application can help teach causes and effect and increase visual attention. We will just tap or drag the screen to create displays of light and sound. This is the first application here with alphabets. It's Alpha Toads Alphabets. It's a paid application. It will teach our children letter and their sounds with 3D graphic, animation, and music. The next one is Tap and See Now. It's a paid application also. It's created especially for children with cortical visual impairment. This application helps teach cause and effect through an interactive picture sound album. Kids learn to track motion and recognize different colors. We'll see now other elementary and other tools for elementary and mid-school students with low vision. Let's start with the basics. It will be Video Magnifier. It's expensive, can provide accessibility to objects and books at home and in the classroom. We might have now other telescopes or clip-on telescopes. We can fix it easily on our smartphone and tablet camera, who can provide over 10 times or higher magnification with high definition. They are made for photographer, but can be helpful tools for our children. Now using the EI. This application is called Scene EI. It's made by Microsoft team. This application can narrate the world around you. Simply point the phone or the iPad camera at whiteboard, smartboard, worksheet, and more, and seeing EI will tell you what is written out loud. It can help read currency, name, color, and even decipher handwritten circle. The next one, Look Out. It's made by Google team, provides spoken feedback about things around you. Lookout uses the camera and sensor on the device to recognize text, people, and objects. TapTapSee. It's an application where we can find both on Android or iOS. It's free. It lets us photograph objects and have them identified aloud. Bookshare. It's an application for children and adults with low vision. Bookshare collection contains nearly 850 titles, 800,000 titles, downloadable in a choice of format, including ebook, audio, braille, and large font. Membership requires verification of print visibility and includes free downloads. Final one, Math Robot. It's designed for students who are blind or visually impaired. This application provides problem, drills, and practice in a very high contrast format. It is also accessible with voiceover. And now we are seeing all the VR Chromecast and even playing or working as Meta, Facebook, Google, Samsung. We can use virtual reality to improve our vision for visual impaired. It's a new era for our children and even for the adults. Virtual reality technology has been changing how many different industries present and interrupt information, and education is no exception. While it may not be feasible to travel halfway around the world to visit a museum or landmark, it's certainly easy to find an application or video that uses virtual reality technology to explore the same places at your own place at any time of day or night, and with the use of assistive technology. There are my tips for using virtual reality technology for students with vision impairment. It don't require any special equipment other than the VR Chromecast. There are many virtual and augmented reality systems that are accessed using headset, special helmet, and other specialty equipment. However, some systems can be accessed using devices that can be found in a classroom, including iPads, iPhone, Android phone, and even computer. A growing number of VR applications are compatible with VoiceOver, TalkBack, and other popular screen reader, which can describe the environment with information from the alternative text in the image and video. And there is much more to make our life better and easier. Moving to contact lenses for children. First of all, the first question will be from the children parents. Are contact lenses safe for all children? Contact lenses, yes, are safe for all children, with research supporting that the risk of eye infection in children who are between 8 and 12 years wearing soft contact lenses appear to be lower than teenagers or maybe adults. For daily disposal, soft contact lenses are safest, with the risk of eye infection being around 1 case per 5,000 wearers per year. The first type of contact lenses that may be useful for our impaired children are the transition lenses. You may know transition in lenses for glasses. The same company made contact lenses that darken automatically in sunlight to reduce glare and enhance comfort are entering the market. Like Johnson & Johnson, light adaptive contact lenses have been approved by Food and Drug Administration. The lenses feature a photochromic filter that continuously adjusts the amount of light entering the eye. They automatically return to a regular tint in normal or dimly lit environment. We can see here, it's remarkable on both light eyes or dark eyes color or iris color. The second one, the augmented reality lenses. A smart contact lens, it's a smart contact lens with a built-in visual display. It's designed to magnify image for people with low vision. The patent lessons designed by a company called Moho Vision can project content from a smartphone. And there is another company, which is Innovega, is also working on a soft contact lenses that can provide a display anywhere in the eye's vision. The company says its eye optic system can improve the safety of hand-free tasks like driving, surgery, and military operation. The technology is still years away from being ready for customer, however. And the new one, it will be the telescopic lens, a prototype of soft contact lenses that can zoom in and zoom out with the blink of the eye, has been developed by researchers in California and China. This could someday be a game changer for people with retinal damage from conditions like macular degeneration. The teams are currently working to miniaturize the telescopic lenses so that it can fit inside the eye. Another team in Swiss has developed a telescopic contact lens prototype that can shift between magnified and normal vision. Thank you.
Thank you, Mr. Asher, for this excellent presentation. Then we will continue with the following presentation entitled Kids Protect with Miss Siwar Sesi.
Hello everybody, I'm so honored today to stand before you to present our project Kids Protect. So, did you know that according to UNICEF, 500 million children spend at least 4 hours a day with their faces glued to their screens? During this time spent on their phones or tablets, the recommended distance from the screen is not observed. The content of the videos children watch is not always controlled by parents, and the light of the screen is not adapted for the eyes. All of this leads to various visual problems that we see in our orthopedic consultation, highlighting need for a parental control solution and vision preservation. So we decided to develop Kids Protect is an application that allows parents to control and preserve the vision of their children. So our application proposes a feature for visual protection, parental control, and entertainment. So we start with the safe distance. So in case the recommended distance of 33 centimeters is exceeded, the screen will lock in all applications to make the child keep their phone at a safe distance. To regain functionality, they simply need to move their screen away. So we have also a relaxation exercise. This is our anti-fatigue breaks implemented by specialists that help to relax the eyes. The exercise will be displayed automatically every 20 minutes of screen usage. So we can check if your child has a visual problem with our various tests offered and set up by specialists. And at the end of the test, a list displaying the location of the nearest ophthalmologist office will be shown and also sent in the report to the parents. So our application offers a parental control. We have a time adjustment system. Thank you. So a time adjustment system that allows parents to limit their child's screen time from the parent's device using a parental control. So the parent receives a daily report on their child's digital activity, including the number of screens unlocked, test results, recommendation, and screen usage time. Finally, we have Kids Words, a library of content adapted according to the age and preference of the child. So this is application made by 2 orthoptists and a computer engineer with the support of our partners. So Kids Protect is ended for children aged between 8 years old and 40 years old. So we are started by Tunisia, and next step we will target the Middle East. So our business model is based in monthly subscription and annual subscription, not only for 1 device, but for 2 and 3 devices. So we create our startup in March 2021. We integrate the CRC Innovation Champion elaborated by UNICEF and Flat Six Labs. We integrate the Connecting of program. We're receiving the AIR grant and we start the development of our prototype in 2021. And in 2022, we won the MOVG Tunisia Award. So some of our achievement: training with national and international experts, demo day in front of representative of Tunisian ecosystem, immersion in the Marseille health tech ecosystem. We are testing the application and implementation of the marketing strategy in Tunisia, and app launch in March 2022. And now we integrate the Connecting Fab Accelerator program. So after 6 months of launch, we have 344 active users, 111 parents, and 233 children. So thank you for your attention, and don't hesitate to try our application.
Thank you, Siwar, for this excellent presentation.
Thank you. I think that's the end of the session of Low Vision. Are there any questions for previous communication?
Thank you very much, Ons, for this nice session.
And on behalf of MEOM, we'd like to give you our trophy. Okay. This is for Tunisian. Yeah, for the Tunisian Society of Orthoptists. One also for you. And also this for international, also Orthoptist Society. I think you are one of the members of this society.
Thank you everybody for your attention. And it's the end.
Okay, we have Dr. Haikal Kamoun. We are, yes. Yes, Dr. Haikal, yes. We are proud to have Dr. Haikal Kamoun of the most. طيب يلا باشا.
رحت جبته من على السلم عجبك كده؟
طيب ماشي.
تنده على الراجل.
هي تبع نفس لا. We need to give this one because it is the same one, I think. تبع النصر.
Yeah.
Did you finish the session?
Yes.
Because he wants me to conclude before you finish the session. Did you finish, really? I would like to thank everybody, especially the people who last to the end. This is a good opportunity to say thank you for everybody, for sharing, for caring, for being here, and we hope to see you next year. This is to conclude our day, our session, and our last session. Thank you so much for being here.